Okay, quick test on a handheld style microphone. Once again, quick test on our handheld style microphone. And another handheld microphone test. Once again, the following is just a handheld microphone test. completing the final test for our handheld microphones going out of our auxiliary outputs. Once again, this is the final test of our handheld microphones. Thank you.
I'll start right in time. So first of all, thank you for all coming to the Brigham and Women's Hospital, Harvard Medical School, to our annual Cerebrovascular and Skull-Based Symposium. This is the first one we have post-pandemic. The last one was in 2019. And I'm just going to be very brief and really thank the organizers, the minds behind this, Professor Al-Mefti. As you can see, there's one Professor Al-Mefti, and there's three of us that have to counterbalance him. And then Dr. Aziz-Sultan and Nirav Patel, and finally Linda B., who's really been the little motor engine behind all this. So thank you for coming. I hope this is going to be a great symposium. You are the masters of neurosurgery, the technical wizards, the people with the best surgical judgment. And I wish I could stay here and listen to this, but I actually have a great case to go and do, which is a frontal sinus exenteration post-op from a hole we put in the frontal sinus. So sorry about that, but I'm looking forward to hearing great things about this. Thank you. Stefan?
Well, as a chairman of Cerebrovascular Committee of the World Federation, I may say that I'm impressed about everything it happens here. And I want to thank to Professor Aziz-Sultan for this organization. I think he deserves our applauses. I'm also very happy to see that from our committee, there are many people from all around the world, from Latin America, from United States, from Asia, China, Japan, from Europe also. So thank you very much for being here and contributing to this symposium. From India, yes. Okay, I hope I didn't miss anyone. So, yes, we started this initiative of organizing our committee to organize international symposiums on cerebrovascular disease, a multidisciplinary approach. This is the second one. The last one was organized in my town. The next one will be probably in Dubai. So, we only started this initiative, and I'm very grateful that you accept to organize this meeting here in this extraordinary atmosphere. I'm really impressed. And I'm impressed about the neurosurgeons present here. Many of my masters are here. And I'm deeply grateful for your presence and for the contribution you have to this conference. I would like to mention only that usually I used to say that in neurosurgery, it's everything about CSF. That means cooperation, science, and friendship. So our mission now is simple. Just make the CSF flow. Thank you.
Thank you so much for so many wonderful, wonderful people coming from all over the world. This is not something I'm in the front stages and on podiums and so forth, but it's so beautiful to see people from all over the world coming to our organization. People that are the icons of a field that started modern-day endovascular, to our brothers from Senegal, to Malaysia, to Brazil. It's really, really humbling that you all came. I think it's a very, very, very important thing. There are some rules, and the rules are, just to go through them, each person, unless they're told, sticks to a 7-minute conversation, a 7-minute presentation. There's 2 podiums back and forth. We will signal you to go up when it's time to speak, and we'll move fast back and forth through that. Discussions, debate, everything is welcome, but we will save it for the end. So you ask why you come from all over the world, from Africa for a 7-minute talk, you know, from China for a 7-minute talk. And I think it's the intention is to get to know you, as Jorge said yesterday, is to sit together, to understand each other, to understand people's perspectives, to see whether clipping or coiling or this or that, but how do you see it? To sit and have a meal together, to gather, because in a sense, as neurosurgeons, you're alone. You know, you train alone while there's 50 medical doctors around. You're alone in a place. And just to connect us together, to look at problems from different angles, I think will solve a lot of things like that. So I really, really, really appreciate you coming. We wanted to open up our home to you, to meet us, to see us, to share ideas with us and get to know one another. So thank you for coming. And home, our next speaker, I was recruited here by Nino 10 years ago, and my office was next to this man. And you know, they talk about gratuity and grace. It's not a thing you do, it's a thing you feel. And when you witness kindness from another human being that you've always looked up to, a person that supports you, whether it's surgically or a person that motivates you to open their home and really take you under their wing, just fills you with a lot of pride. This man has been like that for me for the past 10 years, and I'm sure is like that for a number of people who have come here. So, Professor Mefti, if you wouldn't mind.
Good morning, and thank you so much for being here. Refreshing and an honor. This, what became really classic, is Dr. Sultan. He meant to make it a meeting of the mind and the heart. He wants to make it that there is 9 billion people now, 8.1 billion people around the world. So we think of them too, not get wrapped in all the great things we do. So Ali, thank you so much for putting this and for all what you do. And then, if it run well, became so exciting, it's Dr. B. I don't think she's a bee, she's a hummingbird, never rest for a moment. So thank you, Linda, for putting this beautiful program. Disclosure, you have to put some things. I have no conflict of interest of any kind. And it bothered me seeing some people putting disclosure, almost a whole page was just about every company on earth and kind of showing it. I do have interest in every patient anywhere. So I told Ali I shouldn't really talk. He said, no, you should say what you think. I said, I should really not talk. He said, these are good people with open mind and open heart. They will not hold it against you, and they will not be offended. So here we go. Thank you for all the leader into this, and thank you, Gail, for global neurosurgery became an interest and effort from a lot of neurosurgeons. Just look at this. If you Google global neurosurgery, you got a 961 million entry, that neurosurgery. So there is a very commendable effort into this regard. A major center has initiative and project. And I'm wondering if they all could beat the benefit with somebody like Ali doing what he does to the poor country or to his homeland. This is a list of the expenditures of each country on healthcare in the world. And if you want to summarize this list, you will find right away there is North America, Europe, Japan, and Australia in red. They spend a bundle. And then there is all the rest of the world, 7 billion people of this world living in this yellow area. The advanced area has advanced neurosurgery. You are setting the standard, you are setting the practice, you are developing the treatment, you are the trailblazer. So the rest of the world supposed to come, or we go to follow. So this rich country, and doesn't matter where you are right now, here's the current day practice. This is small, tiny petrous meningioma, frequently around the world, will be treated like this one with the gamma knife in Frankfurt. You expect that the tumor is going to reoccur and grow. So now in the cavernous sinus a little bit, so he gets a partial decompression because it's not safe to work in the cavernous sinus. And the residual get now come to Stanford to get CyberKnife. As you expect, their return recurred, and that's all my patient right now. And what to do, then he come to Boston and have a proton beam. It will grow again in a year and a half, and what you do, now we have minimally invasive endonasal in Pittsburgh that could decompress this. You know that eventually he's gonna die from that tumor as progressed. A few years ago, Dr. Porter here from Harvard with Dr. Kim, who became the World Bank president, they come up with the idea of value care. And I could, it's a beautiful study and beautiful things, but if I could summarize it, it says that the outcome achieved per dollar spent. So if I take this patient and apply their equation, the patient never had disease-free, but lived 5 years with the disease. It's probably about $4 million, the total cost between going from one center to one center and things. So if you divide 0 on a 4 million, the value of the care is zilch. You don't get offended. You hear what I'm saying? The value of what we're doing today is zilch. We have burnt expenditure with very little return. Why? Because a somehow idea surfaced about 15 years ago that in benign tumor, we seek tumor control. That's good for cancer, but became the rule in treating tumor control. Why? How we should do it? By minimally invasive. We want to bring all the talent, so it has to be hybrid treatment. I don't know how to even pronounce the word. And why? To preserve the quality of life. Now, many patients like the one I present to you, they had a miserable life before they lost it. The only minimally invasive on this and the breakthrough and what have you, it's minimally invasive to the surgeon time. That doesn't get offended, but that's the facts. So the answer in benign tumor, you take them all out, and meningioma, you get Simpson grade 1, and the patient will be perfect for the rest of their life. The quest here is cure, and the cure is like diamond, everlasting. The fallacy is a tumor control. The verity is cure. And that's what should be our goal and mission. Why? This is per capita expenditures in every country. You could see in the United States, I don't know, $17,000 a year or more. There is maybe about 10, 15 countries that spend more than $2,000 a year. The rest of the world, the 7 billion people, they spend less than $300 and $400 a year, and many of them $20 and $16 and $15 a year. Here an example. This surgeon, all what he has is one bipolar, a drill from the hardware store, and this is small basic instruments. This surgeon every day taking a tumor like this one, totally remove them so they will not have to recur and need the treatment again, and have that child live happy thereafter, without even needing DDAVP because you cannot monitor electrolyte where they live. What he needs? A microscope. That's all what he needs. You know, if Prometheus brought the fire to humanity, I think this man brought microsurgery to humanity. Microsurgery is really, really made a big difference, not just in the patient life, in the whole humanity, and should be forever. But microsurgery need to learn it. This doctor I showed you came to the courses and learned it, mastered it, and then he became a teacher to teach it. And Dr. B was a student on that day, and now she is the teacher. This is the link. You learn it, you teach it. But microsurgery need cadaver lab. And there is very few cadaver lab left right now active. They're vanishing. And what more important, the vanishing, the interested people to come to them and learn. Dr. Krisht offered the residents totally free the lab, the travel, the food, and couldn't get residents to go there. Everybody going about virtual reality. It's not real. It does not teach you how to get perforators of the basilar tip, no matter how refined it got. You need real anatomy and need a practice on a real anatomy. I was very lucky. This is a great man, Dr. John Fox, 40-something odd years, left his professorship at George Washington. Gail, you might know the place, and went to Zurich to learn microsurgery. He spent 2 years of his life. He came back. I was very lucky. I was first-year resident when he came back and taught me everything I know. And what a lucky day I got. That's it. In my 4 years of residency, I learned what it takes 20 years under today regulation and attitude. Coming out after 4 years of residency, I was in a private practice in community hospital, clipping basilar tube aneurysm with confidence and good results. Training. Learn and teach need dedication. You all gotta admit that the experience today is less than it used to be. So what is this neurosurgery? It's a simple thing. It's a very fine hand dissection. Under binocular vision, you need 2 eyes because it's a visual feedback. You don't touch the things, you see them and move them. And it has to be done through CSF pathways so you do not bother the brain. So that means you need 2 eyes, 2 hands, 2 cerebral hemispheres. You got to think. It takes big heart, it takes big bladder, it takes a lot of time, but need a small ego or humble person and a small pocket too. But above all, it needs passion. This cannot be a war, cannot be a job, cannot be a duty. This has to be the life. You need, if you really want to be microneurosurgeon.
I'm going to send you up against the best. Yes, sir. You 2 characters are going to Top Gun. I feel the need for speed. In 5 weeks, you're going to fly against the best fighter
We're
pilots
going
in
to
the
train
world.
you to be the best in the world. You got to be a Top Gun. And you need the speed. You need the passion. A $4.1 trillion, the expenditure in the United States in year 22. So it's a big industry. It's the biggest industry there is right now. All the big industry work on Taylor rule, scientific management, 100 years old. The bottom of it, disdain to particular worker or special skill. They don't want you. They don't want a Top Gun. You need not to be there. It's gonna be an assembly line. This guy put the wire, this guy make the hole for the tire. It's just a technician. And look at this, that's what's happening. This guy knows only how to pass the electrode under the covariant. This guy screw the halo for the radiation therapist to make the plan. And this guy needs somebody to hold the endoscope so he could work on one nostril and cannot live without somebody in the other nostril. Technician. And just imagine that this guy, after going to Harvard, and then trained in Stanford, and then got 2 fellowships in Yale. That's that hypothetical, okay? In GI, spent all of his day doing colonoscopy. And that's fine, with the exception that this is a New England Journal of Medicine 2 months ago. They don't need a colonoscopy. It doesn't work. There is no use for it. And more, that technician whom we're becoming is it's an hourly worker, not hourly worker, it's a minute worker. This is the report of every doctor right now. I spend 60 minutes, I spend 25 minutes, I spend 70 minutes. Well, even plumber get paid by the job and not by the minutes. Okay, I got you. I'll finish. So we're not just became a technician, we became salesmen. And not just became salesmen, our institution sells us. Go to every web page of every big place. They're selling you. And with the sale, like this is for the endoscopic, it became standard. And we're putting the fear in the patient's mind, fear-mongering. Don't have anything but endonasal. And fear in the doctor. You're violating the standard, illegal fees, illegal concern. And with this, what's the standard of treating this? What's the pathways? Whatever it is, guideline, paradigm. In every place, he was going to be there on a protocol somehow. Well, guess what? This was a live worm just pulled out of this Australian patient by Dr. Bandy. So whatever paradigm he was forced on, it doesn't work. In neurosurgery, the management has to be individual. There is no pathway, there is no guideline. With all my respect, Dr. Marcus, whatever ANS put guideline, it's got to be individual care. Best practices. And let me close here. The red light is shining. She put the global healer. What a healer for me is this guy. This is Dr. Religa. He is a cardiac surgeon doing the first transplant in Poland. 23 hours operation. This is the end of the operation. Everybody is gone. Look at him. His eyes on the monitor with every heartbeat of this patient. That's what it takes for the patient to outlive his doctor. Here, I'll close, I swear. But General Patton, okay, they relieved him from his command after the Sicily things because he went to the hospital. He saw a patient. He told him, son, what's your injury? And the guy said, I don't have injury, sir. So he slapped him. So, well, what you're doing in the hospital, you don't have injury. A little General Patton know that there is some patient, some soldier, 2 out of the 1,000 he had, complaining of battle fatigue. What is that today? Burnout. And look at this. Dermatologists, 50% of them burned out. A neurosurgeon is coming to us, there is a third of us to say that burn out. We're looking for a balanced life. I'm very happy I lived fulfilling life. I'm not burned out, I'm burning to do more. That's what I told Dr. Sen. We must rekindle the passion. And she said, she finished, you read Frost, my goal in life is to unite my avocation and my vocation as my two eyes make one inside. Thank you.
Thank you for continually recentering us and recentering the field into understanding what's the most important. I've seen Professor minute by minute with his patients in the ICU, so that picture is how he lives. We'll start our first session, and the entire theme of this was derived by my brother Nirav. And that's neurosurgery in contacts. You know, whether you clip or you coil or you're in an area that has resource constraints, or you become like the modern neurosurgeon that all the aneurysms are coiled and you don't have enough experience. What does it mean in your hands? What does it mean in your shoes? And how can we put minds together and come up with different solutions? So in the tradition of my mentor, I'll talk about this case that he actually had to come and comfort me with. This is a case early on in my career, and I had seen the endovascular gods. I had gone to Paris and I had learned techniques. It's a young woman with 3 children, 35-year-old, 3 young children. The husband couldn't come to the hospital. They didn't have means. She came in with sudden severe headaches and sort of a sentinel event, if you will. No blood. And had these bilateral ophthalmic aneurysms. This is before stents, before anything. And I had come back from Spetzler, I had seen Moray, I had been trained by Waklu, so bang him out. You know, take balloon, one goes to the one side, we do both of them, I don't know which one ruptured. And balloon coiled it. Balloon coiled both sides, very proud of myself, a tiger, 800-pound gorilla. And somehow, as we were closing, boom, you know, the coil flew out. This is before stents. And I spent time pulling. I had the option of clipping. I had the option of doing both. This is the first thrombectomy devices. Couldn't get it out. Tried and tried and tried and tried and just wouldn't come. Stopped after half an hour, worried about perfusion. Took her to the scanner. Hemorrhage there. Quickly took her to the OR, tried to fish things out, and the brain just swelled in front of me and just couldn't get to things. 3 kids. Husband never came to the hospital because he had to work. So it was a devastating case. How would you look at this? Should I have done anything? Are sentinel headaches important? How would you have clipped it? How would you have coiled it? What would you have done in your own institution? So Nima will come up and speak about some of his work and how to think of these aneurysms. Thank you.
Is it working? Thank you, Ali, for the kind invitation to this very, very wonderful symposium. I will cut it short. Obviously, I'm a neurosurgeon with all my heart, and I dedicated all my career to train surgically the management of aneurysms and cerebrovascular disease, and also go into the academics of it. and unravel the pathogenesis, not because I don't like surgery, but I think as neurosurgeons and maybe neurointerventionalists, we should manage aneurysm patients. We should dictate which ones should be treated by surgery, by endovascular means, or conservatively. We shouldn't let others dictate based on Ishua or whatever how we should manage patients based on 2 factors. So that was my background, and I will start off with these 2 aneurysms, and I will cut it short. That aneurysm you showed has a similar risk of rupture, one of them, compared to these 2, according to the best evidence. I will tell you why one of these aneurysms shouldn't be treated and why one of them should be treated and how. The risk of rupture is, according to phases, which is the best meta-analysis, less than 1% over 5 years for both of these aneurysms. I don't believe that, but still, that's the evidence. And the risk of treatment, according to the latest study, the only randomized controlled study for management of unruptured intracranial aneurysms, which is CURES, is 4%, roughly, okay? Obviously, some of us will do this better, but the majority may end up having these numbers. And I will walk you through our translational research over the past decade to unravel the pathogenesis of aneurysms and maybe come up with new treatment options when we don't have to treat. We used, and you know this, aneurysms consist of collagen 1 as opposed to the parent vessel. We used collagen 1 that we excised during aneurysm surgery to birth date aneurysms based on radiocarbon birth dating. And for time reasons, I cannot go into the method, but you simply have to know that all of us have this signature in our DNA and proteins based on nuclear testings between 1955 and 1963, and then because above ground nuclear testing was prohibited, thankfully, these isotopes dropped in the atmosphere, and we birth dated the proteins in aneurysms in these patients, vertical lines. Those are the birth dates and their aneurysms. And you can see that aneurysms are not a congenital disease. It's an acquired disease, and it's very complex, sorry for that. But the gist of it is what drives aneurysm formation is the presence of risk factors such as hypertension and smoking. And this is a good biomarker to assess aneurysm patients on a molecular level. Then there's evidence, and we did a large population-based meta-analysis of incidence of subarachnoid hemorrhage in population-based study, high-quality studies, and we found that the incidence is dropping worldwide and is now 6 per 100,000 per year, and most of you would agree to that. And it's in parallel to blood pressure treatment and smoking reduction. If we decrease the blood pressure systolically by 10 millimeter mercury in an underlying population, the risk of SAH goes down by 70%. There's good data based on David Hassan's work that aneurysms do not rupture or rupture rarely in patients who take aspirin, and he proved that in a phase 1 study. And why is that? Because ASA, aspirin, reduces aneurysm wall inflammation. And this has also been confirmed in large population-based studies. So to get back to those 2 patients with those 2 aneurysms, both 4 millimeter MCA aneurysms, that's the risk of rupture according to the evidence. This patient is 50, has many risks for another subarachnoid hemorrhage. He had one from a different aneurysm. The aneurysm is irregular in shape, and all of this contributed after Ishua to assess these patients differently. This patient, however, is a cancer patient, 71-year-old, 4 millimeter aneurysm, well-treated hypertension, and has a life expectancy of about 5 years. So I'm not saying that this is better than phases, but obviously we developed a model to harmonize treatment a little bit, and it suggested that this aneurysm patient should be treated and this one should be observed. And I think most of you in this room would agree. So I showed you that not all aneurysms require preventive aneurysm repair. The one that required preventive aneurysm repair, we operated on by surgery. And I showed you what the risk factors for aneurysm rupture are. I showed you that aspirin is a good a good drug. And that was for us the impetus to develop a pharmaceutical trial, which we initiated, so not the companies. And it's running, it's Protect You. And it uses aspirin treatment and intensive blood pressure reduction as a therapeutic target in aneurysms that do not require preventive repair versus standard of care. And the Protect You study is still ongoing. The patient with the cancer we included in this study, and she's still doing well regarding her aneurysm in the intensive treatment arm, and also regarding her cancer. We have 322 patients in the trial. The trial is running in Germany, Netherlands, Canada, and Finland, and I'm hopeful that we ever get it finished. So that's it from my end. Obviously, some of this is controversial, and some of this has also been published in the European Stroke Organization guidelines on management of unruptured aneurysms. Thank you.
Wonderful work. Ricardo will be talking about the endovascular treatments.
Thank you, brother. It's an honor to be here with Ali and the whole team. For a little Brazilian coming from a city of 8,000 people to be giving a talk here, it is a big deal. We put a lot of work and passion behind this, and I had a chance of overlapping with Ali in Phoenix, and that's the reason I'm here. This is our town, this is our team. Those are my disclosures. I'm sorry, Professor Almefti. We work with everybody under the moon. And I got scarred or inspired by these two honorary Brazilian guys to put all my being in taking care of patients with cerebrovascular disease. A little bit to what Ali asked us to focus on. The clock is not running. I'm happy about that. I just gained 30 seconds. Please measure, I talk a lot. This gives you, Louis Kim is giving the best talk, and when you can use both, I think that's the way this should be done, and that's what we do in our practice. But Ali asked me to focus on why do I choose endovascular. I think when we work in a busy environment, simplicity is very important. We have the natural highways to get there. We don't need to work in crafting and access to that. Can get through the wrist or to the groin, getting there. We work really hard and put data behind in what we do. And we know this has been demonstrated multiple times. The morbidity of treatment favors endovascular. And I love the idea that we're going after what we are not doing good today. How can we do this better tomorrow? If you like it or not, I think this is a reversible trend. This is a paper from Boston based on the national sample. You see that for unruptured aneurysm, the cutting point was 2004. And if you look at Mike Lawton data, he showed his own data that clipping is decreasing, and this became even more after ISAT and Brett. We know surgical morbidity favors endovascular. Efficacy used to be a lot towards surgical treatment, but we know endovascular got better, better, and better. So if you go from older technology like coiling, this is a mother of three, PhD, with a superior hypophyseal aneurysm ruptured. She's awake on the table, and we coiled this aneurysm with a wire, ready to honor Jacques Moret for balloon-assisted coiling. She didn't need the balloon. We just coiled the aneurysm without needing to use the balloon, and thankfully she got cured from that. When you have vasospasm, we know this is not a great surgical candidate. Because of that, we go and treat both endovascular and vasospasm and coil the aneurysm. For wide neck aneurysm, we know the recurrence was a weak link. So these new gadgets came, and the web is not perfect, but it sure helps a lot. This is a 64-year-old guy that we enroll on the WEB trial, again, putting data behind it. All the data behind the WEB shows the very low morbidity of this procedure. So you see here the placement of the WEB device and the 5-year follow-up, just like if you put a straight clip across the neck of the aneurysm. Go beyond that, 68-year-old guy, high-function executive with this partially calcified large aneurysm, not a great surgical candidate. We treat him with a stent coiling, and this is his follow-up image. This is his 3-year follow-up image. This revolution came, called the flow diverter. This is a young female, my very first patient treated in 2010 at Mayo Clinic in Rochester with Giuseppe and David Calms, 39-year-old with this large aneurysm. This changed the paradigm. We all remember the algorithms that we had in our textbooks, BTO, fail BTO, pass, don't pass. This is her post-op result. I saw her for follow-up. 14 years later, you see the mass effect on the cavernous sinus completely gone, and she's doing very well with not a new problem over there. Beyond that, we know recurrence was the weakest link for endovascular, and this lady went through a battle with a bunch of treatments till this technology came, and this is a flow diverter. This is a 12-year follow-up because of misleading MRA, calling an occlusion of the vessel. And to finalize, in diseases that we cannot reach well with surgical treatment, the beauty of the highway, this guy was treated for a ruptured ACOM, had this mid-basilar, proximal basilar aneurysm, and we follow him, and here you see growth of this aneurysm. And when the aneurysm grew, we treat him via radial approach with pipeline-assisted coiling, and here you see a 12-month follow-up resolution of that. We know with endovascular treatment, there's an avalanche of new technologies that allow us to see things better, like how, I don't have time to tell you about every single one of them, but we're pushing science and improving results in so many fronts, like high-frequency OCT, new technology of flow diverters, surface modification to get this device to mimic the red blood cell or to stimulate endothelial growth, the development of intrasaccular devices, the development of photobiomodulation that were maybe, just like we treat skin lesions with laser, maybe we'll be able to enhance pluripotential cells to develop again on the blood vessel and induce healing of these aneurysms, going towards what Nima showed to us. There's no question in my mind that endovascular plays a major role. I showed you the data from the United States where endovascular, majority of the aneurysms are treated by endovascular. The results will continue to get better, technology will continue to evolve. I'm looking forward to hear next talks and to discuss this. On your case, Ali, tough call. I think today probably would treat both endovascular, not with coils alone. She had no blood on a CAT scan, but I'm looking forward to discuss that tough one. Thank you, guys.
Thank you, Ricardo. Wonderful talk. Next is Dr. Morcos, my mentor and teacher and bigger brother, to talk about the microsurgical options.
Thank you. Last time we were here, 2019, pre-COVID. It's a wonderful course, and thank you, Ali, and everybody for putting it together. Ali asked me to be a little provocative, so I'm going to oblige and get the debate going for later today. By the way, I'm going to leave Miami after 28 years to go to Houston in December. So I'm very excited about that and hope many of you will visit. I'd like to thank my brilliant resident, Eva Wu, really phenomenal. I want you to remember her name. She's absolutely phenomenal. She's going to be somebody. And I'd like to thank my fellow, who is already somebody, Spiros Karadimasir, for helping me. I have no disclosures. Why do I treat aneurysms with microneurosurgery? Because I'm damn good at it. Because I don't know what it feels like, nor do I care to perforate a carotid or basilar with an ultra-latest, super soft, extra safe, frictionless, lubricated, luxury handling, here today, gone tomorrow, 720 degree, rotatable, just magical microcatheter du jour from 3 feet away. Call me old-fashioned, but I have a soft spot in my heart for the concepts of cure, endothelium to endothelium, subspecialization, clip it, don't stuff it. I believe in maximizing the following equation for each aneurysm: durability times effectiveness times feasibility times affordability times safety. I do think microsurgery has an edge with the first 4. There is no question that in several papers, indeed, as Ricardo said, safety may be better with endovascular in good hands. So I could stop here. Do I need to say more? No. Do I want to say more? You bet. These 2 cases just last 2 weeks. 81-year-old, coiled elsewhere, ruptured, recoiled, recanalized, excellent health. Her parents lived into their 90s. So somebody needs to be trained to deal with this if a very good endovascular person wasn't been able to deal with this. So we just took her to the OR a couple of weeks ago, and and we did this end-to-end anastomosis. You can have an idea what it looks like. It's an ICA-PICA variant. I tried to clip it, couldn't clip it, very atherosclerotic base, and did the end-to-end anastomosis. And that's ICG. Another one, 70-year-old, ruptured fetal PCOM, had a flow diverter twice and a web device. Of course, the good endovascular people in the room would have predicted this failure because of the fetal PCOM, kept recanalizing. We just did an LSO, and my fellow sitting here did the whole case pretty much. And this is actually my partner's case, my endovascular duly trained partner's case, not my case. And I have not actually clipped myself a webbed aneurysm before, so I was interested in seeing how this case went. It went apparently very well, and here is a video. Here is a fetal PCOM. Here is the web. You can see the web there. And Spiros placed this clip beautifully and reinforced it with another clip right there, 2 kissing clips. That's a post-op CTA. Did very well. Clearly, I have no time to really show the data. There is most of the data, you cannot see it, sorry. Most of the data show you better durability with microneedle surgery. No question, there is an issue of upfront safety, and patients certainly, in general, do better in the short term, but long term, many of those papers that perhaps we can show another time show equivalent results in good hands. Thank you for the reminder. I don't know what happened. Do I need to do something? Yep. I lost the connection.
Yeah, can you put it back on his?
I just have a few more slides and I'll finish. Oh, okay, thank you. There's a lovely paper last weekend by actually Dr. Butarbouch, I think, is in the audience, is one of the co-authors, and the senior author is Torsten Melling. It's a very nice paper, meta-analysis of papers that claim safety, effectiveness, and durability. It's very well done paper to show that there was absolutely no difference in the outcomes between the papers that said they're safe, effective, and durable versus the one that did not. So it reminds us that talk is cheap, words are losing their meaning in our literature, the words of science, biases, and marketing. And this is not endovascular, this is all fields. Don't take this as a specific critique of endovascular, not at all. We have to be very careful how we use our words. I think flow diverter is superior to microsurgery in these cases, petrous, cavernous, ICA, growing symptomatic, no question. I think a large ophthalmic segment aneurysm without rapid or acute severe visual decline, it certainly has superior results. Complex fusiform VB aneurysms, although the results tend to be poor in both ways, and any saccular or fusiform aneurysms with highly unfavorable microsurgical characteristics, absolutely. Heavily calcified ones, no problem whatsoever having those. Would I ever choose flow diverter over microsurgery for a PCOM aneurysm with an acute third nerve palsy or an acute visual decline of optic nerve? Sure, I'm not unreasonable. The patient has to be more than 600 pounds with pseudotumor cerebri and von Willebrand disease, have an ipsilateral prosthetic eye. All our operating rooms are on fire. Both my hands are in a cast. Craniotomy is not a bad word. This issue of minimally invasive is very misleading. It's minimal access surgery. We all know. We have a patient in our ICU right now, perforated from a pipeline and going to brain death just the last week. Now, of course, I'm using examples that support my point, but you know what I'm saying. There are two main reasons why a technique or innovation falls into obsolescence. It is proven inferior and overtaken, or its champions die out. And certainly that is what is going on with microsurgical issues. Jacques Moret, my very good friend, the first time I met him 30 years ago in this course, 1994, right here in Boston. Incredible man. He has done so much for the field. I remember him predicting, he said, today in 1994, aneurysm clipping is dead. I was a chief resident. I was distraught. I said, gee, I just finished my training. I'm not going to clip aneurysm. Now, of course, appropriately, the number of clippings have gone down. But I believe in destiny. Jacques Moret has the last two letters of his name. There is a destiny in there that says it all. Endovascular therapy, endovascular therapy, endovascular therapy. He is one letter short of being perfect, which would have been three letters and says it all. Champion of science, coolest of surgeons, conqueror of subarachnoid hemorrhage. Thank you very much.
Thank you. Next is Louis Kim, trained at Barrow by Spetzler and endovascular, and one of the few people that excels at both. A lot of people come out these days doing endovascular as a neurosurgeon, but not really understanding or practicing high-level microsurgical technique. Who's please?
Thank you, Ali. Thank you, Ali, Linda, and Nino for the invitation to speak. And probably the best thing that ever happened to me was that Aziz-Sultan decided to come to Barrow for an endovascular fellowship for 6 months as a resident, even though he didn't need it. And then he came back a few years later for a Spetzler fellowship. So I really appreciate your friendship, Ali, over the years. I'm going to speak about both. Obviously, these are sort of philosophical, and I appreciate the audience obliging me with the that sort of aspect, but I could probably stop here. I mean, this is why I do both. I have the support of my chair, Rich Ellenbogen, incredible partners like Shaker, Mike Levitt. We just hired Stephanie Chen, who is Jacques' protege, who also does both, and then my neurology and neuroradiology partners, Raj Gadki, Melanie Walker. The point is that I am part of a team, and that's why I can do both. You can't just have all neurosurgeons doing both as just the team. You really need that team mentality, and that's how we really excel. But in terms of why do you do both, I'm going to sort of look at it from a personal, professional, and sort of an academic standpoint. I think from a personal standpoint, as was stated by Dr. Al-Mefti today, you have to have that incredible passion for what you're treating. And there's no question that every cerebrovascular neurosurgeon just wakes up in the morning thinking about aneurysms and vascular disease, that we all have a passionate and voracious appetite for cases, and we don't want to give any of them up to anybody, and so we want to do them all. And then I think as a person who wants to do both, you have to love technology, as Ricardo mentioned, and you have to love technicians and technical skills, technical ability, as Jacques mentioned. And this is a case that these are why we do what we do. We love these cases. This is a complicated partially thrombosed distal pica aneurysm. You can see there's a very sharp hairpin loop and a partially thrombosed aneurysm. In my opinion, this isn't a great endovascular case. There's also mass effect. And, you can see the ugly aneurysm here, and, you want to use all the skills. And I think that's the value of what we do, is being able to bring the lowest risk and highest efficacy option to the patient. Here we can just basically plan for an aneurysmorphy, but I get in there, I see that there's a calcified artery proximal to the aneurysm, so you can't just sew them back together, so you kind of think on your feet. And you have to, what else can I do? So we cut the distal vessel, and we just do an end to side to the contralateral pica, and then do an aneurysmorphy at the end where we can basically excise the aneurysm. I can't skip ahead, so I'm just going to, for the interest of time, move on. But here you can see the bypass flowing nicely, and then the bilateral picas as well. Alternatively, as a quick example, this is a treacherous aneurysm from a surgeon's standpoint, and this is a complex posterior circulation aneurysm, but it's actually, quote unquote, relatively straightforward to do endovascularly. It's obviously a challenging case, but this patient has no PCOMs, really significant size, and very small contralateral vert. You can't deconstruct this artery, you have to reconstruct it endoluminally, and this is where, in this case, this is an older case, we actually use coils. I probably wouldn't even do that these days. And a single device, and you can reconstruct the lumen beautifully. And so that's sort of the passion of why we do what we do. From a professional standpoint, I think we have a fiduciary duty to our patients, and that means a legal or ethical relationship of trust. In a legal term, it means the highest standard of care. So I think we want to deliver that to our patients day in and day out, and that requires having all the tools in the toolbox, in my opinion. We also need to deliver the care in a team, and crucial to that means someone who can be a leader across all the arenas of care, including the angio lab, the OR, the recovery room, the ICU, the acute care, and even the outpatient clinics. And the neurosurgeon who does both, I think, is really poised to be that key leader. And both, of course, uses all the tools. It allows you to play to your strengths. I used to think there was always a right answer for a particular aneurysm, but now I realize it's the right answer in my hands. It's the right answer in your hands. And so that's a really key concept that I try to get it to my trainees, is do what you're really good at, but get good at everything you can. And that takes that commitment, that dedication that Dr. Al-Mefti mentioned earlier today. You got to take out the financial incentive. There's no question that's a huge driver of how business is done in medicine, including aneurysms. And so we need to remove that from our teams. Let us do what we're really good at and do what's best for the patient, that fiduciary responsibility. Remove the barriers to treatment, custom tailor approach, innovate. I think that's been brought up beautifully by the previous speakers. But I also want to talk about this, which is the recent publication where this looked at the neuroendovascular workforce by specialty, radiology, neurology, neurosurgery. Look at that graph. Look where it's going. So neuroendovascular skills, which used to be this rarefied air, is now becoming quickly a commodity, whether we like it or not. So as neurosurgeons, in my opinion, what's going to differentiate your skill sets is going to be microsurgical ability along with that commodity skill. And it's not to belittle what's been done in our field. It's continually changing and growing. But that workforce is out there and it's growing. Obviously, it's driven by the stroke care, but they're also going to be tackling aneurysms, AVMs, and so forth. So then finally, the challenge of both. I think I've been told from 25 years ago by Dr. Spetzler, you should train in endovascular, but you can't do both. You can't be good at both. You got to choose one or the other. And everyone I've ever heard that from usually just does one or the other. So I obviously disagree with that concept. Maybe it was stubbornness, it was hubris, who knows. But I think you can achieve that, get to that point where you really are expert in both, and the academic side as well in terms of innovation by using the hybrid OR as your laboratory. So here we are able to perform real-time patient measurements for CFD measurements, as Nima talked about earlier, and predict treatment outcomes based on wall shear stress and wall shear stress gradient, for example. We can biopsy aneurysms endovascularly, get endothelial cells from the tissue, and of course harvest domes during open surgery, and use that to understand how modeled aneurysms affect endothelial expression. You want to make sure you're doing all the things you can to sort of bring all the parts of your career into the OR and the lab as one. And so the role is really not which to use, the clip coil, that whole passé argument, but rather when to use. And we could argue that when endovascular and microsurgery are equal, then you can use it for equipoise aneurysms for the optimal clinical solution, perhaps combined cases or Hunterian ligation. Sometimes endovascular is the preferred treatment, and we know that paraclinoid aneurysms, I almost never clip them anymore because flow diverting stents and so forth are so good. I don't clip basilars anymore because we get really good results with endovascular. And of course, poor grade subarachnoid hemorrhages in the medically ill. What about surgery? Where does that excel? And I think Jacques said it better than I can, but MCA aneurysms, distal picas, acute cranial nerve palsy patients that need decompression, young patients, and so on. And then where do both techniques fail to reach optimal clinical solutions? I think you could talk about your fusiform vertebrobasilar junction aneurysms, which I call the GBM of vascular. And you might even argue blood blister aneurysms, where we continue to struggle. So, and then finally, I think this is an important thing to address, is the learning curve. The world experts will disagree that you can't get up both learning curves, and that may be true in the past, but I don't think that's true anymore. I think there's no excuses. And yes, you have to go through 2 learning curves. In reality, it's a series of learning curves, so all the senior professors in the room know that they've been getting better and better and better over the years. It's not an asymptote, and it's time and experience that improves your skills. And the reason why we can do it isn't hubris, I've discovered. It isn't because we are stubborn. It's because, if anything, we've seen further by standing on the shoulders of giants like Dr. Berenstein, Dr. Murray, who's here today, Dr. Hopkins, Dr. Harris, who's one of the guests, honored guests, and then my mentors, Dr. Spetzler and Shaker. And so I think that's the inspiration for why we can excel up that learning curve much faster than 25 years ago. And I'll end on a lighter note. This is irrefutable proof that vascular neurosurgery, in all its iterations, whether you do one, the other, or both, is one of the greatest adventures in life. This is a patient of mine from way back when who had a very complex partially thrombosed basilar aneurysm that required combined treatment. And he was so grateful, he unexpectedly tattooed my name on his arm. And if I were going to have someone tattoo my name on their body, I wouldn't have been a 280-pound former police officer, but again, you get what you get. So anyway, I'd like to thank again the organizers for this fantastic meeting, and as they say in Seattle, no rain, no rainbows. All right.
Beautiful. Dr. Dave, always a thoughtful talk and fiduciary responsibility. That is just key. Next to the crux of this meeting, Dr. Dayoub, and how we look at aneurysm care from different perspectives and what the current day approach is from your lens.
Thank you
for
Sultan.
coming.
Thank you for the kind invitation. Thank you, Linda, for all the wonderful work that you've put in this. Professor Mufti, Dr. Krish. We've heard today that both surgery and endovascular treatment work well for aneurysms. I belong to a generation that wanted to do both and do both well. Our generation was glorified by some and mocked by others, both with some justifications. And the reality is only a small portion of surgeons perform at a very high level that justifies the work that they do, and the same applies to endovascular interventionists. And what fueled the debate over the last decade or so was that people in this camp were comparing their results to the average on the other, and vice versa. The criticism is harsher on the other side. So what I intend to do briefly is present a simple model of how we learn to do well, to perform well at a high level, and present some of the challenges that my generation went, and touch on some of the challenges that I see the next generation will have, and give you some suggestions that I found helpful, particularly for trainees. And what I mean by trainees is the critical training phase is the last senior years of residency, your fellowship, and early practice. And if you believe the common notion of 10,000 hours of hands-on practice, it takes 10 years to achieve competence in that field. And with deliberate practice, it takes 30 years to become an expert or a master of the field. So you need to learn something well. You need someone who shows you what to do and how to do it well. And you need case volume to apply that knowledge and time for that experience to mature. It's quite clear that the number of surgical cases have been shrinking since the mid-90s, as well as the complexity of the surgical cases are increasing. The opposite is happening for the endovascular field. And that makes the surgical expertise have a steeper learning curve further than it originally is. Another factor as well, we've all been busy in building stroke centers, stroke networks, and the traditional hub and spoke model where the tertiary centers have a concentration of high volume of cases is shifting, where the cases are more and more redistributed to the peripheral. So if you're in that training phase, of that critical foundational phase, you're either training at a center that sees lower volume, or you have your first job at a peripheral center that also has a lower volume. This affects equally the surgical load and the endovascular load, so the next generation will even have a higher task. This is my last slide, so I'm going to spend a few times over here. What to do if you're in that critical phase. Have insight. Know your strengths, know your weaknesses, easier said than done, and resist the temptation to work to serve your strengths. Work on your weaknesses to have a balanced approach. Also recognize that success in certain areas can create shortcomings or create challenges in different areas. The success of flow diversion, for example, had taken away the experience of dealing with giant aneurysms. And when the time comes to surgically address a giant aneurysm, those skills that any experienced person will tell you, you've missed out on. Find mentors wherever you can find them. They will help you with your own insights. They will lift you and guide you along the way. Incorporate skull base in your practice, and that's a really, really big challenge. And this is an excellent audience to try to figure out at the leadership level how to incorporate that. There are logistical barriers to this. If you're a busy endovascular person, you can't expect accommodation from your colleagues that are building career in skull-based cases. But somehow be creative. There are solutions for this. And my last point is avoid the distractions. An incremental improvement on a catheter or a device is a distraction from the other task that you have to work on. Building a stroke network and fulfilling the administrative demands for that is also a major distraction. A tube is a tube. A network is a network. It will find its way. You have more important things to work on. I'm very, very grateful for all the people that guided me, supported me, and lifted me when I needed it. And a special thank you to Professor Mifty, who continues to show us what is precious. If you like these slides, you can scan the barcode. You'll get a copy of them. Thank you.
Thank you. Thank you so much. Next is Professor Florian to give his perspective on building with resource constraints and building practice in Romania. Very excited to hear this talk.
Thank you very much. Okay. Continue. Back. Continue. Quick. Okay. Here. Thank you again for inviting me here. And I'm really, really very impressed. So I will let you know where I'm coming from. So I skip one of the slides. I don't know why. So I'm coming from Romania. Romania is a country located in the, well, doesn't work, in the eastern part of Europe, and I'm coming from Cluj-Napoca, which is the capital of Transylvania. Transylvania is very well known because of Dracula, my grandfather. That's why I became neurosurgeon. So this is my town, and this is a part of my university. I don't have any conflict of interest. So what are the meaning from my point of view of research constraints? First of all, reduced accessibility for a broad education information. I had the opportunity to have the first observership in 1993, 1 month in Grenoble. Limited access to original specialty literature. At that time, we didn't have any original textbooks, only printed copy, and less access to the main journals. Lack of equipment. I started to operate with a microscope built up in Eastern Germany in 1976, and I've got as a gift the first 4 aneurysmal clips in 1996. So it was a tough period for us, but despite all this, I had unlimited resources for an open mind. So my mentors for the first clipped aneurysm were, as you can see here, Tamargo, Rigamonti, Sengupta, the authors of the chapters of clipping aneurysm and anterior cerebral communicating artery in humans and in Schmidek. And you can see these are the original textbooks, printed textbooks, in which I read and I write and I learn. In time, I have learned from great neurosurgeons without attending their operating theaters, but reading their books, articles, following their presentation in congresses. From them I learned that there is no native vascular surgery, with few exceptions, that hardly trained every day. I am deeply grateful for I have learned from them, and even more grateful to my patients who trusted in me during my first steps in this fascinating endeavor. In 25 years of vascular surgery, what I understand that every single case is more important than the total. And from 9 hours, it took me 9 hours to clip the first aneurysm, to 30 minutes, which is usually today, it takes more than 5 years. Other lesson that I learned, it's the uniqueness. As Professor Al-Mefti mentioned, there are no 2 identical aneurysms, so we should treat every single case with the deserved individuality. The most difficult case is the first one and the next one. And with or without resources, cases still exist, and we should find a solution for them. How to solve when you don't have enough number of clips? You can reinforce them with wires. How to solve when you don't have, for example, T-bar surgical clip? You can put counter clipping with fenestrated clips. How to solve when you don't have Gore-Tex, as Professor Spetzler presented in this article? You always have dura mater at your disposal. How to avoid a second operation? you could clip them in the same session. How? It's not so complicated. I only want to present you a case with 3 aneurysms. First, I clip the proximal one, then I move to the distal one, and then dissecting the contralateral sylvian fissure, you can reach the contralateral bifurcation and place a clip. You see it's there enough space. You put a clip. I was not satisfied with the clipping. There is a residual neck, so I placed another one in order to encircle the bifurcation, and you see the result. So, other lessons I have learned: we can predict with high precision which patient will go bad, but we cannot never predict with the same precision the evolution of the Hunter head trait. Surgical expertise is an important factor in the prognosis of the patient. An experienced surgeon could faster recognize and maybe solve an unpredictable event. Use your imagination, but don't be too creative. Management of patients with ruptured aneurysm, it's a multidisciplinary endeavor. That means knowledge, intuition, perseverance, patience, devotion, passion, and luck. So maybe you don't have Hubble telescope to see these galaxies, but you have neurons in your brain. You have network. Activate your network, because your brain, it's a universe. It's only up to us. Everyone is in the possession of the universe. It's only up to us to take advantage of this infinity or to let different constraints to put limit on it. So my residents nicknamed me aneurysmator because I clip all the aneurysms in the same session. And our goal and our mission is now to transfer our knowledge to our disciples. So education is now our main goal. Thank you for your attention.
Thank you. Thank you. Well, Professor Al-Mefdi sets up. We have 5 minutes for questions or comments from the audience. There's a microphone that can be passed around. No, maybe I'll start the question and then maybe somebody can follow up. I picked up one important concept from Professor Murray the last time we were together, and that was logistics. Like the crux of everything is logistics. We talk about clipping or coiling and a full bag to sort of really advocate for the patient. But how do you do this? How do you train the modern neurosurgeon? And then how do you disseminate this education, this training to parts of the world that really need it and deserve it just like we do? I'd like to ask that to Professor El-Kamlichi about how did you spread what you learned through Africa? How do you do that? Maybe it's a big question, but would really love to understand your perspective of teaching. Is there a microphone?
Thank you very much for this question. Thank you for your invitation to be here. I think you are asking about the expansion and the development of aneurysm surgery. You know, when I started my residency in the 70s, there had been a lot of written papers in the area that cerebral aneurysm doesn't exist in Africa, in Middle East, even Ramamurthy in India published a very interesting paper on that. So one of the first duty was to demonstrate that the aneurysms exist with an autopsy study and work, and see that the frequency, the incidence is the same in our places than in the others. And then, of course, it was very difficult to convince the doctors and to have even the neuroradiologists in our places to perform, for example, the angiography in emergency. I remember in the 80s, it took me around 5 to 10 years to convince them that when one cerebral hemorrhage arrived, it should have, the patient should have an emergency angiography. So we went step by step. And the numbers of the aneurysm, of course, was doubling every 5 years since 1980 to today. And now we have more than 2,000 cases operated. Of course, the microsurgery was the first technique used until 2005. Before, I think that Abd-Samad Wahabi would say some word later on. And this teaching happened, of course, in the operating room, in sending young colleagues to have courses, to benefit from courses in Europe, in other places. So this is the way we followed regarding the vascular surgery.
Thank you. Thank you very much. Okay. Any other comments? I'll turn it over to Professor Al-Mefdi.
Dr. Krish and Professor Moret, please, if you could come up here. Is Dr. C around, or do you have his presentation? I got to create a little excitement here. The coffee is not strong enough, okay? Can you put my slide on? 20 years ago that Dr. Morko showed, 1994 it started, there was a big debate which I never understood, with clipping versus coiling, and all the meeting and the discussion go clipping over. I never understood that debate or the basis of it, or why it should ever exist. And I think there is a lot of experts here in the audience, and we will hear their thought. This is settled. The fight only for coiling or clipping, I think there is enough wisdom and knowledge and experience to address it now. Except, this is a great man, not just so good a vascular surgeon to do it in Harvard, but he's concerned about the people in the rest of the world. So I was thinking, if this aneurysm, you all see it, this patient, the aneurysm, subarachnoid hemorrhage, and you could see that he had a middle cerebral artery and choroidal on the same side, and then superior cerebellar, or the Badler tip on one. What to do with this patient? This patient, in my little experience and humble opinion, will be totally applicable for both modality of treatment. And I thought we'll coil it in 45 minutes and cure him with the coil. But I found out that the web is at least $15,000. It's got to put $50,000 at least in this man's head. $50,000 that will buy half of the countries. And find out that now you could get a titanium clips of Yazergil type in new for $26. So if this need is just 3 clips, it's all of it is $70. So the issue came back to me. Clip or coil? Of something applicable for both. So to make it a little exciting, first we asked Dr. Mooney and Dr. C to give us just fact and numbers, because Dr. Moray and Dr. Krish will give us a lot of passion and a strong opinion. So, Michael, you want to start?
Yes, sir. All right, well, a real honor to be here, speak in front of this audience, and thank you to Dr. Al-Mefti and everyone for the invitation, especially to speak about microsurgery. And I know that I can be a little provocative, as Dr. Morko said, because I have the support of him and Dr. Al-Mefti, who have laid some of that foundation already. So we'll go through a couple things here. We were asked to cover these topics in about 4 minutes. So we'll go a little quickly, and I'll try to highlight some of the microsurgery aspects of it. So if we think about the resources needed to treat a case like this, I think there's no doubt that microsurgical resources in terms of the operating room and the staff is going to be more widespread than the endovascular, although that is changing, and there's increased endovascular resources and staffing available in more and more facilities. You need modern standard craniotomy supplies, those listed here. When you think about the more specialized supplies, the aneurysm clips versus the coils, the devices, the stents, the web, there's clear benefit for microsurgery there. Dr. Al-Mefti already touched on. And a few of the maybe a little extra luxuries here for specialized supplies needed for clipping, but that's what we've been speaking about all morning in terms of microsurgery for treating these aneurysm cases and skull-based cases. And this is supported in the literature that overall the supplies for craniotomy case will be slightly favorable from a cost perspective. We've touched on the training that's required to treat these types of lesions. If you think about the training required to clip an aneurysm, well, it's the training that we're all tasked to obtain in our neurosurgical residency. A few interesting numbers that I put up here, mostly for some additional discussion, is that currently, if you look at the ACGME case log minimums, the minimum open vascular case number is 10. So we're expecting our neurosurgical graduates to obtain 10 open vascular cases in their training. And the reality is that most people now graduating and going on to treat these in their practice will obtain some additional fellowship training. There's an interesting paper here just published that if you look at the addition of CAST fellowship training programs and their addition to case logs and surgical case training, the average fellowship training program is going to add about 80 open aneurysm cases. They might have more than one fellow, though. So about 34 additional open aneurysm cases per fellow for those that go on to CAST fellowship training. So maybe worthy of a little discussion as to if that's enough. But it does not require that additional dedicated endovascular. Now, the immediate outcomes that we all know from the large trials of the ISAT and the BRAT, they do favor endovascular treatment in those earlier time points, 2 months and 1 year, less morbidity with endovascular. The complications, well, we think about complications of cranial. Well, they'll come in the beginning with craniotomy, bleeding, or infection. Certainly we have to deal with that from a surgical standpoint. Seizures is, there is literature on that, maybe a little less favorable with the surgery, but probably the most important factor here is the early rebleeding. And there's a benefit to microsurgery there for the obliteration of the aneurysms, and then the additional impact or the additional benefit coming with the long-term outcomes. When you look out to the 10 years, look at the rebleeding, the need for retreatment, those will begin to favor more the microsurgical treatment. And that's really highlighted here, I think, in probably the main takeaway of this, that the endovascular does have a higher risk of rebleeding over time, lower rate of obliteration, and that decreases over time the more and more we follow them. These are data from the 2 large trials that we often cite. Obviously, the technology is constantly changing, but you see at 10 years how quickly it drops off. So if we bring it back to the case from Dr. Al-Mefti, multiple aneurysms, anterior circulation, posterior circulation, to inject a little of the provocative that Dr. Al-Mefti asks for. If you think about treating these with endovascular, well, I think we can say that there's going to be a low rate of obliteration of all the aneurysms. There's nearly 100% chance that they're going to need to be retreated, at least one of them in the future. And there's going to be an early rebleeding risk, a late rebleeding risk. There could be thrombotic complications that need to be addressed, antiplatelet, anticoagulant complications, access site. For microsurgery, you could just ask Dr. Krish to clip the anterior and the posterior circulation aneurysms. And then about 6 months later, you could have a picture like this that you can post on Pinterest and go on with a cure for the rest of your life. Thank you.
Do you have to shave that much hair?
There's also like a transverse incision, so I'm not exactly sure what she had done. But.
You disfigured the patient.
Thank you so much, Mike. My name's Alfred. It's going to be humbling, but as Dr. Patel's son once told me, he hopes that we do endovascular because it's always going to be faster and he might actually make it home for dinner that night. So same topic here, resources, show some pictures. This is the design of an angio suite. Oftentimes we're talking about hybrid suites. Certainly biplane is required in most scenarios, although all of us have done some cases in single plane suites. But ultimately, if we're thinking about the resources, forgive that one line that's striked out. So there's costs of different kinds of infrastructure required, right? So in reality, probably the personnel cost is the greatest cost because it's each individual person's time. Ultimately, it's not just the proceduralist care, but the intensive care afterwards, the long-term follow-up, that's really the investment in the patient and the treatment of their aneurysm. The infrastructure cost, it looks like a lot of dollar signs, but this is typically a single-time capital expenditure. Things like materials handling are typically handled by the hospital regardless, so you're only making a small difference in any hospital's bottom line. Whereas the staffing is really going to be a main driver. Everybody talks about the materials costs, so things like contrast, catheters, wires, and devices, and intraprocedural medications. There's definitely needs to be acknowledgement that devices are getting more and more expensive, but ultimately they still pale in comparison with the amount of time that's invested in the training of people, and also even the accessibility of people. Having a neurosurgeon at each individual center compared to having different proceduralists with radiology experience, neurology experience that you need in your hospital to provide comprehensive care anyways. And then outpatient follow-up ends up being a smaller component of that. This is just more description of the infrastructure resources required. I was lucky to learn from Dr. Sultan about that. Again, that personnel investment is important, right? So Mike already talked about the 7 years of neurosurgery training and how we, in 7 years we clip 18 aneurysms, right? That's not a lot, but there are other specialists who lend some insight into post-stroke care, perioperative management, critical care, and diagnostic radiology. So those other colleagues of ours inform us and educate us as well. And some of them are doing 4-year residencies plus 1 to 2 years of fellowship, or 5-year residencies plus a year of fellowship. And then all of them are theoretically going to CAST accredited or CAST equivalent type fellowship training with somewhere around 40 to 50 aneurysms treated. So most people are getting the majority of their training during their fellowship anyways, right? Mike basically already covered a lot of these early trials, ISAT, BRAT. I think I would want to acknowledge that both approaches have their complications. Certainly the complication profile is a little bit different when you're doing what people call minimally invasive, but someone earlier appropriately described minimal access, but is equally invasive or maybe sometimes even more invasive to the relevant vascular anatomy. Long-term outcomes, I think these ISAT curves nicely show that there's this early cost to some of the microsurgical approaches, and over the course of 10 to 15 years, you start to equalize out. So certainly that impacts which patients you're thinking about what kind of treatment. We'll skip over that, Brad. And ultimately, I want to remind all of us that this is always a changing environment. A lot of those early trials were with ruptured aneurysms, but we've really moved towards trying to improve the outcomes for unruptured aneurysms, patients that are coming into us essentially normal, and we're trying to promise them that we're going to make them better than normal and protect them for life. So don't be fooled by some of the systematic reviews, for example, this one where they only have 40 patients in some of these cohorts. But we do have some data, some analysis of the coils with biomodification that also included stenting, but more recently things like Premier and PUFFs really showed us that long-term outcomes for endovascular approaches, really not just coiling anymore, long-term outcomes might actually get better over time. That being said, sometimes we're finding that newer devices aren't always better in all ways, and some of the long-term follow-up of the web device suggests maybe it's not as robust as some other techniques, and that's an ongoing discussion with ongoing research. So I'll turn it over to the experts. Thanks so much for having the baby surgeon talk to you all about vascular today.
Thank you. I want to thank both Dr. Mooney and Dr. C because they did exactly what I want them to do. Give the numbers without opinion or experience or preference. The problem is that we all falling off what they call evidence-based medicine or what have you. It's another fallacy I did not talk about, because this evidence are a trial done 15 years ago in a large number of center or patient or surgeons. What Dr. Moret achieved, not necessarily what other people achieved, and the same thing of what Dr. Krish. So the problem is going to come down not to all of those ISAT and BARA study and BARAT and what have you, because this is just a statistical twist. The problem is going to come down to what are you capable of doing at your best. So then if that's what should be done. So, Doctor, who want to start? You go.
I can start. So,
okay, come.
At least my colleague will have to say to.
You have your slide.
They will have to answer, so it's easier for you.
Yeah. Give me time some discussion. There is a real good, wise people in the audience.
The evolution of the technology today is absolutely fantastic, to the point that for the time being, I'm used to say that even a neurologist can treat an aneurysm, which is definitely something that is very strange because, the neurologists, they are not used to put their hand on the patient to scratch the skin, to navigate in the vessel, but they saw that it is so easy that they can do it, and they do it especially because of the stroke business. But now they are switching to aneurysm treatment and potentially brain AVM. So honestly, it's not that difficult to learn. So everybody can do it, and I think that you should definitely be conscious that there is no way to move back. If you want to keep on debating, which I hate this debate, I tell you frankly, I came because I have a lot of friends here, but I hate this debate between surgery and endovascular. It doesn't exist anymore. If you want to keep on debating, you can, but I think there is a very simple way to stop this debate. Repeat a randomized study. And you will see that the results of ISAT are bullshit compared to the result you will get today, because the technology has dramatically evolved. So please think that there is no way to go back. Another point. You don't understand the strength you have in your hand. If I was a neurosurgeon, unfortunately I am not. Unfortunately, I am not. You own all the tools in your hand. endovascular has become easy. How can you allow a guy who doesn't know how to put a shunt, an external drainage, to treat an aneurysm alone in his angio suite? Why don't you make a buzz on that? Why don't you say, alarm, alarm, warning, warning, you should stop doing endovascular treatment if you don't know how to put an external drainage on the table to save the patient. You cannot wait 45 minutes for your neurosurgeon colleague to come in the room and wait for 45 minutes the time the patient is dying. So why don't you use this? Go on the network, go on the social network and make the buzz and finish with this. If you say it's no more possible, if your society, if the World Federation start making the buzz on that, you will see that it's finished. Nobody will continue to do endovascular treatment without learning to put a shunt. So there are very simple things to understand. You own the business. I am happy for that. I feel comfortable to do what I am doing because in the department, and probably in 98% of the department in France, I know how to put an external drainage. It's simple. You cannot do a treatment if you don't know how to put an external drainage. So now what's going to happen? You have to teach the interventional neuroradiologist to put an external drainage? Why not? Will you do that? I teach a lot of neurosurgeons, and I am happy for that. Because, even if you are a gynecologist and you want to do aneurysm treatment, if you are good, if you follow the good training, of course, you can do it. You are a doctor, you might understand a little bit. My secretary, if for 2 years, I teach her how to do it, she will do the business. She doesn't know to understand what is the disease. I take the decision and I understand the disease. And I tell her, now you have to treat the patient and you know how to treat it. That's fine. When you cook something, you don't know how the mushroom is growing. You use the mushroom and you do your cook. We have to change things. We cannot continue, I am the best, I am the greatest, I am a neurosurgeon, so I am on the top, because the brain is up. No, stop. It's a simple technique. It can be taught in a very simple way. The teaching has to be strict, and it has to be enlarged for many people. As far as a guy, a doctor, understanding the disease, knows about the indication. Because what do we do today? We treat aneurysm, small aneurysm, with no history of bleeding, and we even don't know if it's good for the patient. A team study was started to try to understand if it was good to do a treatment of small aneurysm and rupture, and it fails because we had a lot of problem to include the patient in the study, because the first thing that the patient gets when he has the information he has an aneurysm, it comes from the radiologist in the suburb of the last city in the south part of France. You have an aneurysm, it's a bomb in your head, please go ahead. How can you change this? The guy knows that when he comes to see you, he has already a bomb. He doesn't want the bomb anymore. So whatever you say up. So it's a 1 minute. So even when we speak, even when we attack the real problem, you quit. You say it's no more. 1 minute. No. We have to debate very strongly. I came for this today. To debate with you and for you to understand that it's stupid to have two disciplines doing the same treatment. Invent a new name. I don't know the name, but invent surgical something, outside from inside, I don't know. Have a single word federation. We have a federation which is not a federation. It's a society, but it's called federation. You have a true federation. Let's have a federation of a new name in which there is everything.
My boss telling me the time is up.
No, but time is... what's important in time when it's useful. When it's useless, time has no...
But that's exactly what I want to hear. Okay, Dr. Chris, ready?
Yeah. Well,
It's like the old, what do you call it? That the two people on the horse with the big. Okay,
Yeah.
you ready?
But I am on your horse.
yeah.
This is a big difference. Huh? I am not on mine. I am on yours.
Oh, we'll take Jack on our horse anytime. There is I would start with one bold statement. Microsurgery, whether for aneurysms or a lot of things, is not going to go away. I'm optimistic. It's going to stay. It's good. When done properly, it has superior outcomes. That's clear. Jack touched upon it, long-term, durability, and so forth. There is a force. It's a very strong force. You can see the force here, and the pressure to mold and to conform to a certain way of doing things. But this is not what counts. What counts, like Dr. Al-Mafti said earlier, is what's going to happen to the patient. And there are best places for this, like Jack said, and best places for this. But the practice and the rest of the world, the 4 billion and so forth, we have a lot of duty to do to provide microsurgery. You cannot give 15,000 web in every patient, $15,000. However, microsurgery, one thing that needs to be understood nowadays, in some places, it's being done at a level where very few people know how it's being done. Jack doesn't know it. A lot of people don't know it. We are doing paraclinoid aneurysms within an hour. Under the brain, you don't see the brain. You have to come and see it. You have to admit that there is progress. The problem is this is being deafened up. It was being kind of blocked from showing the results. No, the patient will not have a stent. No, the patient will not have anticoagulants. They go home and they are cured. And the word cured, like Dr. Al-Mafti said, has value. I live with an aneurysm. I live with coiled aneurysm. This is a personal thing. It is not fun that you have to still worry any time in your life, what if? You cannot forget that. It's easy to say the trend is this. Yes, endovascular is here to stay. Like he said, it's progressing, it's adding, and so forth. But you have to keep in mind also, part of its progress is because of previous failures, not because it keeps improving. Plus, the goal keeps moving. You are putting a certain standard that keeps moving. We have to accept that a treatment only achieves obliteration of an aneurysm in 50% or 60%, and you say, this is a good outcome. It is not bleeding. We keep changing the goal. If I clip an aneurysm and I leave part of it in 50% of the time, you're going to crucify me. You're asking me to achieve a certain standard, but in another mode, you are accepting a lower standard. So we have to also keep in mind that what we want to achieve to our patients has to be the highest possible, not the most convenient or the fastest. Plus, you can achieve an operation in a short period of time. You can create a setup where things can be easy, because no, it's not easy that it's at the end of the day I can do endovascular. No, there are models. You can come and see our model and different models in different places. If you master it, you can achieve very quick surgery in a patient in a short period of time and achieve a high goal. Now, there is no doubt the future is going to be kind of pushing one way or another. But I can tell you an example. Like 2 weeks ago, when my patient who I treated with an AVM called me and said, my daughter came with a headache to the ER in North Arkansas and got coiled, and she's not waking up. The price that can go wrong, you have to keep in mind. This is an ACOM aneurysm that ruptured. Ali showed a case also where the coil went up and the patient didn't do well. You have to keep in mind, the price of the highest complication in both is different. What's the chance of an aneurysm rupturing and becoming brain dead while being treated surgically? Unless you're an orthopedic surgeon doing the operation. So what is happening in real life is not what's happening, I agree, in my place or in his place,
But we have a responsibility for a large group of people, and that has to be kept in mind. We cannot lower our goal. We keep doing it. Dr. Al-Mufti showed it very well. A meningioma is something that needs to be cured if possible. An aneurysm is something that you can tell the patient, forget about it. It's done. And if you keep lowering the bar, we're going to end up with a lot of problems. And yes, you're going to need more technology. You're going to keep needing more technology in the future because you're not achieving the goal. And you keep wanting to do something more. However, going back to the beginning, microsurgery is advancing, unfortunately, in the few places. But like Dr. Al-Mufti said, I could not get residents for free. Why? The teachers are not seeing what's happening. There are people who don't know what they don't know in our specialty. It's a big problem. We have to educate our teachers now and what can be done. You should come and see it. A lot of surgery is done outside the brain. You don't see the brain. That is a beautiful thing, to cure a patient and tell them, forget about it. You don't have to worry about it in the future. It's a big price. I would want that. And it's not about incision. Don't argue about incision, saying you have an incision, that way you don't have an incision. People are paying $20,000 to get an incision for a facelift. So this is not a problem. I've never had a patient complain about an incision. Thank you.
The red light on.
Yeah, thank you.
Now let me ask you on the audience. This patient, the 3 aneurysm I showed you, it's my patient. Okay. In your practice, who would do endovascular treatment for him? This patient, in your practice, who will have clipped him? Kadir, you're losing. Now, let me bring one other subject on this one. This patient, if he was in Buffalo, he would have got endovascular. And if he was in Mozambique, he has no choice but clipping. What I'm bringing here, that there is disparity. They keep talking about disparity in medicine between the low income and the high income. There is disparity across the globe in the level of care you give. So, we need some wisdom here. How many more minutes I have? 1 more minute for the discussion? Okay. First, Kadir, you raised your hand strongly, and you super clipper and super endovascular, like some other distinguished people in the audience. Give us a sense of this. Do you have a...
In the setting of subarachnoid hemorrhage, I think the data is clear that the safety of the endovascular is superior. And that doesn't, we get caught up on the idea of retreatment. Retreatment's not the end of the world. And you can always come back and retreat the patient with clips if you have not been able to completely obliterate all 3 aneurysms with your initial treatment. You can come back and retreat that patient with either different devices or with surgical clipping. I'm not saying surgical clipping is bad, but in the setting of subarachnoid hemorrhage, the data is clear that the safety of the procedure is superior in the endovascular setting.
You're saying, I might have missed the presentation by Michael and see. You're saying the endovascular is safer for this patient I gave you than open?
In the early phase, absolutely. The morbidity of treating those 3 aneurysms with endovascular.
It's not absolutely. Absolutely maybe for you, but it's not absolutely. There is surgery done under the brain now that you don't see the brain for these all aneurysms that we just talked about.
But
you have to keep that in mind.
You can't treat the 3 aneurysms without seeing the brain. And I'm not saying that surgery is wrong.
Under the brain.
In my hands and in the data where we've looked at thousands of patients across hundreds of centers, randomized across multiple countries, the safety is better in the endovascular treatment in the setting of subarachnoid hemorrhage. Now, if this was a patient with unruptured aneurysms, my answer would be different.
Ali, to move back in the same direction.
I need some. Oh, you want to say something, Jack?
Please. You know, Ali, what you said belongs to you. You don't bring any new data. You don't have any new study to discuss either. So what you are doing today is proselytism. You want to convince people that neurosurgery is the way to go. Okay, I respect that. But are we going to continue for the next 30 years to do the same debate?
We're not debating, we're taking care of patients. Debating is something else.
No, we are not taking care of patients. Taking care of patients is also looking at the data and the result of studies.
Everybody showed their successes. I treat your failures. You have to keep them in mind. You come to my clinic, I treat the failures. I treat the coil failures, the stented failures, the dislodged coils.
I do the same for the neurosurgical part.
So it's the same. So,
Jack, we hear a beautiful presentation from you, really. Sum it all up in 7 minutes very eloquently. This patient that I have, and now I'm not in Mozambique, but I'm not in Buffalo, okay? I am where I am, and I'll tell you what I did. What do you do?
Good grade subarachnoid, correct?
Subarachnoid, yes.
Good grade subarachnoid hemorrhage.
Yeah, it's a grade 2 clinical, grade 3 fissure.
Yeah, no, I would clip them, particularly with that MCA. That's very hard to coil. Although we didn't discuss.
I think the one that's clipped, the basilar one, because it's the giant one, and the
it was an SCA.
Yeah,
it's an SCA.
Yeah. What do you do?
Yeah, I'd clip them.
You clipped them?
Yeah.
3 of them in the same session. You're
on,
going from the left side.
Yes, they're all left-sided.
And when do you discharge the patient?
Well, we have to wait for subarachnoid hemorrhage, about 2 weeks, you know.
You keep them 2 weeks in the hospital?
Make sure they don't go into vasospasm.
You keep your patient, who's the endovascular guy? Dr. Rami Al-Mufti, you keep the patient with endovascular treatment how long in the hospital after this? Can't hear you.
The subarachnoid hemorrhage determines that, not the way we treated it. If there's an unruptured aneurysm that we treat endovascularly, we send them home the next morning. If it's a subarachnoid hemorrhage, if they have a pneumonia, we keep them longer. If they have vasospasm, we keep them longer. If they have hydrocephalus, we keep them longer. That's what determines it.
Do I see Dr. Lawton back there? That you, Michael? Oh, I'm sorry. I just tell us what should I do with this patient. I'm here in the United States. I'm in Brigham. I know if I was anywhere out, I gotta clip this with no choices. This Taj Mahal triple plane, how many $1 million is that room? Yeah, and the platinum is a little bit expensive, but
yeah, we would have clipped this case, I think, for a multiple aneurysm case with one operation.
Now, but here what I want you to do, not if this patient came to Barrow and you're gonna treat it. I want you to say, if this patient come to me in a Brigham and I'm the one who's gonna treat it, what should I do?
Well, like I think you said it earlier, I think it depends on your individual competencies and the competencies of your team. If your team wasn't comfortable clipping 3 difficult aneurysms like that in a single setting, then maybe the best answer is to figure out which one was the rupture one with MRI study that would point you to one or the other, or you could use size and you'd take your best guess and you treat that one endovascularly and you would see. I mean, I think there are many ways to have handled that. I think the beauty of the open technique is that you can get to all 3 sites easily. You can address all of those questions by direct observation, and I think the patient would have a good result with that.
Yeah. Now, one issue did not come up, that the hybrid treatment. Is there anybody who will approach this patient with a 3 aneurysm. A couple of them endovascular and one, I guess the posterior fossa, everybody will want to do endovascular, and that middle cerebral, everybody will like to clip. So will anybody in the audience will do the combined treatment for a patient like this?
But if there is a reason to do a combined treatment, do it, but there is no reason. Either you decide because you are convinced that this has to be clipped, you clip it, and I decide that I can do it from endovascular, and I do it. What's the rationale to combine? Combine what? You combine the champagne, the coffee, what do you combine?
I will answer you, Jacques. The middle cerebral artery, maybe in your hand, is no problem for endovascular.
No, my
but
friend,
for
it's
a
no
lot
more in
of
my
people,
hand.
Good endovascular.
It's no more in my hand, it's in the hand of thousands of people in the world. It has become easy.
A lot of people for that middle cerebral one, they can extend and prefer surgical clips. Am I wrong? Who'll say I'm right? Yeah. And most of the people right now, unfortunately, for that basilar one, they will prefer coiling. Am I wrong or right? Who agree? I agree. So this, in your institute, that combination might not be happening, but it is happening in many places. So who said we'll do it? Dr. Sultan, why will you do that?
I think everything is very, very nuanced.
Give him the things.
I think just that there are contexts to where you are and what you do. There's a context to the actual morphology of each of these things. It's a nuanced thing. Ali talks about being on the edge of a clip and being into a zone. You can look at that SCA aneurysm, and you can almost imagine how your devices would fit and how it would herniate out or how it wouldn't herniate out. You can be on the tip of a catheter. In the same context, the MCA, if it's a wider neck, do you need a stent here and a stent there, or do you need a clip across it? It's a nuanced thing. It's got notes to it. It has it can speak to you if you look at it close enough. So in my hands, I would coil one of those and I would clip the other ones. It's what's most comfortable to me, and it's what the aneurysm is telling me. And when you speak to people like this, I think there's an art to it. There's a understanding of nuances that isn't as simple in my mind as a clip or a coil.
One last thing, where I started this morning. If this patient anywhere but not in Temple or in Paris or in Buffalo, he needs to be clipped. He has no choices but to be clipped. The durability, the safety, the expenses, the sitting, but to be clipped needs the training. So we go back, somebody has to be trained and then teach. And right now we do have a problem in training and education. Really, who's the young people in here? How many of you have seen basilar tube clipped? I need the people on training. Nobody. So it's gonna have to revive the microneurosurgery.
Now
Thank you.
This problem is applicable not only to aneurysms, but to microsurgery of tumors and other diseases that we are dealing with. This is a widespread deficiency.
Somebody has to make the art alive, and that needs somebody to master it and then teach it. Thank you.
Sorry. I have a question for the basilar tip. Do you think it's ethical today to clip a basilar tip?
My results in basilar tip is superior to
Ethical.
endovascular. It is very ethical. In my place, it should not be treated otherwise. And I have 95% excellent outcomes in unruptured aneurysms.
Can you turn me
This
on?
is what we do day in and day out. And I know it's very strange for you because the environment is kind of against it, but I will welcome anybody to come and see it and enjoy seeing the patients post-op. And in the future, there will be few places. There won't be many places being done. But at this point, my durability and the outcomes is superior to any endovascular treatment, and it's treated once.
Jacques, look at it. This is the middle cerebral. It's 30 seconds. Linda, don't. It got the clips. It got little belly. So it got the clips. Move down. Open the third nerve and mobilize it. Got the choroidal. Be sure it's free. Dissected it from the third nerve so it doesn't pull on it. And put that clips straighty. Be sure the choroidal is open. Then go down to the intrapendicular cistern. Here the basilar, a temporary clip on the basilar, clipped on the aneurysm. It's as easy as you see. Yes, if you are trained, it's easy.
Charming. It's a charming procedure. But if you ask the population in the street, do you want to have the head open or do you want to treat with nothing and go from inside? Everybody says, I don't want to have the head open. So even if it was better, the battle is lost. You have to accept that. Even if you have better result, which is not true. I'm not speaking about you. Overall, the battle is lost. Nobody wants to have the head open. Nobody.
I think this is an impression that you have. You will be surprised. We open the head for other diseases every day, and nobody has
Different
a problem of meningioma treatment. And if you tell them you have something that they have the indications that may maim them or kill them or disable them, I don't think there is a problem.
We speak on aneurysm.
And the music stopped right here.
And
Thank you,
aneurysm and
Dr.
the
B.
meningioma. Thank you.
Good morning. Thanks for Professor Al-Mehdi. Thanks for inviting me. And after this hot debate, I will discuss about the anatomy of the coronary sinus. Thank you. Is it full screen or is it full screen over there? So the now in the landscape of the coronary sinus, as you know, we have three fossa. We are looking from above to the skull base, anterior, middle, and posterior fossa here. The border between anterior and middle fossa is a sphenoid ridge, joined medially anterior clinoid, and the border between middle and the posterior fossa is a petrous ridge, joined medially posterior clinoid. The cavernous sinus is located medial part of the middle fossa here and lateral to the cell area. If we dress this bone with the structures, here we see the cavernous sinus structures, the cranial nerves from 3 to 6 arise from the brain stem, passing through the cavernous sinus and reach to the different regions. So here is the dura is intact. For the cavernous sinus surgery, we can come either from laterally, peel the dura off here, or from above here, open the roof of the cavernous sinus, or both, depends on the lesions. To open the roof of the cavernous sinus, there are important ligaments, it's good to know. From the petrous apex to the anterior collinate is called anterior petroclival fold or ligament. From petrous to the posterior collinate is the posterior petroclinate ligaments, and between the collinates is the intercollinate ligaments. Those are the roof of the cavernous sinus. Also, we see another important ligaments here. This is petrous sphenoidal, also called Gruber ligament, and that forms the Dorales canal, and the sixth nerve passes through. This is an oblique view, front here, and the back is here. We see the sphenoid ridge, supraorbital fissure here, and the meningoorbital band runs the superior lateral edge of the supraorbital fissure, which is an important landmark for the anterior collinate too, because medial to this band is the anterior collinate. Sometimes during the surgery we can cut it and not realize it. So if you see here the sphenoid ridge, edge of the sphenoid ridge is always sharp and the anterior collinate is more flat. Also, we see the other part. Here's the optic canal and supraorbital fissure here, and this is the optic strut. You see, when we perform the anterior collinatectomy, also we need to cut the optic strut here. Petrous ridge here, there's a one depression, one prominent, one depression, one prominent. Here's a trigeminal impression that trigeminal nerve sits. We see the trigeminal prominence, mayoral depression, and arcuate eminence here. So if you look at here, this is we see the thickest nerve is the trigeminal nerve. When we follow the V1, we can reach to the orbit. If we follow the V2, we can reach the pterygopalatine fossa. And if we follow the V3, we can reach the infratemporal fossa. So another thing is, if you look at some textbook, they show the Mecca's cave, which is the trigeminal cistern that the CSF circulating inside, as you know, the other nerves has too, like oculomotor cistern here, till the entry point to the tentorium. The same thing, but the Mecca's cave, the textbook shows ends of the foramina here, rotundum here, valley here, but we consider the Mecca's cave ends the mid portion of the trigeminal the ganglion. So we're looking at the skull here. This is the V2, pterygopalatine fossa, and V3 is infratemporal fossa. Also, tumor also follow this, the foramina to go to the different regions. So famous triangles. Here is the collinate triangle. Dr. Dolenk calls here as an anteromedial the triangle actually, but we have also different anteromedial triangle here. So after removal of the anterior collinate, between the distal and the proximal ring of the dura, we reach the collinate segment, and anteromedial is between the first and second division that take us to the sphenoid sinus, anterolateral between the second and third divisions. If we drill here, we can get to the infratemporal fossa. And here's the Glass-Cox triangle. The petrous I see located here. If we need to proximal control or something else, we need to drill in that part. The posterior border is the GSPN, greater superficial petrosal nerve. And behind, the most maybe used one is the Kawase triangle. Behind the GSPN, medial trigeminal nerve, and inferiorly inferior petrosal sinus. So What we see here, we see the carotid ICA. Here is the carotid, the canal, and the ICA becomes the petrous part. We see the petrolingual ligaments here. After passing this level, it became the cavernous, the ICA, posterior band, and we see the anterior band here. You see the abducens nerve passes inside the cavernous sinus and takes some sympathetic fibers from the ICA sympathetic fibers, fibers. Also, most vulnerable nerve would be abducens nerve that gives the 3-5 rootlets medial to the V1. So we are going to look from front right now. This is the canal, petrous ICA, and here is the cavernous ICA, just petrolingual ligament laterally, but also we can say the endoscopic standpoint that it's called, here's the paraclavial ICA, by the way. If you look at closer, we see the cavernous sinus here, V3, middle meningeal artery, and here's the V2. See the ICA, the cavernous segment is here. We see the sympathetic fibers of the ICA, it joins the abducens nerve. So we know arteries, veins. The third structures could be lymphatics. Well described in animals, but we still don't know anything about it. But if you look at this, this is our current study in human. You see this is the MMA here. Around the MMA is very rich with the lymphatic structures. We don't know where it comes from. We don't know where it goes. We don't know function or anything, but it's there. So maybe if we can, like to figure out more about this lymphatics, that, that tells us pathogenesis of the tumors or some neuroimmune disorders, etc. This is another, the findings. The dura around the jugular foramen, you can see this is the lymphatics. The green and the red one stands for the lymphatic structures, and you see it's kind of like lymphatic vessels in human too, by the way. Thank you.
You could blame me. I insisted on putting cavernous sinus session. Maybe 15 years ago, these pictures were breathtaking, and everybody will be salivating, and people going to the lab and dissecting the beautiful cavernous sinus. Unfortunately, you don't see it anymore. There is, in the program of big meeting, it disappeared. In the courses, disappeared. And the cavernous sinus become no man land again. Nobody is going there anymore. Which to the contrary, this is the most beautiful place to do surgery. So that's why we named it Cavernous Sinus is My Home. And nobody could prove it better than Dr. Chris. And Dr. Chris, come up.
Thank you, Dr. Al-Mufti. 7 minutes. I think I'm going to blame Dr. Lawton. If you made it 10 aneurysms, we would have gotten 10 minutes, Anyway, well, I have great teachers. I'm lucky, and that's where a lot of my teaching and mentorship comes from. He takes a lot of credit for everything I say, including Evandro and Professor Yazegil. But I'm going to come with a revolutionary kind of message. I urge everybody not to put this case anymore on a discussion, to have several people who say who would come a knife, who would do this, who would do that. Nowadays, this can be operated on safely. This is a patient who's symptomatic on the younger side. This needs surgery. And this can be cleaned well. And how I will address this. And this is the patient. This is the movement of the eyes, even in the hospital. And it doesn't matter if the tumor is hard or not. I have heard also, if it's soft, you can do this, but if it's hard, you cannot. Yes, if it's hard, you're not experienced, you shouldn't be there, and you're not going to be able to do it. But this is hard tumor, and it can be cleaned fully. The same with this. This is post-op, on follow-up. They are fully functional. The same with this case. This is a young lady who has progressive symptoms. She has lost her third and sixth, and you can see how it is abutting the carotid. In this case, this was radically removed. The carotid was already not being needed by her, and this is the follow-up. And this is a Simpson grade 1 in this case, totally removed and full functions. There will be the occasion when you cannot achieve much, like in this case, when you cannot, the carotid is still filling, it is needed, and you end up with a small amount of tumor behind it. So these are the few cases. However, how can we go back and fix this? It was done in a certain way. The failures happened, but we have to do our homework because these patients don't go away. Dr. Al-Mefti showed you the case in the beginning. This was a great introduction. I took all my cases out so to gain time that I saw with failures. Because if we come back and study it and approach it in a different way, then we can achieve more. And how do you do that? You have to understand the surgical anatomy and its variations and the pathologic anatomy. How these tumors grow is important. And this is the cavernous sinus meningioma. Please also don't get fooled. There's a lot of publications that show even a clinodal meningioma under cavernous meningioma. It is not. This is the true one. Where they start is in this location, and they grow in different directions to a different degree. And then, if we look closely, that's when we can achieve something. I spent a lot of time in that region, 30 years now, and this is a good saying of it. Eventually, it will click to you what is the problem, why did we fail, and how we can fix it. And the problem was we approached the tumor wrongly. We used to go in, operating on the tumor, trying to find the nerves. Completely wrong approach. We have to go in, just like Michelangelo puts it. I saw the angel in the marble carved until I said it. You go in, you have to get the nerves out first. But how do you get the nerves out? From normal to normal. That's the title that Dr. B wanted me to show. You have to go where the nerve is always normal and where on the other end it's always normal, and then bridge it while removing the tumor. So the surgery is no more tumor surgery, it's re-identifying the anatomy surgery, and that's how it should be done. So how do we know that this is the case of the growth? If you look at the anatomy of the tumor and you see the smaller ones to the bigger ones, they correlate. And this is based on my personal experience. When I went in and removed this tumor, this is where it was located. The tumor which was bigger, it spread laterally and into the region of Meckel's cave. And then if it grows more, it grows further anterior and pushes the carotid anteriorly, and then it starts going to the sella, and so on and so forth, and it goes towards the tentorium. That's why I like to call those cavernotentorial meningiomas, really, more than cavernous sinus meningiomas. So how to approach them? There are phases. You follow them. There is a recipe now. We used to have a lot of cooks, but we didn't have chefs. That's the problem. So how do we approach them? And I'll give examples. This is all delineating how we dissect the nerves. And an example of this case, you go in and then you have to find all the nerves on the outside. You dissect the fourth nerve, V1, V2, V3, and these tumors do not invade the nerves. The majority of them, the nerves are pushed laterally. And then you start dissecting. You go to the fourth nerve until it goes into the tentorium, then you stop because then you're diving into tumor. You go back and intradural and find the nerve on the other side. And then you bridge the nerves until you get an outcome that looks like this. The steps are the same. You find the nerves. The tumor, you can see it's filling all this region. But you delineate the third nerve intradurally. You find it already extradurally at the clinodal segment, and you bridge it. You bridge the fourth nerve, and then you unroof Meckel's cave, and the steps become predictable. This is unroofing the nerve, and then going the petroclival region until everything is delineated. This is the sixth nerve, and then the petroclival junction. You open it, and then the view at the end in every case is the same. Same with this case. These are the steps, and I'll go fast. And this is the extradural part, and then you open the dura, and you find the third nerve intradurally. And look at the way the nerve is deformed. If you don't find the normal to the other side of the normal, you're not going to be able to save that nerve properly, and you will end up with a problem. And that view at the end will be the same. And there's many examples to show. This is the sixth nerve was my problem, and I found out the solution is in the petrous apex. You have to remove the petrous apex very early to make the nerve more redundant so you can dissect it. And since then, we save every sixth nerve. This is the view of the sixth nerve after you remove all the petrous apex in that region. This is an example. This case was done about 3 weeks ago, and credit goes to Hitesh, my fellow who has helped me show the points. This is the extradural part delineating the nerve and showing all the pathology, and then after that the work starts extradurally. The first part is to delineate the anatomy well, and you start working on the tumor within the Meckel's cave, because there I need to find the sixth nerve, and then removal of the petrous apex from lateral to medial. This will allow the window to go to the posterior fossa to where the sixth nerve is. This is the medial part, and this is the tumor within the Meckel's cave. So we're doing all the extradural part early on and delineating the nerves in that region. Then you go to where the safety zones are found. You start delineating the nerves on the outside, and this is where the sixth nerve is going to be. There are landmarks. It is behind the carotid, going on this ascending part, under V1, and in front of the petroclival ligament. What does that mean? Everything posterior is safe towards the brainstem. And then you start working your way through it. And
my boss telling me
to stop
repeatedly.
Okay. So the final picture is going to be the same at the end. That's the view you get on every case. And this is how you've saved. Now, what's important here, this is the post-op, but look at the temporal lobe. This surgery is done under the brain. To me, it's very important that every part of the brain is saved, and there is no bruises or anything. And this is immediately post-op. You can see the third nerve that is dilated some, and then on follow-up, then they fully recover. And the way, there is a long discussion how to to dissect the nerves and so forth. However, the bottom line at my end of my conclusion is, I do not have any single new permanent deficit in these patients. If they have a sixth nerve before and it's complete, it's a problem. The chance of it recovering is low, because the nerve is really damaged within the Dorello's canal. Fourth nerve usually recovers, third nerve for sure recovers, which is the most important for the functions. And this, to me, is a new convexity. Just like you treat meningiomas in the convexity or in the clinoidal region where you dissect them off nerves and arteries, it's the same thing. And you can achieve in the future Simpson grade 1 in these patients. We have one challenge. I was in the lab 2 days ago. We're trying to come up with a way to remove the carotid and bypass it in 10 minutes. If we succeed in this, we have another big
I didn't
shot.
have the heart to stop it, because I'm been looking at this absolutely breathtaking pictures.
Yeah.
In real life, that's the patient.
Yep.
That's the results. That's what you could do. And that's what you could do in meningioma, which is supposed to be the most challenging one in being able to do this. So it's a beautiful, and thank you, Dr. Krish. Now, this is what you could do and what they're telling you not to do. But with chordoma, you have no choice but to operate in the cavernous sinus. 50% of chordomas are in the cavernous sinus. And to really have a good control on chordoma, you're going to have a gross total resection. And nobody could address that subject better than Dr. Sen himself.
Thank you, Linda, for inviting me. And it's an honor standing at this podium with one of the founders of cavernous sinus surgery. So it's somewhat daunting. But anyway, Sam, I will try and do justice. So what I thought I would talk about is both, because both are of the same way they involve the cavernous sinus, and the behavior is exactly the same. So they originate, these tumors don't start in the cavernous sinus, not like the meningioma talk you heard before. Also, so they start in the clivus or paraclival area and then grow towards the cavernous sinus. They involve many other regions, so cavernous sinus is only a part of the problem. So one needs to address the entire picture. So a tumor looks like this. So cavernous sinus is only a portion of it. And we need to be able to address the cavernous sinus so that the end result is that we get a gross total resection. This has been published by many people, Dr. Al-Mefti included, that gross total resection is what gives you the best long-term survival in these tumors, which are considered to be malignant. So if you look at the results of gross total resection, we compared my previous experience with the new experience now. And again, the same result shows up, is that survival is much better. So the question that I'm trying to answer is that, is cavernous sinus a limiting factor in getting a gross total resection? I think that in the past 2 decades, I would say, the endonasal endoscopic surgery has added an excellent tool to these kind of tumors, which are midline tumors mostly, until they get to the side. And this is best accessed from medially. And also, in some situations, you jeopardize the cranial nerves less when you come medially. So these are the two groups that I compared in my own experience, because at the end of the day, I cannot say that because Dr. Al-Mefti has these results, they work in my hands too. So I have to tell the patient what works in my hands. So I looked at it in my hands, what happens in these tumors when I did them open in the beginning and then this way. So clearly there was a difference. First-time surgeries with the endoscopic had a much bigger total resection numbers. But the recurrent tumors are still the same. They're a problem. Once these tumors recur, you're almost without further surgical recourse. But another important finding is that the volume of the tumor matters. And you see that the difference between the radical resection group and the incomplete resection group is the volume. So if you start out with a big tumor to start with, then you are almost in a behind the curve. Often the tumors will involve both cavernous sinuses, so you need to be able to access them like that. So here's a patient that I had. She was an older lady. She was in her 80s when I saw her. This was a recurrent tumor. So I decided to do this endonasally, and here's the paraclival carotid on one side. So I'm accessing the midline portion of the tumor. The pituitary is up top, and the tumors, these are often calcified. So this is where the morbidity to the carotid comes in. If you read the literature, the chances of hurting the carotid are much higher in these tumors that have calcification. So this is the dorsum sella that I'm removing. So the access is just perfect for this. And both carotids are exposed in the cavernous sinus, and I'm going into the cavernous sinus from medially. Because why? The tumor has started medially. Why come at it from laterally? This is the post-op. It's hard to read in this. It's one of the older scans that I had. Now, this is a young girl. She was 23 years old when I saw her, and she has a low-grade chondrosarcoma. These tumors always almost involve the posterior part of the cavernous sinus and pushing the carotid forward. And since this is growing primarily towards the temporal lobe, I decided to tackle it from a craniotomy. So these are, again, calcified tumors. This has to be kept into account. So the tumor looks like this. And once you move all the structures aside, you can see that the tumor is pushing the carotid forward. And I came at it, so we split the fissure widely. And here's the MCA, followed it down to the carotid. And again, it requires, so I did the clinoidectomy and opened up the roof of the cavernous sinus. I use flow seal to control the bleeding. I know Dr. Krish uses Tisseel. And then followed the third nerve into the cavernous sinus all the way. So I could move it aside from side to side and work behind it, because this is where the tumor is, going into the cavernous sinus. And moving it around and achieving going into the cavernous sinus, identifying where the proximal control always is very important. So this is the post-op scan. Temporal lobe looks good. This is the post-op study. This is another case, recurrent tumor. Here's the carotid by the yellow arrow. This one I did in 2 stages, again calcified. The carotid is disturbed and quite distorted. So it's hard to find the carotid in some of these cases. So this is the patient I did. And this was a craniotomy too. And you can see here that I did it, split the ganglion, found the carotid in the ganglion, in between the divisions of the... It's interesting to know, if you divide the ganglion like that, it's very, very, the sensation doesn't get disturbed. So here's the tumor. I'm approaching it this way. But also you will see here, here's the carotid. It's very stuck to the carotid. Going through the nose, this is extremely dangerous. This is how you lose the carotid. See, I get a rupture here. But I have proximal control. I put a clip there, and I repaired it, and you go on. This is a radiated and reoperated patient, and you can see that this is the post-op scan. This is how our eye looks like. This is a case, again, tumor. Again, multiple stages are required. And this is how I did the first stage, going behind, split the fissure open, work behind the MCA, and you can see those lenticular striates going here. So it requires multiple strategies, multiple ways of doing it. And then I went in endonasally and found the carotid and removed the rest of the tumor. Here's working in the cavernous sinus from medially. All these calcified pieces, very tricky, because this is how one can injure. Here's the basilar artery after the resection. And this is the post-op scan 5 years later. This is the one with a much bigger tumor in a young man. I did this, followed the carotid. Here's the head of the mandible. I went extradurally, exposed the petrous carotid, followed it into the cavernous sinus. So you have to have multiple strategies. This is the petrous carotid. I'm moving it around to get to the tumor. Here's opening up into the Meckel's cave to access the cavernous sinus, so following the tumor all the way. So the tumor makes the way. You have to understand how it is going, where the primary focus is going to be. And you can still get a good outcome. Here's the post-op scan. Extraocular movements look good. So there are many things that affect the results. Cavernous sinus is only a portion of it. The location, major vessels, primary or recurrent tumors. Surgical approach does make a difference, and you have to pick the right way of doing it. So at the end of the day, is it a limiting factor for gross total resection? The answer is no. Thank you.
Thank you, Chandra. So we went from the challenging pathology to the must-to-do pathology, and now we come to the delightful pathology in the cavernous sinus, and that's the schwannoma. And I tell you, there is no greater joy in life than to see your son doing better than you are. So I have Keith Al-Mufti here.
Nothing like talking about the cavernous sinus after Dr. Christian, Dr. Sin. What's that? Okay, well, like my father said, a real pleasure to talk about trigeminal schwannomas because they are kind of the gem, I think, of all of skull base surgery. Really a delightful disease to treat, but they share the characteristics of essentially all schwannomas. I think probably acoustics are the most distinctive schwannomas in the sense that, the schwannomas grow in a particular pattern and they have a lot of shared characteristics. So the first thing is they're encapsulated tumors. So here's a photomicrograph of a small fourth nerve schwannoma. And you can see that even within this fourth nerve, you can see a cleft of plane between the tumor and the nerve. You can almost imagine that you'd be able to dissect that away from the fourth nerve. The point of that is that this is the trigeminal nerve in the cavernous sinus, and the trigeminal nerve in the cavernous sinus is not one nerve, not even V1 is one nerve. In fact, even the sixth nerve is two nerve fibers. And so when we think of a trigeminal schwannoma, you're really thinking of a tumor that's growing from one of these single fibers, and the job is to preserve the sensation. Additionally, they're schwannomas, which means that they're going to start growing somewhere once the central myelin turns into the peripheral myelin, or beyond that. In the trigeminal nerve, that's a few millimeters away from the brain, from the pontine exit zone. That means that tumor is within the trigeminal cistern. It's protected by an arachnoid on both sides, which is opportunity surgically. Next, most of these tumors are multi-compartmental. All schwannomas kind of grow in particular patterns. There's a cisternal part, there's a pathway that the tumor is going from one place to another, and then there's the end organ. And if you look at the trigeminal schwannomas, they may begin in any one of those places and then extend into one of the other regions in their growth pattern. Now, this is an example of that. Here's what appears to be a tumor growing either from the cisternal segment back into the cavernous sinus or to Meckel's cave, rather, and or vice versa. But if you look closely, it's actually extending here into foramina valley. And paying attention to this gives you a couple opportunities. One, I now know this is a V3 tumor. If you look at V2 and V1, they're totally clean. And so I want to approach this tumor from the V3 side because I really want to protect V2 and V1 in my dissection. Now, there are a number of different approaches that you can utilize, and I think they're useful for a variety of tumors. If you have a primarily cisternal tumor that might be creeping into Meckel's cave, well, then that's good to do from the CP angle. If you have a giant tumor, you might need an expanded petrosal approach or a combined approach to access that. If you have a tumor that's in the maxillary sinus, well, you might come at it from the maxillary sinus, but these are generally exceptions. The real workhorse of the disease is approaching them through the cavernous sinus and the expanded Meckel's cave, as was described in this paper. And doing that just requires knowing the layers of the dura and dissecting that off, and you'll immediately encounter the tumor. And as you get to this tumor, you'll quickly see that you see no nerve fibers, right? The tumor disrupts the appearance of the nerve fibers, and identifying them becomes the challenge. So here's one that you'll obviously do from the like a zygomatic or transcavernous sinus approach. This one, is from V3. You attack it from the V3 side or the middle fossa. And then this one, you might say, well, it's mostly a CP angle tumor. But for me, I wanted to come from here because it had this large cyst within the brainstem, and I thought that would be a very difficult angle to see, and you can get a very good resection of that tumor from that perspective. So just to show a short video of this, so here we've done a temporal craniotomy. We'll dissect the meningoorbital band and cut the meningoorbital band. This tumor was growing from either V1 or V2. It was difficult to tell in the preoperative imaging. We'll dissect the lateral cavernous sinus and expose that tumor. And here you get that first kind of view of the tumor bundle, and you don't really know where the nerves are. You can kind of sometimes pick up a window. You'll incise into the epineurium in the plane of the direction that you're imagining the fibers to go. And once you get a little debulking, you can start to see the normal nerve fibers come into play. And all of these are V1 fibers, that the tumor is growing from a branch of V1, but those uninvolved V1 fibers can be preserved. Here you see the carotid artery and able to dissect that away. You have to be thoughtful of the sixth nerve at this point if you're seeing the carotid like that under V1. And this tumor can be very dissected in a very pleasant manner. And here you comes into view the one fiber that this tumor's growing from. Once you see that, or it'll come up here in a second, once you see that one fiber, here it is, and you can see that that tumor is all growing from that one fiber. The remainder of V1 is preserved. As the dissection proceeds, or as you complete the dissection, you'll get this final view in which you can see most of the V1 fibers were preserved, and the V2 bundle, which wasn't apparent at the initial point of dissection, becomes much more clear. Let me fast forward that a little bit. So here you see the preserved V1 fibers. They're all splayed apart by the tumor. And then here's V1, here's V2 that's now a very, very obvious structure and entirely preserved from it. So these tumors, I think the compartment of origin really kind of can facilitate the approach. Using the expanded Meckel's cave, understanding the cisternal anatomy allows you to follow giant tumors into the CP angle in a safe manner, and respecting that arachnoid membrane protects the other neurovascular structures. And then it is possible to preserve function even in the branch that is the origin of the tumor. Thanks.
Thank you. Now you notice that the title of the whole session is Cavernous Sinus, My Home. It's just to relate that this is a neurosurgical territory, and the hesitation of dealing with lesion there, I personally cannot understand it. And I could blame it again on the same thing, exposure and training. If you have not seen it, if you have not gone to the lab, you're afraid to go there. Now, and then you will hear all of kind of fallacy. Cavernous hemangiomas in the cavernous sinus, they melt away with the gamma knife. So you should never go there for them. They just evaporate with the gamma knife. Well, is that true, Dr. Pinsayed?
No, and thank you for the opportunity to be here to present the cavernous venous malformation of the cavernous sinus. These have been called cavernous angiomas, hemangiomas, or cavernous malformations, but basically they are part of one big group of pathologies, the dural, that can develop any part in the body. If they develop around the CNS, they can develop in the skull, in the soft tissue, in the skull, in the dura, in the falx, or in the tentorium, and in histology they look exactly the same. The cavernous sinus ones are particular because they are the ones who are first the most frequent dural cavernous venous malformation, and then they represent 2 to 3% of cavernous sinus lesions, which is not negligible. The differential can be tricky, and identifying the pathology pre-op is very important because the surgical strategy is a little bit different. And then just a quick review of this pathology, because it's not that frequent, with around 50 to 70 cases published in the literature. It's Asian descent, middle-aged female, that's the population where it happens the most. And then in natural history, it does not behave as the usual malformation. It behaves more like a tumor. So it grows inside the cavernous sinus, pushing, as you can see here, the nerves laterally, and then causing local mass effect and a cranial nerve palsy, headaches. That's how the patients present. Interestingly, it has been reported that this malformation will grow during pregnancy and regress after delivery. On imaging, the differential can be tricky, as I said, and the two big ones are meningiomas and schwannomas, so I wanted to quickly go through how it looks like on the imaging. So on the CT, it's a little bit hyperdense lesion. You can find some bony erosion, nothing really specific, some intralesional calcification, but specifically no hyperostosis like you would see with meningiomas. And then the MRI is a little bit more specific, so you will have an extradural lesion, well encapsulated as you can see here. The T2 signal will be very, very bright, that's a give. And then the other thing is you can see that the carotid has a normal diameter, even if it's circumferentially encapsulated, which is something that sometimes you frequently don't see in meningiomas. The interesting thing is the contrast enhancement. It's very avid, it's very strong, and it can be very homogeneous or heterogeneous, and it has to do with the dynamic nature of the lesion. So if you do a dynamic MRI, as you would do for a pituitary, you would see these have 30 seconds in between them. You will see this fill-in appearance that is characteristic of cavernous venous malformations. The angio is not that specific. It's 50% of the cases, mild delayed blush. And then the exam that's really helpful is the scintigraphy. It's 100% specific and 86% specific, sensitive, 100% and fairly specific, showing with technecium labeled red blood cells, delayed fixation in the cavernous sinus. But we're here more to discuss the surgery. So and specifically the surgery in comparison to other treatment options. As Dr. Al-Mufti was saying, gamma knife patients have been treated without even surgical, without pathology. And the results, we don't still have any long-term follow-up on the series. It seems to have some efficiency, but most of the patients present with bigger tumor because it's soft, and they're very young, as we said, middle age. So it's not the appropriate treatment for bigger tumor, young patient in the cavernous sinus. The tenets of the surgery are extradural surgery. It's an extradural tumor, so stay in the extradural space. Cranio-orbitozygomatic approach with an extradural cranioidectomy is frequently the way to go. The proximal control of the carotid at the petrous level, as we just said, saw with Dr. Sen, is a good thing to have. I would even argue that necessary. And then we carry on the middle fossa dissection as we just saw in the previous presentations, allowing to progressively find the pseudotumor capsule and do the resection while paying attention to the intracavernous carotid. So what are the results of the surgery? We have gross total resection 80 to 90% of the cases, and you can see in this literature review, a relatively recent one, that the extradural route is the way to go. And we have our own case series coming out soon. And a quick case this is how, the tumor displaces the cavernous sinus laterally, and then how you sneak in under to do the resection. So this is a case, 40-year-old female. She presented with right-sided facial pain, and her neuroexam was intact. You can see the classic appearance here with the normal caliber of the carotid. And this is a 3D recon from the inside showing the carotid encapsulated and pushed anteriorly and medially. And for the surgical video, after the COZ and the middle fossa approach, here we're freeing up the third division of the fifth nerve, allowing to get to the petrous apex, not the apex yet, but to the GSPN, and GSPN leading us to the Glasgow triangle to find the carotid. Placing a Fogarty balloon for the proximal control, and then we do the anterior cranioidectomy. I'm just speeding it up. And then we do the peel of the outer layer of the cavernous sinus. These tumors, these malformations, they grow within the cavernous sinus, and they push the nerves laterally. So we're able to dissect progressively the nerve V2, V3, and sneak under them. And you'll progressively see here the pseudocapsule of the hemangioma of the malformation. which is progressively coagulated and dissected off the other leaflets of the cavernous sinus, since the lesion can grow in any variable spaces within the cavernous sinus itself. So you can see here, the whitish area is like one inner layer of dura, and the malformation is progressively coagulated and dissected. I'm just gonna speed it up progressively. We'll see the ICA soon. Here it is, there. We'll see it better in another. And one important other thing is any bleeding from these type of malformation is more of a venous type because they are low flow malformations, so compression and hemostatic agents will control the bleeding. Here's the end, here's the tumor progressive, here's the ICA. So for the outcome for the specific case, the patient had only some residual partial V1 and V2 numbness. Her scans showed gross total resection, and the pathology confirmed the cavernous venous malformation. All in all, to remember from this rare pathology is that it's an extradural lesion, so do an extradural approach. It's not locally invasive to the structure, so it can be dissected of the carotid and of the cavernous sinus layers. And then it's a low flow malformation, so bleeding is manageable with compression and hemostatic agents. Thank you.
Didn't answer my question. They're saying that this melt away with radiosurgery, and there is no reason for you to risk the patient life and function and operate.
So the current response rate is around 50%, and the longest series are around 4 to 5 years. So we don't still have long follow-up on these malformations being radiated directly without surgery.
So let me get it right. The shrinkage is not disappearance, it's shrinkage.
It's shrinking.
50%.
50% of the cases.
50%. And over a period of time of...
The follow-ups for the series now, they're variable, but around 4 to 5 years, the longest one we have, I think. Okay. So we still don't know if it's the right thing to do. But again, most of the patients present with fairly large tumor lesions, as we just saw, and they're very young, so it does not seem to be appropriate.
Again, what meant with this session that the cavernous sinus, it's a neurosurgical territory, it's our home, it has a lot of lesions that we need surgically to operate it, and to do it, we need a training in this area. Dr. B.
I have a question. Thank you, Dr. Al-Mefti. Specifically, I have a question for Professor Krisht. You show such beautiful results, and I'm always inspired by your ability to redefine possible. But in the path to get to your current excellent cranial nerve outcomes, there's likely a learning curve. Aside from training, how does one deal with the psychology of facing the second or the third patient with a cranial nerve deficit that may not get better? Because it's a ubiquitous question, not just for the cavernous sinus, but for any high-risk surgery, for all of us in our psychology to overcome, to get better.
Thank you, Linda. And, well, training, lab, training, and watching. One of the most underestimated acts is watching other people operate. This is becoming really a problem because every trainee thinks that they can only learn if they do, which is completely wrong. And you have to see it done and done again. Now, at this stage, there is a certain way of dissecting these aneurysms. How you dissect them, usually I call it tangential dissection along the nerve, because you have to be, and it has to be sharp dissection. Now, there is something that I mentioned many times in my lecture, I call it metric anatomy. You have to know the anatomy of depth. You're dissecting the fourth nerve distally, you're close to the carotid. You don't dive too down. When you go to Parkinson's triangle, you can go further down and dissect it more. Now, what am I talking about? Anatomy. It's all anatomy. You have to go to the lab, dissect, and see it. There is no reason for you to have deficits if you can take the information that I have. You know, if you can take it and really go with it, you're going to do way much better than my first cases. I have done better because I've watched Dr. Al-Mefti also. And it has to keep progressing in this way. Now, the second most important thing after anatomy is do not think short term. Most people want to achieve the glory and be on the podium and everything in the next year and this year and be an expert. You know, some people do a skull-based fellowship. Next year they are the program director of skull-based in a place. It's a lot of wrong things. You have to plan long term to achieve. You want to be at this point in 3 to 4 years, be at this point in 3 to 4 years. You have to know your limits. I have no limits, but you have to know your limits. But those are things that can only happen if you see it. If you try to envision what I'm doing and try to go apply it, it's not going to work. It's not going to work. It's like I said earlier, it's easy to be a cook. You want to be a chef, you have to go through the whole kitchen and make sure how things are done. I hope I answered it.
Dr. Sen, I want to be sure that the message or my craziness is correct. You go with that beautiful endoscope and you resect the majority of that chordoma, so beautiful. But post-op, or if you get an intra-op, MRI, there is a piece at the petrous apex, lateral to the carotid artery, that you cannot reach through your endoscope, okay? No matter how good you are. Now, I strongly believe, and that's not what the practices I'm seeing, that you need to go back cranially for that lesion and achieve a gross total resection before you send them to radiation. Is that make sense to you? Because what I'm seeing, a lot of patients who have that piece left in there, oh no, you cannot have a cranial operation, it's very dangerous. This is from the cavernous sinus, you don't go there, your quality of life is gonna be disturbed. And these people send to radiation, proton beam or what have you, with that piece that's visible, and as you expect, the control is limited in years.
I think, at least in my practice, I would go back in.
I'm talking chordoma, not chondrosarcoma.
No, chordomas. Even chondrosarcoma, I would do that. I think that I give the patient the option, because if there is some tumor remaining somewhere, there is probably something somewhere else that I cannot quite see. That's why the volume of it, the starting volume is important. I look at the initial scans. So I will think myself, and I have to be honest with the patient, what is the likelihood that if I do this second operation, I will get it all, 100% resection. If in my mind I don't think it's going to happen, then I will tell the patient that yes, we can get from 85 to 95%, but not 100%. But in my experience and what I've seen is that if you can get 100%, that's where I have people surviving 20, 25 years with chordomas. But those are the people I did not radiate and I got the whole tumor. So I will look at it, I will tell the patient that there are risks with this, but this is what I can accomplish. It's the patient's life and function. I will lay it out to them, but technically, yes, we can do it. And I've done those. I've done endoscopically, then I've gone back transcranially. So that's the way I do it. Now, Ali, you showed amazing results, and what you showed, I'm digressing a little bit. In this day and age, Ali, how does one become as good as you are, considering how risk-averse people are? Hospitals don't want patients to be hanging around forever. And Gamma knife is a very, very effective treatment for many residual small meningiomas. How does a person coming up? Of course, I've been to the lab countless numbers of times. I have watched cases, I have watched Shaker do operations, I have watched Dr. Al-Mefti, I have watched your videos, but that path, you're showing somebody who's 30 years down the road. Morcos is showing somebody who's 30 years down the road. Al-Mefti is 40 years down the road. How does one arrive that with all the heartaches and heartbreaks to get there? Mike Lawton is sitting there. Everybody watches his fancy bypass videos and reads his books. Can everybody be like that? What is the path to that? In this day and age, when all these surrounding constraints exist, no resident of mine goes to the lab and does any dissections. I can guarantee you that. When Dr. Roten was alive, I asked him one day, Dr. Roten, how many of your residents go to the lab? He said, none. So we have a disconnect here. You're showing the pinnacle of cavernous sinus surgery. The path to that, how does one get there?
Let me get all the brain power in the room. Who will operate on meningioma and the cavernous sinus first? Good. Oh my God, this is my good. Now, who will then do partial resection and then give radiosurgery? Man, I love you guys. We need the discussion with a different audience then. In hemangioma, Jack, and you could lead that issue. You took a lot of them from the cavernous sinus. But didn't the radiation, radiosurgery, or purported effectiveness persuade you?
He's talking to me? Yeah, the ones I've removed are like, Atul Goel has a huge series of those. The ones I've removed are very large. We always go for a gross total. There were a couple I had to leave a piece on the nerves. I did radiosurgery, and actually in those, it's not gone, but it is stable many years. So yes, there is a good response, not a cure, but a very good response. Is that your question? Cavernous hemangiomas of the cavernous sinus. Is that what you're asking me? Or meningioma?
You're aware of the report that coming that radiosurgery is so effective that it melts the cavernomas away in the cavernous sinus.
Yes, yes, no. I do have that experience. I have 2 cases that it hasn't grown. It's not gone, but it has not.
So if a patient came in today with cavernomas, you tell him, go to the gamma knife, I don't need to operate on it.
The way I've done it is the pieces that I judged I'm going to hurt the cranial nerve if I keep going. And I left a small piece. The ones I've seen are big. They're not appropriate for radiosurgery. Yeah, that's what,
okay,
if that's
now,
what you're asking.
Yes, please.
I'm from India. We published a series of 17 cases of cavernous sinus hemangiomas operated and around 9 cases given gamma knife in 2017. The most surprising finding was, compared to meningiomas and schwannomas, the volume reduction in cavernomas of gamma knife is almost 80 to 90%. And that saw us do a paradigm shift from surgery to gamma knife for cavernous sinus hemangiomas, which are within the volume limitations of gamma knife surgery. So anything below 12 cc or 13 cc, we do gamma knife. But anything above 14 to 15 cc, we do surgery. So this is one of the few tumors which actually melts with gamma knife.
Yes, please.
I had a separate technical question, so if you wanted to comment on that, I'll wait. For Dr. Krisht and Dr. Sen, I remember a paper of Dr. Sen's from the 90s where he looked at the histology of meningiomas in the cavernous sinus and showed adventitial invasion of the carotid artery wall, as well as within the fascicles of the nerve. So Dr. Krisht, I'm curious, when you see these amazing things, are there some meningiomas you get to where you just say, hey, I can't free this up? Or is it a matter of getting better, or is this a biology problem?
So the first few slides that I showed, the last one before starting the talk, I mentioned that this is one of the few cases where when the tumor is around the carotid invading, you end up removing everything except around the artery. But when you look carefully at the anatomy, the pathologic anatomy, the overall majority, the tumor is behind the carotid because it starts in that cavernotentorial cave and grows widely. Occasionally, some cases, they go around it. In a young person who has a narrowed carotid and they pass a balloon test occlusion and very symptomatic, I'm going to cure this one. So I'm going to take the carotid because they passed the balloon test occlusion. I did mention at the end, the last frontier I have is to replace the carotid because there will be this subgroup. But over time, I realized that the carotid is not really as invaded. In a good number of cases, it is pushed anteriorly and the tumor wraps around it, unlike what was reported before. And I think in the past, with all my respect to all the surgeons, and understandably, they were cautious about it, and they found out that this is invading. However, in some subgroup, it does invade. But even in those cases, there is a good number of them that you can clean them. However, in the same way, you have to find the carotid in the canal and up towards the clinodal segment, and you have to follow it to be able to know which one is cleanable, which one is not. Most people were timid. They did not follow them. And then they ended up assuming this is the case. There are some invasions in some of them, you can tell. Usually in those cases, down way proximal in the petrous part, you can see the invasion there very early when you try to get proximal control.
But Dr. Krish, she's telling me cut off. But I have one last question. Dr. Al-Mufti, 98% control, 50% improvement of the pre-op sixth nerve policy, no other complications whatsoever, no CSF leak, no wind infection, no nothing. That's what radiosurgery could offer for that trigeminal schwannoma. How do you dare to cut me out? Where are you? Yeah, give him the microphone. You're happy there is no gamma knife people in the audience.
Yeah, for some reason, it seems that the trigeminal schwannoma incidence is in a much younger patient. That's certainly been my impression. I think all of the cases I showed, those were in people between their 20 and 40 years old. So there are oftentimes large tumors beyond 2.5, 3 centimeters at the time of presentation because the numbness comes late. So there's a lot of surgical tumors, and the surgical results, it's a very safe tumor to operate on. I mean, obviously, surgery, there's risk, but and I think the trigeminal problems with radiosurgery, you're going to dose all of the nerves, right? You're going to dose the whole ganglion. So I think there's some real advantages to resection.
Okay. Dr. Sultan, we're finishing, but one question for you. I'm working inside the cavernous sinus and the carotid ruptured on me. What should I do?
I think you pray first and foremost, but I think there are techniques if you have access to a C-arm or if you plan ahead of time. And Caroline has a wonderful video of that where carotid's ruptured. A balloon test occlusion, I think if you can sacrifice because of the collaterals, that's a good way. Otherwise, one of these covered stents or a bypass. I think there's a sort of a quick, medium, delayed ways of thinking about it. Carotid occlusion, stent reconstruction, bypass, and it all depends on the anatomy and what you see in the occlusion. Thank you so much for our session. I think we're going to take a quick break, a 6-minute break. There are vendors who have supported this in the back room, and we're also streaming this, so it's getting out to people in parts of the world that can't be here with us. So thank you all. We'll see you here in 5 minutes.
12. I got 12 minutes.
You do the time?
I got 12 for me. It's 12.
No, it's okay, but so you take care of it. Yeah. So I won't bother looking at the time.
We already have an adapter for
Here,
you.
great, okay. So I'm all set.
We would like to get started, please. You bring in your coffee, your cakes, and just so we try to catch up. So I was asked to introduce this wonderful session and to moderate it. It's hopefully one of those feel-good sessions. It's titled Triumphs. And I didn't pay attention if there is another session called Disasters, but probably there should be. That's the next one. But thank you for putting me on the Triumph one, eternal optimist that I am. And you gave me the wonderful assignment of introducing the topic of mastery. So that's a wonderful thing to talk about. And then I let the speakers tackle each pathology in turn and show us their mastery of it. I'm not connected. You guys see? Yes. Now I see it here. Okay. So I call it the art in the skill and the skill in the art. What is mastery? The tall man in this picture is not the giant, correct? The giant is the shorter man who has inspired mastery, legacy, skill, and art intertwined. Watch him operate in the Sylvian Fissure in the 70s. These are not sped up videos. This is how he operated, and no wonder he inspired so many. And we all need an hour or more to talk about this man, and I won't, but you know what I mean. Remarkable pioneer and remarkable inspiration. You cannot buy a textbook today of surgery without the word mastery in it. Everybody wants to write a textbook, how to master this, how to master that. But I remind the younger people in the audience this wheel of our careers. I'm renaming those names that you all know. I'm renaming it. You start blissful ignorance, then tortured ignorance, then forced knowledge, and hopefully you end up with the intuitive knowledge of the masters. But mastery is very rarely, if ever, a gift. As Michelangelo said, if people only knew how hard I worked to gain my mastery, it wouldn't seem so wonderful at all. Picasso said, learn the rules like a pro so you can break them like an artist. We were talking about those a little bit earlier with the questions. And I love this. The father of Taoism, Lao Tzu, said, I have 3 things to teach: simplicity, patience, and compassion. These 3 are your greatest treasures. It reminds me very much, actually, of Al Roten, this saying. Surgical skill. I'm moving to Houston, and this man, most of you should know, of course, from Houston originally, and Denton Cooley. I'm not going to use a neurosurgical example. I don't know what you were doing on May 28, 1982, but this man was doing 13 simultaneous heart surgeries, and of course he routinely did 13 to 20 a day, the days where you could run 4 and 5 and 6 simultaneous ORs. Not that it's necessarily the best thing, but clearly this Denton Cooley epitomizes mastery in cardiothoracic surgery. That's an operative schedule of his department at the time. But remember, of the first 20 cases performed with cardiac or cardiopulmonary bypass, 19 died. Remember, there is a price to mastery. Remember Charlie Drake's experience with VB aneurysms. There is Denton Cooley celebrating 100,000 pump cases back 20 years ago. Mastery in microsurgery means mastering the small, the sutures, the tiny sutures. But look, there are artists who actually do better than us, proud microsurgeons. Look at this artist sculpting here. Look at this phenomenal guy. Google him, Willard Wigan. He sculpted the Last Supper of Jesus inside the eye of a needle. And to give you a scale, this is one of the STA-MCA bypasses.
Look to scale, remarkable. So there are masteries in everything. You'll be happy to know, the neurosurgeons in the audience, that when they asked lay people on the street which surgeons have the best hands, neurosurgeons are thought of as the ones with the best hands compared to our colleagues. Bruce Lee said, "I fear not the man who has practiced 10,000 kicks once, but I fear the man who has practiced one kick 10,000 times." And indeed, that's how you do it. We're hoping that one day that mentee who is struggling to do a suture, to even grab the needle, can of course become as good and, more importantly, better than his or her mentor. Technical skill is only a small part of mastery. I have no time to go over these things in any detail. I encourage my residents at least to read this book, Mastery, from Robert Greene. These are the parts of the book that are important. I think one of them is deep observation. Another one is how to handle the 7 deadly realities. He talks about, I don't know a master at all that has any of these faults to any given degree. Envy, conformism, rigidity, self-obsessiveness, laziness, flightiness, or passive aggression. I don't think you can achieve true mastery if you have a significant component of one or more of those traits. I think I agree with him. I had many other things to say, but we're really short on time. But I'm happy to talk maybe to the young residents later about some other things they could read about that I think are very useful for us surgeons engaging in this career that requires quite a bit of resiliency and the flow state and many other things to talk about. But I'll stop here and I invite Nirav to come and talk about how is he mastering or has mastered AVMs. And 12 minutes, correct?
Thank you very much. Thanks for everybody for being here with us. The point I want to make today is AVM is a neurosurgical triumph. This is a collective triumph. Look where we came from. John Hunter described the first AVM. And great neurosurgeons would look inside and shriek and say, this is going to be a disaster, and they would stop because they didn't have the technical abilities that they then developed over time. I get to talk and work from the Brigham, where Harvey Cushing operated this AVM after radiating it. And in short, he said that was the wrong thing to do. The patient was left pelagic and disastrous, though he expatriated the AVM. But time moved on. Neurosurgeons got smarter. Cerebral angiography occurred. We could see it better. New results started to form, and we understood what is an AVM. It's not a tumor. It's physiology gone wrong, but beautiful. And in the microsurgical era with greats, Yasser Gill, when he came in Madison when I was a resident, and Sant, and Sugita. And these great folks have done something collectively through those disasters that occurred. Their information was passed on and improved. And we simultaneously learned more about the natural history of brain AVM. In order to achieve real results, we have to beat the natural history, not just ourselves. And then look at what we can do for the great surgeons who now have mastered these techniques, people who have talked in this symposium on their abilities to do this work. And I think I can say safely that at least grade 1s, 2s, and some 3s should all be operated. That is the right thing to do. These have excellent results because of people before us. But that's really not the point. The point is more about what we have learned collectively. This concept of mastery, it went through generations of neurosurgeons. And it fits with this book, that there's an apprenticeship model, residency and fellowship. that then as an early career neurosurgeon, there's a creative active phase, and then as masters who give us the techniques that we can then stand on. And I would just take a minute to say those techniques work. The arachnoid dissection, closing the arteries before touching the AVM. That's proximal control. It makes sense. Taking all the inflow and then sweeping those loops back into the AVM. And I will say training, our training, is a triumph of neurosurgery. It works. Residency, that apprenticeship model. I got lucky enough to work with some excellent neurosurgeons, some of them in this room right now. And as a fellowship develops the skill sets necessary to go out and be safe when you do neurosurgery. It was spoken earlier in the conference that how can an early career neurosurgeon achieve great results like Dr. Christ or 30 years down the road? Well, I think it's because once they have learned those skills, that mastery has been achieved. It can be passed on in a much less painful manner. And this is a paper we wrote on that concept, that early career neurosurgeons, having done a fellowship, can achieve good results in AVM surgery, and that tells us we should proceed and continue. Now, I will say, why am I doing this? I gotta tell you, this is the reason I'm on the planet. I love operating in the arachnoid. It is phenomenal. Who doesn't want to just jump in there? Look at this. You're going to help somebody, and you're going to do something beautiful that challenges you, that puts every last bit of energy that God made in your mind to the test every day to get better. What a great job we have. It's so fun, so useful. And you feel that these books are speaking to you about flow and meditation. Those are the moments in my life that I enjoy the most in the operating room. I'm sure all of us could agree on that. And then to do it and to help somebody, a connection that never would have formed had I just walked across the street and that person walked the other way, they wouldn't even look me in the eye. But now we're bonded for life. What a great job. And that this stuff works. These microsurgical techniques are useful. They can be learned. They can be passed on. This is such a straightforward example. How else would you do this AVM? You would close the artery, but you would do it first. You would dissect the arachnoid. There's no need to do anything else. It's a straightforward, wonderful operation that provides this 20-year-old medical student a cure. We should do that. And we can take those principles into the more complex, ruptured motor cortex AVM. Even just done on CTA, you know the targets. Close them without a catheter. I'm not against the catheter. I use it all the time, 50% of my business. But I think it's safer to close with a clip under direct vision. So this is fun. You turn off the clock. Tell your wife you'll be home whenever you're going to be home, and dissect the arachnoid. And the AVM gets softer and softer. And because it's softer, it becomes safer as you take each arterial input. Then going down into the deep white matter, bringing the loops back, not cutting them in half, but bringing them back to the nidus, and taking that ventricular feeder early in the operation allows then a safer resection from the motor cortex. And I'm not saying anything new. I may never get to say anything new, but at least I can transmit what we collectively have built over 100 years for future patients. You know, they get better, even motor cortex lesions. Ruptured AVMs, GCS3T, don't give up. These people get better. You can do it that night. You don't even need an angio because you don't have time to get it. Another ruptured GCS3T, young patient. Another one. Giant AVMs, they can be done as well, but I will just caution, without the embolization, you can get into trouble like in this one. So I don't want anybody to think just don't do it without embolization. I think it's AVM techniques that we have learned. But if we use the techniques, it will involve better and safer outcomes. So anyway, you have to keep working at getting better, because then you can avoid this. And she ultimately did all right. And then the craniotomy, those are techniques. How do we bring all these deep-seated lesions to the forefront in our face? Not not around the edges. This bilateral interhemispheric transfalcine window is a great way to do it. And we don't need to have embolization. Not that it's wrong, it just adds risk. At least in my hands, I can't do it for 0% risk. And I don't think it makes my long-term outcome any safer. So here's an MCA artery on the cortical surface. Now the ACA feeding artery, same thing. And now going to the opposite side for the PCA through the left-sided window. And once those arteries are all occluded, look at how soft the AVM is. Right? It's like you could push on it, you can move it around. Now it's not going to pop when we dissect it carefully out of the white matter. Even with the retractor on it, it's good. So that leads to a safer outcome. And harder and more complex, pushing the envelope. This is a complex patient to me because it's diffuse, it's large. She's 35 and 4 kids, and she wants hope. She wants a cure. It's a special patient that has that bravery. So we use everything at our armamentarium. We have the augmented reality, we have subcortical neuromapping, visual evoked potentials. It still took me 3 different operations to get it done because it was diffuse, and every time you get to the end, you think you're done, but you do an angio, it's still there, you go back. It's not free. Certainly there's a cost to these patients, but ultimately she's doing great and she's cured. Now I'll tell you, we talk a lot about physician burnout. 1 in 4 doctors is burning out. Well, I'm going to give you the cure. Enjoy the arachnoid, help patients. This is it. This is what I figured out. You know, we'll not get burned out when we help patients doing something we love. Now, embolization is going great. It has progressed over the decades. It is doing more and more for our patients. But I'll say it's not quite equivalent. Same with radiation. It is getting better, and it is not quite equivalent. So we have to continue. Why does it matter if we continue? Because we have patients like this guy. He's 20, he has a seizure, he drops out of college because he can't work, he has a work-study program, he gets embolized 6 times without any future. He just has this big rock in his head. Nobody gave him an option of surgery. You operate, they get better. Radiated, embolized, mother of 2. I found her in a homeless shelter. This is terrible. How she ended up homeless because of this disease that should be cured. That's why it matters. And then there's these patients who, because they're brave, like this woman, we take this thing out, and to skip the details, she goes on and decides to do right by the world and starts talking about brain AVMs and gets herself on the nightly news because of it. We have to spread the techniques, like in Dr. Biscaya's courses in Madison or our courses at the Brigham. You know, I feel that's a duty because someone gave it to me. At least I can help spread those techniques. And even more importantly, maybe in environments where they don't have a choice. I am very proud of our fellows, Dr. Sultan and I's fellows. We've gone on and built a stroke center in Puerto Rico because of that great work. I think that's awesome. And then this is so fun, to go to a place like Paraguay that I got wonderful opportunities to go and do microneurosurgery in this environment. They don't have another option. There's no embolization, no radiation, and you can use these exact techniques that these master neurosurgeons have given us to go forward. And I'm going to skip to the end. They are learning how to do it on their own, so it's sustainable. But I give you one last example. This 20-year-old in Paraguay ruptured twice, deep interventricular AVM. It's still considered difficult, but if you can do it with these techniques, it worked out okay. There's an ACA feeder, PCA feeder, no catheters, no embolization, and we do the case. Just like we've been talking about, taking all the feeding arteries deep in the ventricle and then taking it out. And I think this is the point. This is the triumph of microneurosurgery, neurosurgery of AVMs. That this patient, that we can travel down to another place and give her a cure, that's a triumph. Now, I will say there is so much more to do. I am not triumphant. I cause complications that I will never forget, and it is an awful feeling. And I don't ever want to do it ever again, but it's going to happen. So there's so much more to do. And then there's the inoperable cases. What to do about them? Maybe we can sensitize the endothelium for better radiation. Maybe we can endovascularly cure patients as we push the envelope and the skill sets get better. Maybe we figure out with laminar wall shear stress which AVMs are actually going to rupture. But there's so much more to do. But I'll leave you with that I believe this is one of our greatest triumphs as a collective specialty of medicine, as physicians, that neurosurgery has done a great job with. Thank you.
Thank you very much. Of course, we're leaving the questions and the discussions till the end. My great pleasure to welcome Monami Abdel-Samad Al-Wahabi, who's going to talk to us about mastering aneurysms.
Thank you.
Thank you for making the transatlantic flight.
Thank you very much, Marcos. Thank you, Professor Ali, Professor Mefti, for the kind invitation. It's for me a pleasure and an honor to share with you our experience and how we can assure mastery by, of course, a long process, learning from the masters and also developing the technique and also reviewing the indication and the results. So, okay. I am from Rabat. Neurosurgical department for Rabat has a very long tradition of microneurosurgery, especially in aneurysm. Since the introduction of the technique by my mentor, Professor Khamlichi, in the 80s, become a routine neurosurgical activity in the department, despite the use of endovascular from the 2005, and we are at least operating 1 to 2 cases per week from that time. So I am very pleased to come back to Boston. I spent 2 years here, and then you see how the Brigham was at that time. And I was, by chance, I have attended one meeting on brain aneurysm. It was 1991, and you see that debate started very, very early in the 90s. And still 30 years ago, we are still in this debate, which kind of management should we offer to our patient, microsurgery or endovascular treatment. And I think Dr. Morey was also there in this meeting because his name was in the program. So this discussion, as I said, start very early, but the real paradigm comes with the ISAT when it shows that the results of endovascular are better than the microsurgery. But two decades later, we found that the debates continue to be there. And the reason for that since the publication of the ISAT, it has many other observational studies and 3 other randomized studies that have shown different results. This is one reason. The second reason is that in our clinical practice, daily clinical practice, when you reviewed some data from many departments that have a high experience in neurosurgery, in micro-clipping neurosurgery, you found that the results are different from what has been found with the ISAT. So to answer this dilemma and to discuss this, we go for review our experience. This is based on more than 1,000 cases that have been treated in the department. This is an institutional experience. And to go for mastery, you have to define the selection criteria for the selection. One of the more difficult and this debatable question was, what kind of patient should go for microsurgery, what kind of patient go for endovascular. And this is our strategy. We go for a patient-tailored treatment protocol. And you can see this is the cases we consider better candidate for clipping. Young patient, dysplasic and wide neck aneurysm, MC aneurysm. what we consider to be better candidate for coiling, most posterior circulation aneurysm, and the one that can be treated either way and with good results with those. And we go through this patient. There is some illustrative cases, and the first one, how we can use microsurgery to treat some cases that has not been treated, or at least proposed by our colleague, considering not suitable for endovascular, and this is the case of dysplasic right ACOM aneurysm, was considered not favorable for coiling, and with subarachnoid hemorrhage WFNS grade 2. And with microsurgery, we can preserve the perforating arteries, and we can use some fenestrated clip to make a remodeling of the aneurysm and the artery without sacrificing any perforating arteries. And you can see here, this is very helpful. The fenestrated clips in this situation are very helpful to assure this exclusion of aneurysm. The second case is a large rupture wide neck aneurysm, ACOM aneurysm, which was considered not suitable for coiling. And in this situation, we go also for microsurgery, and you see here, we go for left terminal approach and resection of part of the gyrus rectus. And then we go for dissection, the AW1, and then the A2. And very important, after having posing temporary clip, we go for the sac, dissecting the sac from the surrounding tissue, and be sure that with the first clip was put on the sac, and sorry, this is sorry for that. Okay. And we controlled the ICG, and we found that our clip was not good position, so we repositioned the clip to be sure that the both A1, A2 are free. A third case is a case that presented with dysplasic wide neck and calcified right MCA aneurysm, and we go for surgery. This case was discussed with our team. It was not considered for embolization, so we go for microsurgery clipping, and then after dissection of, you can see here, the sac, the neck. We dissect the neck free from the surrounding arteries, M2, and then make some bipolar coagulation to shrink the sac and to prepare for the clipping. Okay, and that's it. The third patient presented with large carotid ophthalmic aneurysm with mass effect on the third nerve, on the optic nerve, and we discussed the case, and we consider that it is a good case for surgery, and we go for first anterior cleidoctomy with then we use a temporary clipping in the neck for the carotid. During the dissection of the sac, here we prepare for the neck of the aneurysm, and then we decompress the nerve, and we resect the sac to be sure that the total decompression has achieved. I will go now for last two cases, maybe you have debatable. This is a very young, 30 years old PO who presented with basilar trunk aneurysm, and we discussed with our radiologist and the interventionist. They couldn't afford a solution for the patient. We were obliged to go for micro surgical clipping, and you can see here, this is the dissection, and we arrived to the vertebral basilar artery after opening of the Sylvian fissure, arterial the lamina liquis lamina membrane. And then we can see here the aneurysm that has been clipped, definitely. The last case also is a vertebral basilar artery trunk, who we discussed also the case with our colleagues, and it was not possible for them to go for coiling. So the neurosurgeon should be prepared for even some time to go for the vertebral basilar arteries, and this is very important for the patient. So we dissect the vertebral artery, we put a temporary clip, and this is, we remove temporal clip. We already positioned the clip, and then we make aspiration, needle aspiration, to be sure that it was completely excluded. And that's it. And this is the post, you can see the post-operative angiography control. So these are the results. You can see when you compare the two group, coiling versus clipping in our practice, you can see that there is no difference. And I want just to go for that, so to one or two slides, that what is not questionable, that that is clipping is superior to coiling regarding obliteration rate and risk of recurrence, and that endovascular techniques have still many limitations and are more costly than clipping. And also I think that the debate what we had this morning about coiling versus clipping should be ended. I think we have to move to a more patient-tailored treatment strategy should be adopted to get mastery in both techniques. So this is my conclusion. The results in our study and many others have shown that in daily clinical practice, both clipping and coiling yield to similar good clinical outcome. And clipping is still the best treatment option in 50 to 70% of rupture aneurysm. And the patient-tailored treatment should be proposed. The clip is dead, no long life to the clip. Thank you very much.
Thank you, Abed, very much. Very nice presentation, thank you. And next, Bin Shu from China, who will dazzle you with the number of bypasses he has done. It's an unimaginable number. By being here today, probably 10 less patients are having bypasses back home. So I'm sorry about them, but that's right. So
okay, thank you.
Can you see it here?
Thank you, dear colleagues. I come from Shanghai, Huashan Hospital. Actually, we have a lot of Harvard elements in our hospital. The first building and the East Campus was all designed by Harvard University. And last year, we have more than 15,000 operations in our department, and more than 4,000 gamma knife and cyber knife cases. So in terms of the hemodynamics, we have three types of bypass surgery. The first type is blood flow replacement, normally used in complex aneurysm, square-based tumors invading ICA. The second type is borrowed flow from a neighbor artery, which is an ICIC bypass, normally used in the A2 or M2 aneurysms. The third type is blood flow augmentation, used in the myomer vasculopathy and atherosclerotic occlusion of ICA or MCA cases. So this is normally we use these three types of donor vessels the saphenous vein can deliver most blood volume to the cortex, and the second type is the radial artery, and the most used was superficial temporal arteries. The first type is blood flow replacement. This is a cerebral revascularization for recurrent nasopharyngeal cancers invading internal carotid artery. So this is a tailored bypass strategy for ICA sacrifice. The balloon occlusion test was routinely performed. If the balloon occlusion test was passed, which is there's no neurological deficit, we will do the enhanced balloon occlusion test, which means the blood pressure decreased 30%. If the patient still can tolerate very well, this kind of ICA can be sacrificed directly. If the patient have some symptoms, we will do the bypass. And for the treatment of skull-based tumors invading carotid artery, we have 4 kinds of blood flow replacement: the maximum flow bypass, high flow bypass, medium flow bypass, and the low flow bypass. So this is a maximum flow bypass. Both ICA was invaded, so we should replace the blood flow for both ICAs. Before the surgery, we do the balloon occlusion test. You can see the outcome was quite good. So we have the chance to do the one-side bypass to feed the both hemisphere. So we just do the ECA saphenous vein to M2 bypass combined with the 2 STA M4 double bypass in the left side. After the bypass, you can see the 3 bypasses feeded the whole brain. The second type is the high flow bypass, normally use saphenous vein. It can be replaced the whole hemisphere's blood flow immediately. The second type is the medium flow bypass, normally use radial artery. It can be replaced the MCA territory immediately. And the fourth type is the low flow bypass, normally use STA MCA double bypass. So replaying the main part of the blood flow of MCA territory. So after the bypass, we should treat the ICA, use coils combined with onyx. So we should sacrifice a long segment of ICA, so then the ENT doctors can have a very long safe zone to resect the tumors. So after this kind of treatment, the 3 years survival rate from 15.7% increased to 100%. So I also tried some new graft artery in some selected cases. This is a right GEA. So this is the right GEA. You can, it can be supplied very long segment. Mean length was 22 to 29 centimeter. The diameter for the proximal to distal is 3.3 to 1.3 millimeter. So it's a very useful graft. So this is after the bypass. You can see the blood flow was all patent. So actually, we can also use a progressive clip to make the blood flow even increased after the bypass in 7 days. This is a typical Silverstone clip. So the later one is designed by myself. So this is a use of the progress clip. So the ICA was narrowed around 70% at the first. Then in 1 week, we will achieve the totally occlusion of the ICA. So you can see after this kind of treatment, the double bypass was all patent, and the ACAM and the PCAM was all increased. So now the patient tolerated the bypass and the ICA sacrifice very well. The second type is borrowed flow from a navel artery. So normally it's A2 to A2 or M2 to M2 side-to-side bypass. But the main concern is whether the distal cortex can tolerate the temporal occlusion of the blood flow during the anastomose time, and whether the blood flow from one proximal vessels is sufficient after being allocated to the two distal vessels. The third type is the blood flow augmentation, normally used in the monomer cases. So for the ECA branches, we have 3 layers who can supply the blood flow to the cortex. The STA, or post-auricular artery, or occipital artery of the scalp, deep temporal artery of the temporal muscle, and the middle meningeal artery of the dura. So I always performed the combined approach, STA, or post-auricular artery, or occipital artery, to MCA, or to ACA or PCA territory bypass, combined with encephalodural myosynergesis. So we use all the 3 layers donor arteries. This is the individualized design of the skin incision, bone flap, dural, and the targeted bypass. So this is different layers of the deep temporal artery, middle meningeal artery, and STA. This is the individualized dural flaps. And sometimes we use this technique, I call this Chinese spring roll, to achieve the hemostasis of the blood bleeding from MMV. And at the same time, we can keep the patency of the MMA. The stomas are located in the ischemic area, but not the area for totally infarcted ones. So this is only 0.4 millimeter donor artery. So the delta P was quite high. So I also tried some new techniques, 3-dimension DSA guided keyhole direct bypass. If the MCA network was quite good, which means the Suzuki early stage, and we can choose the indications for the early stages of moya, and this is the first type. The recipient artery was just beneath the donor artery. So this is a post 1 week. We can see the MCA territory was totally filled by the STA, and this is a type 2. The same result, you can see the STA increased in size and feed the whole MCA territory. So this is a new set of single-arm micro-anastomose instruments, also designed by myself for the deep anastomose. So the underlying logic of the hemodynamics is the Poiseuille's law and the Bernoulli's principle. You can see this is a flow 800 after the bypass. You can see a lot of phenomena of the Poiseuille's law and the blood flow change. So we measure the 7 precious parameter in the monomer case. So this is the result. The mean delta P is around 22 centimeter water column. So it's just like a little waterfall. So hemodynamics are extremely important. This is my personal experience in bypass. By now, I have more than 11,000 bypass cases, totally in 112 hospitals in China and India. So this is, in some cases, we can achieve the total cure of the Moyamoya disease, like this patient, but not every case. So we still have a long term to go. Thank you.
Thank you very much for this excellent tour of this whole complex topic of bypasses, and the hemodynamics are always very interesting. Next gives me great pleasure to invite Mustafa Bashkaya to talk about brainstem cavernoma. Mustafa many years ago was in Miami, and it's fantastic to see where you have achieved and where you have arrived, Mustafa.
Hello. Thank you, Dr. Morcos. Thank you, my brothers Ali and Nirav, and my sister Linda. And thank you, Dr. Al-Mefti, for leading this symposium. It's wonderful to be back here. So Nirav asked me to speak on the triumphs in brainstem cavernous malformations. And in 12 minutes, I don't know how I'm going to do, but I have no disclosures other than loving the microneurosurgery. And since I'm, as you notice, I'm vocabulary constipated person in English, so this is my presentation. Surgical treatment of brainstem cavernous malformation is the only way, and is always ends up in the victory, right? I am done. Thank you. Bye. So brainstem cavernous malformations, natural history is bad. So I think these should be treated aggressively, especially patients having symptoms or repetitive bleeds. And in some cases, even if you sense that it's going to be a problem in the future, you should be more proactive and tackle these lesions early. What are the treatment options? This is the only pathology in this session we are talking about hasn't been contaminated yet by the other disciplines. So surgery is the only option because you eliminate the pathology like every other neurosurgical procedures. Once you eliminate, you can achieve the cure or near cure. Yes, if it is not reaching the brainstem peel surface, you can wait in some of these cases, but I'm going to show you a case where I waited and it didn't result in good outcome. And timing, I like to do it after the last bleed, next few days to 2 weeks, because after 2-3 weeks they become very contracted and fibrotic, and it's very difficult to remove them, especially if they bled in the past multiple times. And rarely in some cases you may need to do emergency surgeries for these brainstem cavernomas. Goal is complete surgical resection while preserving the function and the normal anatomy, and you have to study the anatomy. I mean, there's no other way. The main principle in brainstem cavernoma surgery is getting access safely. Technically, removing these are not that challenging. Surgical approaches, and people talk about the brainstem safe entry zones. We studied that. These are the cadaveric brainstems we isolated, and we simulated the surgical approaches in 12 proposed safe entry zones. And we used the DTI, everything to get the measurements to see how we are close to the nuclei and the fiber tracts. 1 millimeter this tract, 2 millimeter that nuclei. It is not safe. Believe me, there is no safe entry zone in the brainstem. Surgical approaches, transcavernous, retrosigmoid, all the approaches you use to get the access to the posterior fossa pathologies, in particular brainstem. And two-point method described by Dr. Spessler. Since he's not here, I can't speak. So it is good most of the time, but not every case this is the good method of choosing the right approach. Sometimes, especially in the floor of fourth ventricle, you may want to choose the longer and more the approach that you may need to traverse the normal brain, because floor of the fourth ventricle, I don't think there's a safe entry zone. And a couple of few case examples. This is the case at age 5. She had 2 surgeries. Retrosigmoid seems like a retrosigmoid approach, and recently presented with this picture. No question, this is a perfect case in my mind for retrosigmoid, redo retrosigmoid. And we extended their approaches 43 years ago. They did this surgery, and she doesn't even remember the name of the pathology. And it's scar. You have to go through a lot of scar and arachnoid dissection, like you are doing any kind of cerebellopontine angle lesion. And you have to respect normal anatomy as much as, and you notice, first thing I noticed, they were there 2 times. So patient couldn't tell me what kind of surgeries she had, but what kind of pathology, family didn't remember. So this is coming close to the basilar artery and its perforators. So you need to be very careful. And any technique you use to remove the tumors or AVM or aneurysm or anything, you use those techniques, mostly sharp dissection, and then getting around it and removing the whole thing, one piece or multiple pieces. Good thing about cavernomas, you can do piecemeal resection. So usually the bleeding is not the issue. We start seeing the basilar artery there, and its perforator is going to be very close to the cavernoma. But take your time. Like Nirav said, this is the most sacred time between you and the patient, and enjoy this moment. Enjoy the arachnoid, enjoy the PIA, and get the good results, and we remove the rest in one piece. And believe or not, this patient went home day 2. No new neurological deficits. Subjectively feeling better at day 2. She was hemiparetic, and she's doing much better after the surgery. So not only preserving what you have, but making the patient better, hopefully, with your surgery. So this is the case. I waited with that 2 bleeding rolls, right? That 2 bleeds. You wait until it comes to the surface, and after million bleeds, it came to the surface, but patient became incapacitated. So then you ask yourself, why did I wait it? So, and now this is another case. It's straightforward, comes to the surface, and then this is the case to show you the importance of preserving the dural developmental venous anomaly. You see right in the center, but you mobilize the structures like you are doing any other surgery. You mobilize the artery first. You mobilize this developmental venous anomaly, or whatever you call it, and preserve it. It's a good case to demonstrate, because right in the surface, most of the time in the videos or real time, you barely see these venous anomalies, and then you think you preserve or you take it. But this is the case. So at the end, everything should be untouched. Normal anatomy should be preserved, and pathological anatomy should be taken out. And this is the way it should look. And this is the case showing that multiple bleeding episodes and this experimental studies. This patient was subject of trials of beta blockers. That trial, this trial, and basically he was subject of his wealth. He traveled all around and, let's try this medication, let's try this, let's try, and suddenly became densely hemiparetic, unable to walk, unable to eat. And we know that this is going to be very fibrotic tissue, because we allow cavernous malformation to bleed multiple times, recover, came back again. And this is a good anatomical variation showing the arcuate foramen. So you need to mobilize to get a good angle from the far lateral approach, and then the rest is arachnoid dissection. And arachnoid, creating windows between these neurovascular structures, getting to the ventral aspect of the brainstem. And then once you get it, you visualize you see the cavernoma right there, and entrance, recent evacuation of the recent hemorrhage. The rest, this didn't come easy like you see that brainstem cavernomas nicely pulled, everything comes in one piece. I spent 2 hours to get this piece by piece because it was so fibrotic and stuck to the normal brainstem. And as you notice in the pre-op MRIs, this is very ventral. You are right next to the corticospinal tract. So finally it came out, and approach worked very well. Surgery at the end looks good. And immediate subjectively feeling better after surgery. And improve over 2 weeks to the near normal, and now he's normal. And another case to demonstrate this, I approached this transcavernous, Dr. Krish, so because I've watched him million times how he does the transcavernous approach. I had to do a little bit drilling of the Petrus Apex 2, but we removed it. So patient again, subjectively feeling better after surgery and improving over weeks. Very recent one, 3 days ago. This patient, 2 bleeding episodes. How are we going to approach this? Very straightforward paramedian supracerebellar approach, complete resection, no neurological deficits, continue to have subjective diplopia. And you see this. Do you see any damage here in the cerebellum or anywhere? Emergency cases. So for some reason I encounter these gigantic emergency cavernomas, and this is the case. It became comatose, quadriplegic, everything. And then we did the surgery. 6 months later, he got married. Normal. Why should we wait? You already have a fresh hemorrhage there. And another one, this considered inoperable brain tumor in California, moved back to the Wisconsin, and more episodes considered inoperable. Straightforward, and I think I knit out and I did this. Emergency case in the middle of night, that's okay. I mean, we are neurosurgeons. We don't have to wait next morning. So, in conclusion, surgical treatment of brainstem cavernomas is the only way. Eliminates the pathology, eliminates the bleeding, multiple bleeding risks, and increases the chance of recovery from pre-op neurological deficits. And anatomy is correct, helps us to correctly localize the tumor, choose the correct surgical approach. Khan, do you know whose dissection is this? 3D anatomical dissections of the brainstem and vertebrovascular system, 1953, performed by Yaşargil in Zurich. 400 hemispheres he dissected. So, like Dr. Chris said, you hear, you forget, you see, you remember. When you do, you understand, but don't start doing these surgeries in real time, in real patients. Go to lab first, learn, and then start doing it. Thank you.
Thank you, Mustafa. Beautiful collection of cases and philosophy on brainstem cavernomas. Now my pleasure to invite Ray Turner to talk about endovascular frontiers.
Thank you. I'm glad you guys pulled my, I call it the goon picture. You know, they just don't know how to take good pictures down in South Carolina. This will be a little bit different talk, I think what you've been hearing. I've been really fortunate for a long time to been able to partner with industry to bring a lot of technologies to market. And so, Dr. Al-Mefti, I apologize, but I got a pretty busy slide here of all my disclosures. It's important to know I am Chief Medical Officer at Siemens Healthineers. So anything that has to do with angiography or robotics also falls to me, and I've been fortunate to have a lot of great partners over the years. And you know, I was out there with my Brazilian brother Ricardo and Dave Langer, and Dave brought up like, hey, do you guys still do that Charleston meeting? And you know, this was a great meeting because we used to get together and just talk about problems. What problems were we having? And how can we potentially solve those problems? And it was just really good camaraderie. I think like what you see a lot here, you know, with the different families and, you know, what Dr. Krish is putting out and trying to help people get better at surgical dissections, right? And just solving the problems. And Dr. Hughes pointed out, like, he developed a couple devices to make his bypasses easier. And, you know, a lot of the stuff in the world of endovascular goes back to Dr. Murray and, you know, and his colleagues in France in getting us to where we are. So I'm going to talk a little bit more about hope now and possibilities. And maybe you guys in the room will hopefully realize that we're no longer vascular people, but we're also really starting to expand into other areas. And so I'm going to try to give you a little hints of, I think, where things are going over the next 5 to 10 years. This article is really interesting. It's the first time I really thought about the fact that maybe we should be, you know, we are no longer just doing vascular stuff. Right now we're starting to move into trauma. We're going to start moving into these other areas. You know, and this was, you know, really the first decent series published on middle meningeal artery embolizations for the treatment of subdurals. And you fast forward 5 years, this was 2018, now it's 2023. We've already completed 1 study. We've got 3 studies currently enrolling. And, you know, our industry partners have invested close to $12 million in trying to see whether or not we can achieve better outcomes with embolization with the treatment of subdural hematomas. And so I don't know if that's good or bad, but this is our reality, right? You know, when I trained, you know, back in the day, I think I did 7 ischemic strokes over the course of a 2-year fellowship, and now I feel like that's all I ever do is ischemic strokes, right? And so you kind of have to roll with the punches. And so the first one I just want to talk about is venous disease. And if for the open vascular people, think about, are there open solutions that you can provide? This doesn't necessarily have to be endovascular answers to all this stuff, right? And so, yes, we know about the headaches and pseudotumor. We've been doing that for about a decade, right? But pulsatile tinnitus is kind of the newer thing. The French have been doing it for a few years now. It's starting to really hit mainstream in the U.S. You've got a pretty decent prevalence of 1 to 3 million people. And it turns out it really is, in many patients of vascular disease, there's some sort of stenosis or disruption that's causing turbulence. And, Vitor did this great paper kind of looking at, the flow around some of these arachnoid granulations or these, areas of narrowings. And then what happens when you can treat and how you can restore laminar flow and eliminate some of that turbulence that these patients are starting to hear. But when you think about the treatment of it, right, a lot of it's been just medical management, or we've been doing a lot of things off-label, right, and just essentially taking a carotid stent, trying to figure out how to get it up around all these turns and opening those vessels up. There is some data to support the stenting, right? We're not completely crazy on doing this. This is a case out of the guys at Cornell, 42 patients, that Athos did and his team, that show that they can actually get good resolution of symptoms. And finally, we've got companies starting to invest money in developing stents specifically designed for the venous system to go around the bends, maintain the luminal patency, but eliminate that turbulence of flow. And Vitor did an early experience of 13 patients over the past year or so, up in Toronto, where you see he actually had good results. He placed 15 stents. He had the angioplasty, couple them to eliminate some of the narrowings. But, other than having some headaches in 2 patients, he had 100% resolution of the pulsatile tinnitus symptoms in those patients. And so when you look at quality of life metrics, they all start to improve in these patients. And it's just really, it can be a very debilitating disease. And so the venous system is something that we're really starting to explore. And it's interesting to understand where can we go to in the brain and what diseases we can kind of go after, which kind of leads me to how do we get there, right? And so Bond had all these really cool toys, right, that could actually, right, like the injector seat and everything, right? So steerable technology has been around a little bit, quite a bit in the cardiovascular space. What's one of our challenges is the sharp turns we've got to make in selecting vessels, right? And so, this is from the guys at Rothschild. This is an example of using shape memory actuation and the properties of nitinol to be able to get these devices to change on the fly. And that's like a really cool video, but here's the more practical applications, right? You've got these tubes or these wires, and now all of a sudden they start looking like catheter shapes that we're used to dealing with. And they can change on the fly, and you can change at multiple different points along those catheters or the wires. It's not just in one space. And so here you can imagine, how that can help us better access the supravasculature and move our way through the supravasculature. And there's other companies like this out there, like Bendit, Rapid Medical's working on some of these things, just trying to make our lives a little bit safer, a little bit easier, give us a little bit better outcomes for our patients. And so you see here, you essentially are attaching this at the handle. Let me see if this video will play. And then you can actually start to actuate the devices, and you can see it here in the fluid column, being able to actuate it and actually move it in 2 different dimensions at the same time. And so Michel Piotin and his partners at Rothschild did the first cases of 10 patients, successful in all the cases, and it's really just about helping to navigate up past some of these challenging areas and decrease the risk of thromboembolic complications or the risk of time in these cases. And so skipping ahead, they're now expanding to 10 centers over across Europe and 100 patients to try to get their CE mark from the notified bodies. We also can probably teach you some new drugs, old dogs, new tricks, right? And there's a lot of things kind of, as you know, we've done a lot around flow diversion over the years, with the healing response of all this stuff. And it's all about kind of neck coverage, right? And we've got intrasaccular, we've got endoluminal, and there's some newer stuff coming out over the next probably, I would say, 2 years in the US. This is an example of one. This is the Nautilus device. And think of this as like it's a coil. It behaves like a coil. It feels like a coil, but you basically are deploying it like a disc and letting it seat into the aneurysm, and then you can come back up and put more coils in there, and it locks it in place. And it gives you much better, tighter flow diversion at the neck of these aneurysms than what we're starting to see with webs and some of the other things that maybe are a little bit more difficult to conform to all these aneurysms, because we know the best aneurysm for a web device is the aneurysm that is shaped exactly like a web device, and that's very uncommon. And so no need for dual-ended platelets. These can be used in ruptured aneurysms. And you can see with these things, it's got the potential to give you some progressive occlusions. Here's an ACOM aneurysm. You can see in the middle, this is their immediate post-treatment, and then this was their follow-up. You can see that healing response you're seeing because of that flow disruption that's happening right at that neck of that aneurysm. They did first advanced studies in Japan with Dr. Sakai, and then also down in Colombia. They are in the process of doing a US study right now. They did a European study of 30 cases, and you can see that they're targeting not just really wide-necked aneurysms, but they're also going after ruptured aneurysms in these studies. And the results have been core lab adjudicated, 87% immediate occlusion rates, Ramon 1, Ramon 2, and at 3 to 6 months, a little bit more progression, 94%. And so really exciting to see kind of what people are trying to come up with to help solve the problems that we don't have necessarily great solutions for right now. And so 4-year follow-up on the Japanese patients that were done in Kobe, again, no retreatments, all remain good neurological status. And so this is the US trial that's currently ongoing. This is the first patient they treated in this study. You can see here, really nice results on these patients at 1 week follow-up. This is the 5th patient, literally just being done last week in this study. And again, it's exciting to see the new tools that are coming, right? But then you kind of get to the stuff that's like kind of science fiction stuff. And I don't know if this video is going to play with sound. So I'm just going to skip ahead. Synchron's been working on this concept of listening to the brain and then translating those things into signals that we can actuate. And so these are stents that are going in the venous system. They're typically placing them, as you can see here, using functional MRI for locations. But these are really incredible. This is the first patient that was treated down in Australia, and he's using his brain to click basically like as if we were clicking on a mouse. And he can actually move things around on these screens. He can open up applications. He can actually start to type. He can actually do home automation controls. And a lot of it is all done through these, the ability to kind of teach the brain what does it feel like to not just click a button, but also click at different amplitudes. And it's really fascinating where they're going with this stuff, and how can that really bring things to that next level and open up the doors of functional aspects of what we do, right? Can we use this for amputees? Can we use this for people that have difficulties communicating? Huge opportunities with some of this stuff. And so again, this is starting in the U.S. The U.S. feasibility study. It was done at Mount Sinai. They were able to complete it. And then lastly, you can't put me on the stage without me talking about robotics and where things are going. And so this is an example of the first approach at doing an endovascular case in a pig from 100 miles away, and they successfully deployed a coronary stent in this case. We've learned that we can do this stuff literally over the public Wi-Fi, which is amazing. We don't necessarily need truly dedicated high-speed fiber optics. Our infrastructure's in place. In India, they went ahead and they did 5 patients in coronaries, and now we're moving more into neuro. But not only are we able to do these things from a distance, but this is a video of a human trying to get across a high-grade stenosis and trying to find their way through it. But we can also teach the machines to do it. And so as that person's twisting and turning and putting forces on the wire, we can record all that stuff and then let the robot do it if we can teach the robot to do it, and look how fast this thing goes across. So really, really exciting how we can take learnings from the automotive world and start to apply them in our medicine world and healthcare to teach things, how to do things and potentially do them more reliably and predictably than perhaps we can. And we talked a little bit about health economics, and we've been looking at this. And it is actually health economically viable to do this in a cost-effective manner, at least in the U.S. system. And so, with that, I think as we continue to see development of, our computer power and connectivity, the reality is it's like what I did in training, I no longer do, and I can promise you what we're doing today, in 5 or 10 years, it's going to be like being at a history museum. So, and with that, thank you.
Thanks, Ray. Very exciting things ahead. Thank you for this great review of all that. And last but not least for the session, Linda the Hummingbird will talk about intraaxial tumors. And then after that, hopefully there are a few minutes to ask a few questions of the speakers. We'll see.
Should I use my adapter? Oh, great. Thank you. Thank you so much for the opportunity and the honor to celebrate intraaxial tumors in this group. I have to say it's not completely by accident that the last 5 talks were on vascular, because usually tumors, specifically that of malignant tumors, are often, surgery for them are often viewed as a drop in the bucket against the biology. But yet, in serving a cancer center, I strongly believe that neurosurgery plays a vital role in improving both the quality of life and the quantity of life of patients with intraaxial tumors. And that intraaxial tumors are the benefactee of all of the amazing developments in innovation, technology, and technique that we've just heard about today. And so we do this, of course, on the foundation and the road that the decades and centuries of anatomy have paved for us. But in individual patients, that map of that road comes through imaging. And specifically these days, whether it's by structural imaging, easily accessible imaging, there's probably an MRI at every other street corner, certainly at least in Boston. And we're able to see more and see more in vivo in the intact patient. As you can see on these examples, the white matter null tracts highlight every possible cortical spinal tract, optic tract, fornix, whatever one wants to see. why that MT2 RAGE floss protocol gives new granularity even to the parts of the thalamus. And so we can then apply that to fundamentally infiltrative tumors, like here a multifocal glioma. In a patient who comes with auditory hallucinations, we're looking at a regular T2, I might think there's 3 patches of tumor, one in the left posterior sylvian fissure, one in the posterior superior temporal lobe, and a wedge in between. But if we just apply a slightly different sequence with published protocols, you can now appreciate that there's 2 areas of nodular tumor and 1 area of infiltrative tumor. And I do tend to believe that nodular tumor almost anywhere in the brain is safe and accessible to remove and to get to. And so that, of course, the infiltrative area corresponds to the area of language activation on functional MRI and allows us to plan better safely to address these. Furthermore, even without the advanced imaging, we can see by a simple 2D T2 sequence, especially in the setting of edema, that tracks are highlighted for us. We know exactly where the corticospinal tract and internal capsule are, even to allow us to better plan whether we come from lateral, medial, superior, inferior, or whatnot. And that this ability to see more with images in this day and age applies to even more complex tumors, such as this. Once we're used to seeing that little strip of gray around a tumor, you can now appreciate that the strip of gray splits around this tumor in the left posterior thalamus, and that's corroborated by the tracks. Specifically, that if we actually do tractography, we see exactly what we already suspected based on the anatomic structural imaging, which is easily and broadly accessible. And that in this particular tumor is enveloped almost 270 degrees or more by motor fibers, leaving us only 1 window for safe approach and safe resection in a young woman with a pathology that now is curable with ganglioma. More often, we even have a GPS to take us down that road, and that's, of course, the many modalities of image guidance that we have today. Although I personally don't rely on neuronavigation very often for once we get past the craniotomy, but the fact is that it's easily accessible in many places, and if one were to do it, you could even track the instrument to avoid any interruptions of flow. As in this case, you can see wherever my bipolar goes, you could, the nibbled away tumor is visualized on the right-hand side through software programmed by some of my excellent engineering colleagues. But in practicality, I do tend to think that for intraaxial tumors, or at least any mass that you can distinguish on a true T2 sequence from the surrounding brain, you are able to see it on an ultrasound, which is real-time, easy, and fairly free at the moment of surgery. And folks debate about what the right tools, what the right brand, what the right contrast media with an ultrasound is, but I tend to think that rather than the exact machine is how the tool is used in general. And so for me, I tend to prefer the modality of having an internal fiducial, and that's a gel foam. It's brighter than any other blood or tumor that I know of. 2 points form a line, 3 points allow triangulation, and gel foam can be slipped into any arachnoid nerves under a vessel and doesn't move. So you can have an internal fiducial. That solves the problem, which we often hear in posterior fossa surgery, of having the ultrasound probe being too large to touch the surface of the tumor, especially when it's deep, like a ventral brain stem. Because I no longer need the ultrasound to touch my tumor. I just need to see the relative position of my internal fiducial, that tiny little soft gel foam, which can be tucked anywhere relative to the lesion that I'm going for. And so having that real-time map then makes it very easy to unlock where we're going. Even better these days, all of the engineering achievements that we've had allows us to have physiology. So not only do we have structural anatomy, but we have the ability to see in real time both monitoring and mapping how far we are going to get. It's like a cheat sheet for the speedometer before we're caught speeding. But some people would say that they don't believe in monitoring because they are in the middle of the tumor and they know things are fine, but the physiologist says, well, we've just lost motors. What do you do in a moment like that? Do you stop? Do you push on when the patient is in front of you with a craniotomy that's open? I tend to think, and this is our early experience, that much of the so-called artifacts actually fall in canonical patterns. And once we recognize that, it's actually easy to reverse. Specifically, this is one of the most common patterns that we see with so-called brain sag, or the removal of large tumor or cerebral spinal fluid, in that as we remove tumor, we first see SSCPs drop, followed by signals for the motor of the distal hand, and then the arm, and lastly the leg. This is not magic, it's just pure physics, because SSCPs are run every minute or two, while motors are run every 10 to 20 minutes, or at the discretion of the surgeon. The homunculus says that the arm and the hand are lateral, so as the tumor is removed and the brain sags in, your arm signals will go down while the leg is propped up by the falx. So understanding the very simple physics of why these signals can sometimes go awry, it's then even easier to reverse that simply by infusing a little saline into your cavity. This is the key for me of unlocking thalamic surgery, because as soon as we go in intraventricular and lose CSF, the signals will often go down, but allowing us to just refill some saline and reestablish a baseline gives the confidence to push the edge. Furthermore, the ability these days to have not only mapping, such as what we were acquainted of in the surface of the brainstem, but cortical monitoring of almost every motor particle, including the 3rd, 4th, 6th, V3, 7th, 10th, 11th, 12th, really allows unlocking from the bottom of the thalamus, known as the dorsal midbrain, where the 3rd nerve nuclei is, to the bottom of the medulla, because we can both map and monitor in real time without interruption of flow. And lastly, no matter how great the map and the GPS is, the vehicle that delivers us there is all of the beautiful microsurgery that we've heard about in the last hour and in the next few days, as well as the skull-based approach, which Dr. Al-Mufti says is the servant to everything else. It brings us to the horse to the water, per se. So putting that all together, so the ability to safely resect intraaxial tumors in any location, challenging or whatnot, is equivalent to owning a GPS. If you have a GPS, I can go to pick a city, any city, and be able to find my way in foreign territory. And in this case, from the grocery store to my office. So that delight and joy of being able to restore anatomy and preserve and improve function, for me, is why I'm so passionate about tumor surgery. As you can see in this young boy who, when he was first diagnosed with papilledema at 15, he underwent a shunt placement by his local neurosurgeon and was watched for a few years. 4 years later, he developed new enhancement at a second site in the suprasellar area stalk region, and then over the next 6 months had steady progression of this mass, prompting 4 more surgeries at his local facility. That then led to a left pterional approach for biopsy, a right transcortical approach for biopsy, all of which, and even a course of chemotherapy for presumed possible immature teratoma or mixed germ cell tumor, even though they didn't have the pathology evidence to support that. But really, in essence, what led this 19-year-old is completely debilitated. By the time that I met him, he had severe compression of bilateral thalamus that you can barely see, the midbrain, which is completely contorted, and tumor going all the way from below the floor of the 3rd ventricle to the mid-pons. More importantly, the fact is that he now was severely hemiparetic on the left side, weak on the right side, sleeping 20 hours a day from somnolence, can't really look, can't speak, and really no longer able to live a life. For me, this tumor, because of the anatomy that we see, dictates 2 trajectories of dissection, which can be achieved through one particular approach, and that is for me, interhemispheric, posterior interhemispheric precuneus approach. Combining all the tools that we have, this allows us to then be able to remove the tumor with fairly great ease, but the intraoperative scan now shows, although the midbrain reconstituted beautifully, and I removed what I thought was tumor in the aqueduct, but there still remains a nodule with a tiny little sliver that's there. So this is actually the final nodule within the dorsal midbrain proper. And at this point in time, although his alertness was improved, I still wanted to get him back to college and to be able to live a normal life. And so that's then going back for stage 2, allowing us to combine again the ability to map out down to the 3rd nerve, the 6th nerve, the 7th nerve, to the milliamp or the millimeter of the brainstem to really allow us to reconstitute anatomy. I think tumors are as easy as that in often, that we just have to return what was there. In this case, the bilateral thalamus, the midbrain, preservation of the periductal gray, so his 3rd nerve remains working, his colliculus is restored, his memory is still there, and really allowing us to also reconstitute CSF spaces so he no longer needs his shunt. But what, of course, is most important is the fact that even at a month post-op, he can now read and walk with assistive device. At 8 months, he can walk without assistive device. He can move his eyes, and at this point in time has finally returned to his freshman year of college. I think that's the joy of a curable tumor that we can take out with microneurosurgery. But sometimes, just so that I'm not too Pollyanna about it, there is the element of biology, and biology, as well as the innovations in science, does help us. And in a case like this, which was initially sent to me as an optic pathway glioma, except for the fact that his vision was excellent. And the reason why it was viewed as that is because, of course, this T2 signal and the fattening of the bilateral proximal optic nerves as well as the optic chiasm. You can actually really not even tell where the chiasm is. But again, using structural imaging, you can see that the tracks are actually preserved, and the fact is that his function is too good for this to be a very infiltrative tumor. So having that belief that function dictates and supersedes anything else that we believe in, I went in with the attempt of finding a plane and was lucky enough to be able to actually turn out to be a papillary craniopharyngioma. Again, now his optic pathways are completely restored as well as his function. However, despite the fact that I cut his stalk and allowed him to have this, less than 2 years later, he returned with weight loss. And I would say that the story of papillary craniopharyngioma is one of both serendipity and being able to take opportunities to repurpose biology. And specifically, it was actually first observed in a 9-year-old child at Boston Children's Hospital. And it was at the time in 2012 when we had just instituted a Dana-Farber routine molecular profiling for every brain tumor. It was new to us, it was free to all patients, and we wanted to just see what we found. And in this case, the neuropathologist, because it was a child of which papillary craniopharyngioma is quite rare, thought that he had a sample mix-up. He thought that he was a pilocytic astrocytoma and he had mixed up the samples. So he sent it to his wife, who was across town at another institution, to retest the pathology and profiling. And again, she saw a BRAF mutation. And the two of them collectively thought, this is an opportunity. BRAF mutations are well targeted in melanoma and so many other cancers. Can we make this a potential for a disease that has plagued so many? And so in this case, I benefited from that, from the passion of all the oncologists who led the teams to create the trials, all of which now allowed this patient who, despite my best efforts in his resection, came back with a recurrence just at the stalk. So if I went back, it would have just been for this tiny little bit at the stalk, but instead being able to be a BRAF MEK inhibitor through the biology that is learned through serendipity and keeping one's eyes open, he now once again can have perfect function and regained his ability to have a normal life. So in my view, surgery for intraaxial tumors is a gift. It's an opportunity to use every tool that's in front of us to learn from microneurosurgery, engineering, skull base, biology, and by using it all, that's how we can help, of course, our patients. Thank you very much.
Thank you. That's really masterful, wonderful. Do we have a few minutes to ask a few questions, or shall we're right on time, or shall we proceed? Ali, or whatever you guys say.
Time for keynote presentation.
Okay.
If you want to take a question, that's good, and then we'll go from there.
A few minutes to ask. Yeah. Any questions from the audience to any of the speakers? Okay. Can we give him a microphone?
these are beautiful presentation. And rightly so, say the triumph, to show the beautiful work everybody in here is doing. Why every slide has the name of the insurance company? The X Health, MGB Health, Prisma Health. There is not even the name of a university that we learn and teach in it. Whom we're working for these days? Just for a insurance, big insurance company?
I don't have an answer for you. At lunch. Ray, can I ask you, could you comment on the spontaneous spinal CSF leaks and the rise of the use of embolization of the venous and venodural fistulae? I saw Giuseppe Lanzino present, I think, 100 cases from Mayo. And
him and Walid are doing a lot of work on the anatomy of those lymphatic systems, how to get down through the venous system to where the rectal granulation, and essentially it's like they're spontaneous leaks and they're going in there and resolving a lot of these, intracranial hypotension issues using liquid embolics. It's really exciting to see what they're able to do where blood patches are failing. We're starting to find these things, but they deserve a ton of credit. They've been really pioneering all of that stuff to help understand the opportunity of the vascular system on the venous side peripherally to get to the spine. Yeah.
Great. Can you give the microphone to Abed? Abed, may I ask you, give us a sense of availability and of affordability of endovascular treatment in Morocco and the rest of Africa. How different is it from the Western world?
So far, there are 3 or 4 countries in Africa. They are both microsurgery and endovascular treatment. In Morocco, Egypt, and 2 other countries, Algeria, Tunisia also. But the problem there is there are a lot of difficulties to have all devices for endovascular. For example, a device should cost something like 10,000 euro or dollars. Only 20% of the population, for example, in Morocco are insured. So it's very difficult. This is one thing. The second thing that is the expertise in microsurgery in Rabat, for example. Rabat, by the way, is the national reference center for Morocco. So we get almost 90% of the cases. So the expertise, as you can see, more than 40 years and has been developed and is maintained as routine activity. The endovascular is more, I should say, young activity. So the colleagues are training to do their best, but we try to keep the indication between neurosurgeon first and endovascular colleagues, just to discuss every case. So the situation, if you apply, as I show in my slides, what are the best candidates, and clinical and daily clinical practice, you are going for 70% for microsurgery versus 30% with endovascular. So 2 things, there is a consensus with our colleagues to develop this, but regarding this indication, and second, there is some limitation from the cost. So this is the situation in Morocco. I think in the Maghreb should be the same. In sub-Saharan Africa, there is no endovascular. The microsurgery is just starting. Few cases has been reported in Senegal, for example, and of course, South Africa is different. So there is a big need in Africa to develop microsurgery and endovascular surgery.
Thanks a lot. And last question, just actually to Jacques, unless Jacques, you'll address it in your keynote. To me, as a non-endovascular person, it seems to me conceptually, AVMs should be curable in larger percentages endovascularly, we know with the flow concept. Can you address, are European endovascular neurosurgeons better than North American ones? I mean, it's very rare in North America to achieve AVM cure endovascularly, this endovenous access issue. I don't see much of it. I mean, my colleagues are here that can address it. Give us your sense on where we're going, and also, I know you slowed down doing endovascular for unruptured AVMs. You had a wonderful paper a few years ago about your own complication. And I don't know if you're going to talk about this in your keynote or now.
I can.
Okay.
But I can answer very briefly regarding, for example, the treatment of non-ruptured AVM. I refused to participate to Aruba because I knew that my results at that time were worse than the natural history. So I refused. And it was a disaster for the study because at the time I refused, I was doing an average of 200 new brain AVM, not session of treatment per year. So, it was a big input, but with such an amount of patients treated endovascularly, not necessarily completely, but as a first step for another treatment, our complications were higher than the natural history, so I decided not. Today, I keep on doing the same, despite the fact that we have made tremendous progress, but I keep on doing the same. Regarding aneurysm, small aneurysm, I am not prone to treat tiny aneurysm when the patient is asymptomatic and when the aneurysm is discovered incidentally. I will attack a tough topic during my talk. Maybe you won't be happy, but I have to do it.
That's why I thank you very much for this now.
Thank
and
you.
All yours.
Could you turn on my screen? So it's with great pleasure that I want to introduce this icon that's changed generations of people in different specialties to really push the envelope. I've been following him for over 20 years now, and the story started with my mentor who just walked in, Roberto Harros. In training with him and Dr. Morcos, Dr. Harros would tell us stories of different people, and there was this constant guy in his stories, this Jacques Moret from the other side of the world that was constantly battling neurosurgeons and pushing the envelope. And what you saw this morning, this concept of clip versus coil, and this man by himself constantly fighting, constantly arguing, constantly innovating. And for me, this was exciting. As an Afghan, we respect people who know how to battle. and so I went to go and see him. Dr. Harros was very encouraging of learning this discipline, even though he thought it sometimes collided. And this is one of my first cases I guess as a young attending, I think I remember. And these are things that my mentor, Dr. Harros, had 20% complications with. This big basilar aneurysm and these balloon techniques. This is before stents. I learned from him. And then I went to Paris. I cruised the cities, discovered what a beautiful place this is. Little bars, little places, little avenues, and it was amazing. And at the end of these streets, I found a warrior, but more interestingly, I found an artist, a man who creates and innovates and brings new things to life with a magical stroke. And even his symposiums, I was one of a batch of neurosurgeons sitting in a sea of radiologists in his link courses, and this was not just a course; it was an environment. It It was a scene. It was showmanship. It was, just beautiful to be part of this. And even the parties and the gatherings, right? Environments where we can gather. I saw and learned from him. So to me, going there, finding this person, understanding his work, seeing how he does things and collaborating with, was just completely eye-opening. And I thank you for sparking something important in my career. Please.
Okay. It's okay. He knows the way it works. Is it okay now? It works? Okay. Good something, evening, afternoon, morning, in the middle, lunchtime. It's my pleasure to be here, and especially my pleasure to accept the invitation of our friend. We had together a tremendous opportunity to speak freely about life when we were in Colorado with a Charbel. And it was really emotional. So I will try to share this emotion with you. Differently, a little bit more pushy emotion today. So I'm used to start this my lecture with this nice flower, which usually I dedicated to the ladies in the room. It's no more possible because all around you you have woke people, and you have to be careful about what you say. So I cannot dedicate this flower to the ladies, so I decided to use this flower to hide the evolution of Paris. The city of lights, dirt, and homeless. This is basically what's happening in the city. Of course, if you go to the Champs-Élysées, nothing is visible. But if you extend a little bit outside, this is what is visible. And I will try to show you exactly the dirty thing that we do. Dirty means not necessarily bad to look at, but bad to think about why we did it. Okay, so it's going to be the good, the bad, and the ugly. It's a wonderful movie. I love it. And my name is Jacques Moret. I would have preferred to be James Bond, but it's a different song. This is my conflict of interest. The law gives you the obligation to speak about your conflicts of interest and to show them, but the size of the letter is not indicated in the law. So this is the kind of letter I use. Then I give you times to read, so because usually we don't have time to read the conflict of interest. The slide is going so quick, so you don't see anything. Basically, the biggest conflict I have is with the French government, because it gives me so much money every month. This is my major conflict. I am employee of the government, strictly, with a miserable salary, obviously. So the good, the bad, and the ugly. There is a word which is summarizing those three adjectives. My name, I am French. And this is exactly a good summary of what can be the good, the bad, and the ugly. Why? First of all, I can get my salary without doing anything. Nobody check on me. Nobody knows if I go to the hospital. Nobody knows if I work. Nobody knows if I play golf. Nobody knows anything, and nobody asks anything. Second, I cannot be fired. So this is probably the reason why they don't ask me what I am doing, because as I cannot be fired, nobody cares. The beauty is when you chair a department, it's the same for your collaborator. Whatever I say, nobody cares, because they cannot be fired too. So basically, if you don't create a family, you have no way to work. It's interesting. So I do exactly what I want without any restriction except the money. We have love, so money is not too much important. So I decided when I was thinking retiring, so maybe I will have something to do. I will have to fight for my retirement plan and blah, blah, blah. No, I don't even care and fear, because my retirement plan is completely organized by the government. So you ring, you say, I retired, boom, the next day you got your retirement plan, finish, no problem. Isn't it a beautiful country? I heard during this morning that one of the criteria for selecting the technique that we'll be using to treat a patient is money. You know, it costs, you know, a web costs 15,000. We don't have that problem. Everything is free. I can use 5 web for the same patient and nobody cares. So it's a good option for you. If you want to get a treatment with an expensive device, you take a flight ticket, you get in Paris, you ring to the Bicêtre hospital, and you claim that you have a headache, knowing that you have an aneurysm, for example. I decide that this aneurysm is pre-ruptured. Who knows? You know, sometimes you feel fine, and the second later you got a big bleed, and that's it. So I decide this aneurysm is more or less pre-rupturing, because you had a strong headache and blah, blah. So I do the treatment. As a tourist, the treatment is free. As a tourist, the treatment is free. If you come with the idea or an appointment to have a treatment, it's not free for you. But if you come to look at Paris, beautiful it is, you know, with all those guys sleeping in the streets, you know, you can get a treatment for free. My life is pretty good, and I'm sure that a lot of you will be happy to share this life, but it was not so beautiful. Imagine at the beginning when I decided to do this business, this is the kind of obstacle I had in front of me. All what they call the giant, I call them the elephant. You know, they were always there to speak polite, to shit on us. And it was difficult, honestly, but it was so motivating. It was so motivating. One day we'll get the revenge. That's it. It's done. Nevertheless, they were all good friends. But you know, when you speak in front of your friend, everything is clear. When you take your friend and you put it in a group like today, everybody is defending his own way of doing. It's normal, it's human, but we have to accept this. Nevertheless, it was a wonderful period. In addition, I forgot the Emperor Sami. Okay, so let's quit about that. I could have taken this opportunity to show you wonderful cases, at least what I think it's wonderful. Maybe it's a piece of cake for you, but for me it was difficult, and some cases are wonderful. So for example, you know, this guy is 18 years old, He had this huge aneurysm discovered because he had some headache, never blame. And as you can see, it's a little bit tricky to understand. And this is a distal part of the middle cerebral, which is definitely, exiting somewhere from the sac of the aneurysm. So we check everything, try to understand the possibility to access and to reconstruct the parent artery. And finally, we decided to do it from the posterior circulation. This is a close-up view with a 3D reconstruction. So instead of going from the carotid, which is seen and there is a very tight angle, so we went from the vertebral retrogradely to the PCOM, navigated without seeing too much in the middle of the pouches, and then finally we got an exit. So what do you do when you get the exit? When you get the exit, the first thing to do is to exit. You remove the catheter, because if you start deploying a stent at the distal aspect and in the middle of things that you don't understand what's happening, you lose the entry, forget it's finished. So as far as we understood that it was possible to navigate, to get access to the distal part, we started from the proximal part and then we reconstructed the parent artery. This is a reconstruction. 3 flow diverter in a telescopic way, reconstructed. You can see the blood which is stagnating. This is 1 day post. Aneurysm is shrinking a lot compared to what it was. You can see on the corner here. And this is 6 months later. Aneurysm has disappeared. The parent artery has been completely reconstructed. I could show you many of those cases, but this is not what I am going to do. I don't feel good because I don't know who I am. What is my medical specialty? Am I an interventional neuroradiologist, INR, as we usually say, an endovascular neurosurgeon? Certainly not. I cannot access the top, so I decided to stay at my level. Neurointerventionist? I don't know. Is it fair? What does that mean? What means interventional neuroradiology? You intervention on what? Honestly, I don't understand. So it's time to gather together and have one name. One name. So why do we keep on debating neurosurgery versus INR for treatment of aneurysm? I don't understand. I told you this morning, I don't understand. So I'm not going to continue for this topic. Why do we have 2 different disciplines? You completely understood or totally understood that I am against having 2 disciplines. I want 1 discipline. People do from outside, people do this, open the skull, people don't open the skull, but at least 1 discipline speaking in the name of the discipline. Why don't we know yet whether it's beneficial for the patient to treat small asymptomatic aneurysm? Can you imagine that we speak about cost and we put devices in small aneurysm without knowing if it's dangerous for the patient? I don't understand. Why don't we claim that it's not ethical to perform an endovascular treatment if the guy doing the treatment doesn't know how to put an external drainage? We already discussed this morning. I think it's a crucial point. So there is a lot of hypocrisy in the way we work. And we have to admit this hypocrisy. In absence of scientific criteria, a little bit of philosophy, we have to take our decision to the best of our knowledge and belief. Okay. So basically, we have to trust on our own ethic. The problem is ethics. It's a tricky word. Okay, let's try to understand. Do we always take our decision with ethics for the patient, meaning without external pressure? The answer is no. Even in France, where we have no pressure, because, if I don't want to do the patient, I don't do it.
If I want to do it with multiple stents, I do it, no problem. But we have pressure. We have pressure by the environment. The morning, you have pressure by your family. You have a lot of pressure. And in your environment, at least in the United States, you have the pressure of the money. We don't have. You are not the only one. A lot of countries in the world have pressure for the money. It's not for the money of the patient, but it's the money for the doctors. And the patient has to pay. That's a problem. Isn't the treatment of incidental aneurysm by device company? That's the reason why I hide my conflict of interest. Because like everybody in the room, I am under pressure of the company. You cannot imagine, fortunately today, they have almost no right to get inside the hospital for the last 2 years. But before, they were getting in the hospital even without asking the authorization. So when the guy or the lady from the company is in the angio suite, what do you do when you do an aneurysm treatment? You use the device of his company or her company. And sometimes you know that this is not the best. Why do we use all the flow diverter on the market? Every single brand, we use it. I know exactly the ones that are good. I need 2 flow diverters, that's it. All the rest, I don't need it. But I use it. I am, as you, under pressure from the industry. Are we going to continue this way? Yes. Because if I don't do that, I cannot give good food to my son. He's small like that, poor guy. Ethics. What is ethics? This is the science of moral and lifestyle with an essential and specific criteria based human species. Only human species has to deal with ethics. So the moral is what you do with the duty. We have a lot of duty. The problem is if you do it by duty, you do it by duty because of your environment. When you live in Saudi, you don't have the same moral as when you live in the United States or in France. So moral is a concept which belongs to the guy who is saying, this is my moral. Otherwise, it doesn't make any sense. Ethic is what you do with your sentiment. When you do something with your sentiment, it's the same. You know, this poor guy is so nice, I'm going to deal with this vein of gain and aneurysm. It's part of your decision. The sensibility you put in the way you approach the treatment of a patient is important. Can we accept this environment? No, it's not possible. We are human species. That's the reason why I invented this word, acknowledge. Acknowledge is the magnificent contraction of ignorance and knowledge. Very simple, everybody will remember. I'm pretty sure that from now you will remember acknowledge. Basically, it's a social network disease. You have so many bad things, good things, a mixture of... I will not say the word because I know that we are not in France, so I have to be cautious. So it's terrible. It is just terrible. The worst is acknowledge is always mixed with show-offing. And show-offing is completely different than show-off. Show-off is an instant in your life. Show-offing, it lasts. It's a way of doing on a long-term basis. I show off, and at the same time, I speak a lot about things that I acknowledge. I know a little bit, I don't know that much, but the problem is not to know, the problem is to speak. I do that. I did it, and I continue to do. I try to limit myself. It's difficult, but I try.
Everybody does that. We have to show off. We have to be on the stage. We have to say, I am the best. What has to be done with, it has nothing to do with our business. So we are just becoming Instagrammer. I cannot become Instagrammer. I have zero social network. So don't try to send me Instagram or WhatsApp or whatever, or WeChat, zero. You can be worse, which is TikTok. TikTok, TikTok, boom, 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 and everything goes everywhere. Ah, la, 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 what a world. If I had to take a disease to demonstrate what is acknowledged, this is a brain AVM. I love that. When I look at it, the picture is nice and I acknowledge a lot. So supposing we know that this AVM has to be treated. Nobody knows, huh? But supposing we know everything. This is a firm indication, okay. Is endovascular treatment close to cure all the AVM? Ask me this question. Of course, I defend my corporation and I say, of course, yes. Yes, we will treat all the brain AVM. No problem. Absolutely no problem. And I can show you AVM that we can treat. Look at that, bingo. We put a mixture of whatever you want, what you have on the table. And you get this, the patient is cured, and your AVM is gone, and it will not recur because we have been occluding the veins. Okay. But when I answer, yes, we'll do, is it an assumption or an affirmation? Is it a desire or a provocation? Is it an utopia or a dystopia? Is it an opinion or is it the truth? An opinion is something in between the truth. An opinion is an elegant way to say acknowledge. Okay. Is the patient the beneficial for that? I don't know. Sometimes I really don't know. So I do think that I don't know. And this is a big, 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 big problem. We don't have the evidence for many things we think we know. Think about that. We don't have the evidence of many things we think we know. But that we know, ignorance is not useful for anybody. So we're in a big balance. We treat sometimes the pictures as a neuroradiologist. You treat a mass, a structure, when you remove an AVM, but do you really treat the disease? I don't know. So it makes me feeling about we are in a system that we don't control that much. We are under pressure from everywhere, and we don't know how to exit. That's the reason why I am asking you this very fundamental question. What is the difference between a brain AVM and a romance? Of course, you know the difference. Anybody can get into. But how to get out, it's much more tricky. I'm sure that a lot of you have experience on that. Huh? Okay. Me, I have. Huh? I am a strong defender of experience on that. Okay. So let's go back to our acknowledge. Acknowledge is the why. Why do we have post-thromboedema? Why do we have post-thromboedema and hemorrhage? Sometimes we know, sometimes we don't know, sometimes we think we know, but we don't know. Why do we have post-edema and hemorrhage at the same time? Why do we have nothing? This is the worst. This is the good for the patient, but we don't understand why the patient has bled or not, or why this patient has not bled. Do you have opening the skull the same problem as we do? If we were a single entity, we would spend a lot of time all together to understand this. Is there a single difference between open skull and closed skull surgery for treatment of brain AVM. Don't tell me about the breakthrough. Don't tell me about the breakthrough. It doesn't exist for us. So I decided to try to understand what's happening when we occlude both. We occlude the artery, we occlude the vein, and the surrounding. The surrounding is crying, but you don't hear him crying. You know, even if you try to put your ear on the head of the patient, nobody is hearing anything, is listening anything. So I try to understand what's happening. So everybody, each time you get in the operating theater, you remember the vascularization of the deep structure of the brain, which is summarized, no problem. But the problem is elsewhere, somewhere else. I'm pretty sure that every single morning when you brush your teeth, you think about the neuropil and the neuroglia. You are a neurosurgeon. For me, I have an excuse. I am a neuroradiologist. But you should, every morning, think about neuropil and neuroglia. And what about the transmission? What about the volume transmission? Who knows in this room that since 2015 it has been scientifically demonstrated that there is a volume transmission based on the neuroglia? So, when you occlude arteries and veins, you destroyed all the environment and you destroy the regulation and the transmission. We have no way to control. We have no way to know if we destroy too much or not enough. But this is what's happening. This is the paper clearly demonstrating, scientifically speaking, that in the brain, in the place where you are working, you have a wire connection and a Wi-Fi connection. The neuroglia, in addition to the wires of the axon, makes a system which is volume transmission, and this is, for my understanding, potentially the reason why we have those complications, despite the fact that we thought that we did a very good job. We can see a little bit of this deep structure because all this vascularization, where it is in the vascular space. And we have a very simple access on the vascular space in the white matter. Look at that, it's just a vasosity. You see the vascular space. If you look at the book of Georges Salamon, which is an anatomy, all what you see here is the vascular space, where all the exchanges happen. And we destroyed all that. Okay. I speak, but now I am going to show you example. And this is what I call the weird and strange phenomenon. So let's go with me in this ugly travel. I'm sure that in the room everybody is anxious to jump on this AVM and to treat and to open the skull and to remove everything. You agree? Okay, so nobody agree? And that's exactly what's happening with us. Because I didn't understand too much, so I say, as far as I don't understand what I'm going to do, I'm going to play on the floor. So I went with the catheter anywhere, and I push glue in multiple fistulas, slow flow fistulas. And this is the final result. And this is immediately post. There is less flow, but it's not that terrible if you compare to what it was before. And then the patient came back 15 months later, without doing anything, he's cured. 2 minutes, it's too much. I will take 4. Why did it happen with this patient? Who can tell me what happens? We know that
when venous thrombosis occurs, this is one of the ways for the brain AVM to bleed. It thromboses all the veins of the posterior fossa and is perfectly in good condition, despite venous thrombosis. Let's have a look at this. The patient was treated by endovascular way. We went in the middle of the vessel here. We put a catheter here. We blocked the distal. We blocked the entry. It went in the nidus of the aneurysm, as it's explained here. And then we occlude the AVM, the veins, and everything. This is a progression of the cast according to time, and this is at the very end. So you can see that even when everything seems to be completely occluded, you still have part of the malformation. Okay, so this is at the end, and this is the control angiogram. Patient is perfectly fine. Exactly the same location, exactly the same AVM. We did exactly the same. We were occluding the nidus and the vein, refluxing and everything, like in the first one. Look at that, 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 look at that. Occlude the vein, reflux. Suddenly the blood pressure increase. What's happening? Shh. Patient is bleeding. Why? Why did he bleed? Why the first one didn't bleed? I don't know. Of course, we continue. Finally, we succeeded to get the whole thing, but the patient bled. He had a deficit. This is the follow-up. Picture is fine. The patient is completely cured, but he has a deficit. Look at this one. Deplocated in the white matter. We went from the venous side. We occluded the nidus. This is at the end of the procedure, 3:50 in the afternoon, and this is 16:15. Patient bleeds. He's cured. There is nothing else. Okay? The same. We did exactly the same. We went through the vein, same location. We did the same treatment. We occlude the malformation. Patient didn't bleed. Same with this one. From venous approach, patient didn't bleed. Okay? Look at this one. Posterior fossa. You go there. You enter progressively, you do a first session to go slowly, and at the end, the goal was to finish and occluding the veins. This is what we did. This is after, this is before. You don't see that much. This is the CT scan after. This is before and after. There is not that much difference. Veins, everything is fine. This is the CT scan 12 hours later. Why did he bleed? Patient survived. So to finish, I think we have to be very humble. Understanding over the last 30 years, almost zero improvement. Cure rate, tremendous improvement. So we cure more and more brain AVM, but we don't understand more. That's a problem. Definitely, technology has improved. We have detachable tip catheter and everything, so it plays a role. But we have to be fronting, looking face to face, that we do things without knowing part of what we are doing. So be humble, or try to be humble. I try to be. And the more I go, the more humble I am. I feel better now. Thank you.
Thank you for that honest talk. It's a pleasure to listen to you.
Thank you.
Thank you so much for coming all this way. Thank you all. So we'll take a, how long? A 15-minute lunch break? 30-minute lunch, and we'll come back. Thank you.
There's a vendor room at the end of that talk in the corner if we visit them.
Catastrophe, you know, and then the patient died. No, can I connect directly? You should be able to, yeah. Yeah, because my computer don't need that. Yeah. Just in case. Just in case. Excellent. You know, just in case. How do I, to go next?
How do I go forward?
Just left and right.
I'm sorry, so this is to go next?
Yep.
Okay.
And then
Oh, that's right.
that's
Go
go.
up.
Yep.
That's right, okay.
Hey, did we end up getting the other PTZ up?
Oh, yeah. So you guys consider it a PC? That's better than the yeah, PC. Yeah.
Perfect, okay. Good afternoon. Okay. Hello, 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 hello. Well, I hope you guys enjoyed a very accelerated lunch. So we're entering our afternoon stretch. And specifically, the afternoon, as we mentioned, the last session was triumphs, the optimism, the achievements. This is the reflection. Specifically, Diving for Pearls is a session that we constructed based on the belief that in neurosurgery, the dive itself is as costly and as precious as the pearls. And so this session is meant to reflect on our mistakes, learn from our complications, but how we learn and how we learn honestly to set the tone. We have Professor Roberto Heroes.
Thanks, Linda. Can you hear me? Yes, so this is on. So Linda and Ali gave me a kind of a little bit of a crazy topic to talk about and gave me 5 minutes to expose how we learn. So I'm going to teach you how we learn in less than five minutes. So let me see. Are the slides showing? Yes. Okay. So the first, how we learn in many ways, obviously. But how I have learned the most, I have to tell you that I have learned the most from my complications. And from that you can gather that I've had many over the years. And I think that we clearly learn, we clearly enjoy our triumphs, and it's good to enjoy and to have a good time and go home and feel good about it when you have a great case with a great result. But don't advertise your triumphs. Let others do it, and it will be much more effective, and you'll get more credit if others advertise your triumphs, and concentrate on talking about your complications. And I learned from my complications, but it is very important also to learn from the complications of your colleagues. I keep track of Dr. Marcus's complications. He doesn't have very many, but you know, when a world-class surgeon like Dr. Marcus has a complication, I pay attention to it because I say, my God, if that happened to him, I want to make sure it doesn't happen to me. So I know he remembers his complications, but I also remember them as well as I do mine. So it's important to make sure that you pay attention not only to your complications, but also to those of your colleagues. And it's very important to discuss them openly. If you discuss your complications openly, people get to think that, well, he must not have many complications. He's so interested in that one that he had, and he must be a great surgeon when he is so concerned about this one complication that he has. Of course, if you repeat every week, then it becomes an old thing. But it is important to discuss them with your colleagues, and I think that you learn from it and they learn from it. So there are different levels in which I learn, and now I'm talking about surgical complications. After all, we're surgeons. Even Jack is a surgeon, right? An endovascular surgeon, or what do you want us to be called now? So nice to see you, Jack. So it's important to learn about complications at different levels. First, before they occur, and that's very important. I still, when I was active surgically, still thought every night about the case I was going to do the next day. And what I thought about is what could go wrong? What complications could I have on this case? And try to think in your own mind about ways to avoid them. So that's already one way, one level at which you're learning about complications, to foresee what may happen, usually the night before surgery. Then it's important when they occur at surgery. You know, many of us are in academics and we've always worked with residents, and the tendency is to, you know, if the aneurysm ruptured, to think that it was just bad luck, or, you know, the resident bumped your arm when you were dissecting the aneurysm or something. Blame somebody else, blame bad luck. No, it's important at that time to own to your complications and say, damn, that happened. You know why that happened? That happened because I didn't do this, I didn't do that. Or maybe I should have had proximal control of that aneurysm and I didn't. And maybe I was too cocky, just dissecting with a knife too close to the thin area of the neck. And the next time I have to do it just a little differently. So it's important to talk about as they occur. Then it's important to rethink about your whole operation, particularly when you had a complication, as you dictate your operative note. I always paid attention to dictating the operative note. I think that it is important to rehash the operation as you're dictating it. And I remember one time in the service, when I was in the military service in the Vietnam War, I did a vein stripping. And I had you know, you have to cut the greater saphenous vein and leave the stump and tie the stump. And I remember dictating the operative note. And then I double tied, and I said, damn, did I do that? No. And just so I came back and told the patient, you know, every now and then I like to recheck, make sure everything's okay. I'm just going to take you back to the operating room on the local anesthesia and take a look. And sure enough, there was a stump of the greater saphenous vein with the marks of the hemostat that I had not ligated, just waiting for him to get up and die, right? He wrote a letter of commendation to the commander of the base because I was so thorough that I did this routinely. And then it's important to discuss it informally with your colleagues. And you know, Jack and I have had many conversations. Can this happen? How do you think? It's important to openly discuss your complications during Morbidity and Mortality Conference. And Morbidity and Mortality Conference, I think, is one of the most important conferences that there are in our profession. And then it's important to publish your complications when there is an important point to make, otherwise not. But when there is an important point to make and you publish it, and I just wanted to show you very briefly this one case, which is the most rewarding, it's giving me the most pleasure of any article I have written. It's a simple case. It's a young lady that I killed because she had an aneurysm that happened to be under the clinoid. And the point is that this was at the end of the day a case, an afterthought, because it's a very little aneurysm. I hadn't exposed a carotid in the neck, which I usually do for all big paraclinoid aneurysms. And I hadn't noticed that it was an isolated circulation on that side. And worst of all, I had not seen, you can see here where the arrow is on the CT scan, that there was a hole on the anterior clinoid, which I did not see preoperatively. And that hole is where the aneurysm was sitting. And I call this a subclinoid aneurysm. It points laterally away from the optic nerve, so it's not an ophthalmic aneurysm, it points laterally. And the dome is like the dome of a mushroom, which normally berry aneurysms don't, you cannot see it well, don't have that kind of a dome. So the reason that this was the most rewarding article I've ever written is that 4 or 5 people have stopped me over the years in a meeting and said, you know, if I hadn't read that article, I could have killed this patient. Because what happened is as soon as I started drilling, I drilled into the aneurysm that was under the clinoid. Then I had to stuff it with Surgicel until the bleeding stopped. And what happened is I occluded the carotid. The patient had a massive stroke and died. So the best paper I've ever written, I think. Thank you very much.
Thank you so much. Next, we have Dr. Jorge Mura sharing aneurysm treatment, pearls, and bailouts during open approaches.
While my computer starts, I want to say that it's very difficult to talk after Professor More and Professor Eros. And I want to say to you that I always think about his paper, that he just talked now, because now I'm going to talk about the bailouts. And then I always take an example, that paper of Professor Eros. I said to the fellows and the residents that everybody showed the battles that we won, but nobody showed the battles that we lost. And then I always remember his paper because I said to everybody, you know, I'm sorry, but voy a decirlo como lo digo normalmente. I'm sorry, but the guy was so honest. All the other neurosurgeons only show the giant, the bypass, the 3 bypass, 4 bypass, 5 bypass, whatever. And the guy showed when he exploded an aneurysm and killed the patient. He said, now, I killed the patient. And then, for example, I have a list of my dead patients in a skull base. I have a list because everybody asks me how many patients I have operated in a skull base. I said I have 22. 22 only, your experience is nothing. No, I have 22 patients that I kill. That's my experience. That's the things that I think about every day. This is my conflict of interest. I'm sorry, Dr. Al-Mefti. I have only one. I'm almost pure, but I'm not pure. And I always be thankful with Dr. Evandro, Elder Tedeschi, Wen. And the first thing when you think about the aneurysm, you need to be master of clipping. Today we hear a lot about all these troubles that we have and everything. And what happened? You need to clip first. This is my experience, 1,465. And this is the bypass that I did. 175 is nothing. It should be 11,000. And I want to show the 3 cases. I think in 4 minutes I only be able to show you 2. But this first case is a case that was very interesting for me. It's 2011. And this patient, I made a very good pre-planning of the patient. I go for the neck, I prepare for a bypass, progressive visual deficit, everything. Left side, in dominant hemisphere of the patient. But what happened? When I, always something happened. But you need to be afraid when something happens in your surgery. When something happens in your presentation, you can do all over again. I want to show you this. And then what happened? The anesthesiologist put the pressure down, okay? And what happened? The aneurysm thrombosed and thrombosed the MCA. And what I did my first thrombectomy, 2011, before everybody talked today about thrombectomy because we have the endovascular treatment. But I did this in 2011. And why? Not because I'm intelligent, no. Not because I have the experience, of course. I did because I heard Dr. Spetzler in a congress that he showed a case of A1, A2 aneurysm that he did this. And I remember. And that's why for the young guys who are here, it's very important to study, go to meetings and everything. Because we follow people. We don't follow images or MRI, whatever. After that, I clipped the aneurysm. I resect the carotid artery. I made a bypass between the superior thyroidal artery, radial graft to the carotid artery, and the patient did well. Nothing happened. Everything worked. And in 2011, I knew that this never happened. Huh? Never happened this, but it's for something. It's pushing me, somebody from above, to do better. I have 2 minutes. And then I want to show you the second case. The first case was a success. It's published, that case. And then you're going to say Dr. Moore is a liar because he said that he's showing something he lose, but didn't lost. But I want to show you the second case, subarachnoid hemorrhage. Of course, we can argue that this patient can go to endovascular, but you see this huge aneurysm, 75 years old. We don't have in that time available 24/7 endovascular treatment. I go for the operation. I made a very good pre-planning, okay? Very good pre-planning. But we made 3D reconstruction. We see the clips that we are going to use, everything. But what happened? When the resident take out when the team, not the resident, when the team take out the bone, okay, explode the aneurysm. And then I remember Yuja, I said to the anesthesiologist, put adenosine to the patient because I need to go to the neck. You cannot see nothing in the surgery, but I remembered my pre-planning and I knew where I have to put the clip. And I put the temporary clipping and I control everything. I open the lamina terminalis, clip the aneurysm. This is the basilar artery, you can see here. I want to show you the CT. It's terrible. We made a decompressive craniotomy. If I show you, in this case, the angio-CT only, you say, wow, what a good surgeon Dr. Murray is. No, I'm not a good surgeon. The patient died 1 month after the surgery. I can tell you that died for a pneumonia. No, I killed the patient. When I indicate the surgery, we take out the bone flap. Everything was done. This is the only rupture that I have in the last 7 years. It's terrible for me. But this is the reality that we have to deal with. Okay? And give me 30 seconds to show you why microneurosurgery will be very important always because we have this kind of cases. Okay? No endovascular, no clipping, no nothing. You need to do revascularization. You need to do first generation, second generation. I'm going up to third generation only. I don't have fourth generation. Michael knows that. I only go to the third. And then I made a STA MCA and a reconstruction M1, M2. And this patient was cured. Classic is not obsolete. New is not innovation. We can develop new techniques like the MiPlata approach that we cannot talk today. But the most important thing is study, laboratory, anatomy. Of course, I copy this from Ali Krish, the technique. It's the same technique. Endoscopy, we must not be afraid. We need to use endoscopy and technology with microscopy. And the most important thing is our heroes must not be forgotten. Dr. Evandro, Yuja, and always teach. These are my fellows. Without them, I'm nothing. Thank you very much. I'm sorry.
Thank you very much for the always passionate advocacy for aneurysm treatment. And the counterbalance of that, Dr. Kadir Erkman, aneurysm treatment, endovascular pearls, and bailouts.
So I think the only thing that's worse than following Jacques Moret and Professor Harros is preceding Mike Lawton. So I'd like to thank the organizers for the daunting task here. But this is great to be back in Boston. This is actually the room that I graduated residency in was in this exact room. So it's fun to come back to Boston and see my old friends. I do not have any disclosures except to say that clipping an aneurysm is my favorite activity. I'm talking a lot about endovascular because that was the topic given to me, but that is actually my favorite activity that I do. I can't come to Boston and not acknowledge this person who meant so much to me. During my residency, I had the honor and real privilege to train with Dr. Scott for 7 years of my residency. Really, master anatomist, incredible surgeon, the best teacher I think I've been around, and just a really kind-hearted person, and really a big loss to neurosurgery. One of my heroes, as was mentioned earlier. So I'm going to talk about some endovascular complications in the management of aneurysms, and one of the lessons that Dr. Harros gave us is to avoid the complications. That's part of it. I think one part of this is to understand when to use microsurgery and when to use endovascular. There are really good indications. I think Louis Kim gave us a really nice breakdown of his thought of when to use each. But you have to understand the limitations and advantages of each type of treatment, and then understand the nuances of the different technologies and techniques. I kind of think of the complications from endovascular treatment of aneurysms as intraoperative. You can have rupture of the aneurysm as you're working on it, thromboembolic or thrombotic complications, migration of coils or device failure, or delayed. Again, you can have delayed thromboembolic issues or thrombotic complications, in-stent stenoses, or aneurysm recurrence, which is kind of still the bane of the endovascular world. So the first complication I'm going to show is intraoperative aneurysm rupture. This was a ACOM aneurysm, ruptured ACOM aneurysm that we were treating endovascular. The patient also had a contralateral MCA. And we weren't even at the aneurysm yet. We were just kind of getting the guide catheters up, and our first run, we see massive extravasation from the aneurysm neck. And the important thing here is, first we blame the resident, as Professor Harros told us, but is to remain calm. Obviously, it's no different than having an intraop rupture during open aneurysm surgery. The first thing, what do? We let the anesthesiologist know, and then you have to get proximal control. We don't have clips to put, but for in the endovascular world, you can put a balloon at the neck of the aneurysm, temporarily stop the blood flow, and then proceed with the coiling, and then manage the patient with a subarachnoid hemorrhage. This is obviously a case that I added this from Dr. Marcos's talk. I didn't have the ultra latest, super soft, extra soft, frictionless, lubricated, low trade handling here today, gone tomorrow coil. This is a case so this is the same patient. Here's the ACOM aneurysm and post-coiling. As I said, she also had a contralateral MCA aneurysm that we coiled at the same time. She, during her course with significant subarachnoid hemorrhage, developed vasospasm. So she had severe ACA vasospasm as well as some MCA spasm. But as we were doing our spasm treatment, just trying to access this anterior cerebral artery, we noticed that there was thrombus in the middle cerebral artery branch. So here we've occluded the branch while trying to treat the vasospasm from the subarachnoid hemorrhage that we caused from treating her ACOM aneurysm. So this is a kind of a trifecta. In this scenario, we have the tools, right? This is something that we do frequently is remove thrombus from vessels. So we're able to do a mechanical thrombectomy of that M2 branch and then proceed with balloon angioplasty here in the A1 segment and have a nice result from that. So, again, pearls of how to rescue situations after you've caused a complication. One thing that I like to think about is when new technologies come out, we love to adopt new technologies, and sometimes it's not always the best thing. This was a device that I think at one point had a lot of promise and excitement. I think is less so now. The Pulse Rider neck remodeling device. And really the idea here is to prevent coil protrusion from the aneurysm neck. This is a basilar apex aneurysm unruptured that we plan to treat with this. One thing I didn't recognize in hindsight reviewing it is the stenosis in the PCA and the proximal P1 segment. This is the Pulse Rider device deployed, coiling. Thought we had a nice result. Patient did fine immediately post-op, and however 3 hours later had a homonymous hemianopsia. We took her back. That PCA had thrombus in it. It was difficult to fill, and now we have a device in our way. We can't really even access it. The nice thing is we can use the 2B3A inhibitors and infuse that intraarterially, and oftentimes can fix these occlusions. There's another patient. He's a professional guitar player. Noticed he had a bad headache and clumsiness of his hand, and came in with this. He did not have subarachnoid hemorrhage, but we found that he had this hyperdense lesion with adjacent associated stroke. So this is the aneurysm in this PCA. And the first angiogram was just a diagnostic angiogram, and then we brought him back the next day for treatment, loaded him with dual antiplatelet therapy because he didn't have subarachnoid hemorrhage. And now you notice that the branch that was there is missing, and there's even thrombus in that distal PCA where we want to treat this with. Based on that, we thought the best option here was to go ahead and add the antiplatelet therapy, put a stent in there, and then brought him back, and now he has, there's the thrombus. You can see that PCA now has thrombus in it from where the stent goes, and then brought him back to retreat him, and now you can see with the stent in place that artery is nice and enlarged. The thrombus is resolved. We can go ahead and give him a more complete treatment. I'm just going to jump ahead here to one more topic that I want to cover is the treatment of flow diverter complications. So this was a patient, here we go, sorry. I think I was a little aggressive with this. So this was an example of device failure. This is a patient who had an ophthalmic aneurysm that was coiled remotely many years ago, pre-flow diverter age, and the aneurysm had recurred, and she presented to us for evaluation. We thought this was a very good flow diverter case. This is with the flow diverter that was already deployed. You can see there's the device is not open fully through the carotid siphon, both on the AP and the lateral. Oftentimes these you can pass a wire through there and just bump the stent and it opens. In this case that did not happen, and worse yet, now we have stasis of flow within that carotid right where that stenosis is. You can see the stenosis there. You can see the endo leak coming through on this one, and this is a scary picture. So in this scenario, our pearl to manage this was to go ahead and do a balloon angioplasty within the flow diverter. That's doing it once, and then we pull the balloon back more proximal, and you're able to do a second balloon angioplasty within the aneurysm, or within the flow diverter. This is the post-op result. You can see immediate stasis within the aneurysm. The vessel is now back to normal. This is a Dyna CT demonstrating the flow diverting stent is now wide open. Thank you.
Thank you, Dr. Erkman, for giving us so many concrete pearls for the oh crap moment that sometimes is encountered. Our next speaker and next duet of cases are about bypass and the moment of intraoperative and postoperative complications. So thank you, Dr. Michael Lawton. Someone did accuse him that if his book was called 10 aneurysms, we would have given you 10 minutes. But fear not, even if he had 10 aneurysms, we would have still given you 6 minutes.
Okay, well, in 6 minutes, it's a lot of pressure. Well, thank you, Linda, for the invitation, and congrats to Ali and Nirav and Sam. Appreciate the invitation here. All right, can you see my slides? The title there? Can't tell. Okay. Well, what I thought I would do, since time is so short, is just to show two cases, and I think we're diving for pearls here, so I'll try and share with you some of these pearls. This is a case, the first case, and one thing we don't talk about is just the background or the backstory for some of these cases. This was a woman from Israel, and they mailed her films in for review, and I constantly am getting tough cases like this for review, and so this adds to that sort of psychological backdrop when you're dealing with complications, when they travel halfway around the world to come to you and you've made promises that they expect you to deliver on. But this woman, as you can see, had the growth of this basilar tip aneurysm here over a very short interval, and you can see the anatomy, dolichoectatic. You've got the P1s coming out on either side of the aneurysm, and clearly a not reconstructible case with a clip. So I'm just going to play this video. This is the view now intraoperatively. This is a left-sided orbitozygomatic exposure. And the initial dissection is just to get the anatomy. The plan here was to do a flow reversal, a surgical flow reversal with a M2-P2 bypass and then a proximal clip occlusion of the inflow. And so you can see the anatomy nicely laid out. This is the P1 coming out of the sidewall of the aneurysm, and you can see the graft that's going in. This is a radial artery graft, and one of the things that I do just to make my life a little easier is to have the plastic surgeons harvest this for me. And so I think my big mistake on this case was not to thoroughly check that graft and see how the harvest went. But anyway, they passed me a graft that looked fine. Didn't notice anything out of the ordinary. So I finished the bypass here, and I take the clips off. Everything looks good. You can see a pulse in the graft. This is the view now looking at the basilar trunk, and that's my proximal Hunterian clip occlusion. And we go to the icy green, you see there's nothing in the graft. The graft is completely black. And so these are just sort of the next series of steps to kind of bail yourself out. So there's confirmation that there's no flow. You can actually see contrast on either end, so it looks like the anastomoses are fine. First I'm going to take the clips off, see if there's any flow that I can push through with release of the temporary clips, and I can't. So now I've actually made a little transverse arteriotomy here in the radial artery to try and do my thrombectomy. And so I can go in with a dissector, I can go in with a Fogarty catheter, and I'm trying to extract clot. And you can see that I'm able to get a lot of clot out. And I've actually got 3 transverse incisions there. And these are just kind of testing, kind of plumbing the circuit to try and get all the clot out and to ascertain whether the anastomoses are good, and they are. And so I'm really just cleaning the central portion of the graft out here with some heparin flush. And it actually flushes clean. Here's just sewing up those transverse arteriotomies, which give you full access to the lumen and are easier to close than the linear ones. But here again, now we go to the icy green, and despite all of that, you can see the bypass isn't filling, so it re-occluded again. So I have to, this was just to convince myself that it wasn't the icy green and that it wasn't. So I'm going to have to just take down this entire construct. So what you're seeing here is using the stump of the distal anastomosis. I've left a little cuff of the radial artery graft, And so instead of redoing that from scratch, I'm doing an end-to-end reanastomosis of a new segment of radial artery. So this is another piece of the graft, and I'm redoing the whole thing. So this is a different M2 branch, and I'm going to sew that in differentially, or in a different spot. And Jorge mentioned the fourth generation. This is an example of a fourth generation end-to-side anastomosis because I'm sewing interluminally and keeping that graft nice and short. And here, finally, it works. So this is an example of the bailout. I'm just going through the whole process of redoing it. The graft now works. It's what I call a double interposition bypass because I used that initial cuff to help facilitate redoing that deep anastomosis. You can see the flow reversal effect there with the dye. And she did well, actually. She's alive and well back in Israel. This is now 2 years down the road, and you can see angiographically that I was able to bail that one out. Quickly, since I'm down to 2 minutes, I'll show you this one. This is a case that was first coiled. Then there were other aneurysms around that were referred to me for clipping, and her aneurysm recurred. And just to jump through this really quickly, I dissected through all of this scar tissue, got all of these trunks off the aneurysm. You can see the flow inside the sac of the aneurysm there. And what I did here was just to do what I call the picket fence clipping through the, using the tips of the blades to close the sac. And you can see the creation of the picket fence. Bottom line is, there are 3 trunks coming out, and when I looked things over, the 2 outer trunks were fine. This middle trunk was occluded, so I've got to now salvage the middle trunk. And I first tried to do this with the excision reanastomosis, and you can see a fish mouth and an end-to-side reimplantation, but the problem was that the tissue was so unhealthy that failed. And so I'm going to just jump ahead. This is the failed reimplantation. And when that failed, what I had to do then was to take it off of that one branch and swing it over to the other side. This is now a side-to-side reimplantation. This is, again, another fourth-generation technique using different anastomoses for this end-to-side construct. And that worked. So here we are at the end. You've got a reimplantation that's done side-to-side. You can now get all 3 of these vessels perfusing, and you've salvaged a tough situation. So those are the 2 cases I wanted to show you. In the spirit of Jacques Marais and being philosophical, I would say this. The first thing is that when you get into trouble, what I found is that you have to escalate. You have to be willing to escalate from where you thought you would be to another level above. And in both of these cases, it shows having to escalate both your technique and your expectations. And the second thing I would say in that philosophical vein is that, 5,000 aneurysms down the road, you get kind of numb to this business. And when these things happen to me now, I actually get a strange thrill from it because it gives you a chance to actually do things that are more interesting and more creative. And I would say, think of your complications in that light. It's a chance to escalate. It's a chance to pull out these things. I wouldn't have dreamed of doing either of these types of bypasses for these 2 cases, but when you're under the gun and in duress, you have to. And so it's your opportunity to shine. Thank you.
Thank you so much. Beyond the intraoperative bailouts, we now welcome Dr. Miki Fujimura, who's going to share about the perspective of hyperperfusion and potential pitfalls for bypass.
What's this? Okay, can you see the slides? Okay. Thank you for inviting me to this kind of very traditional meeting. I am coming from northern part of Japan, Hokkaido Island. In East Asian, like China and Japan, we have a lot of the bypass cases. And I think the moyamoya disease, bypass for moyamoya disease has the best indication of the flow augmentation bypass. So recently, especially in Asian country, increasing number of moyamoya disease patients are undergoing bypasses. But now today we know that the patient with moyamoya disease has a much higher risk for the cerebral hyperperfusion syndrome after the conventional STA-M4 bypass as compared to the atherosclerotic patient. So the surgical procedure, standard surgical procedure is very simple, STA and M4 anastomosis, in many cases combined with indirect pyrosynostosis, which provides a very favorable cerebral blood flow increase immediately after surgery. But at the same time, this procedure for moyamoya disease has a pitfall because of the characteristic vascular fragility at the recipient artery. The patient with moyamoya disease has a much thinner, much more fragile recipient artery characterized by the medial layer thinness compared to the normal vascular structure. So this could be one of the underlying pathology reason why patients with moyamoya had a much higher postoperative incidences. Besides the vascular fragility, there are a lot of the mechanisms underlying the higher incidence of hyperperfusion in moyamoya disease, as summarized in this slide. I don't have enough time to explain everything, but for instance, the patient with moyamoya has increased pro-inflammatory molecules overexpression at the brain structures or something like that. So I will show the typical cases, several cases of the local hyperperfusion in patients with adult moyamoya disease. Of course, the purpose of the bypass is to increase cerebral blood flow, but everyone can recognize the local too much increased CBF in this case. I think we are convinced this is a very pathological finding for two reasons. The first reason is patient becomes symptomatic one day after the single photon emission finding in the middle. And also if we look at the brain very carefully, here is apparent vasogenic edema, signal intensity changes in accordance with the cerebral hyperperfusion. So if we go back to the intraoperative finding, immediately after surgery, there is a localized hyperemia at this site, which is completely in accordance with anatomical location of the CBF increase. So we attempted mild blood pressure lowering and administration of some agent, and the patient recovered completely discharged without neurologic deficit. But in a much more rare occasion, this kind of deleterious complication can occur. Incidence is less than 1%, but the local cerebral hyperperfusion can result in the delayed intracellular hemorrhage. So we examine how much increase of CBF is pathological. This is our previous question. Now we know that in our consecutive cases, we found that if the local CBF increased more than 180% in the local ROI, patient becomes symptomatic, like a transient aphasia or transient weakness. And if the local CBF increase is over 240 or 50, patient has a potential risk for intracerebral hemorrhage. So I think the quantitative analysis of the cerebral blood flow after this procedure is very critical in patients with adult moyamoya disease. So next point is the management, how we manage or how we prevent cerebral hyperperfusion. 3 points. Number 1, the blood pressure lowering, but not too excessive, of course. The 110 to 130 mercury could be reasonable. And number 2 is a pharmacological agent. Anti-inflammatory antibiotics, minocyclines, or the edaravone is a free radical scavenger available in Japan. So we do this kind of agent for the axis of the hyperperfusion. And the last thing is just a topic, the flow control bypass. So what is a flow control bypass? This is a very preliminary trial of my colleague in China. And okay, sometimes in moyamoya disease, we have to preserve the blood flow of STA if the STA has anastomosis to the brain. So this Dr. San tried end-to-side anastomosis to minimize the sudden increase of CBF by the end-to-side anastomosis. I don't have, I cannot talk very in detail, but what we found was that this kind of flow control side-to-side anastomosis reduced the risk of symptomatic hyperperfusion. This is a very preliminary, but compared to the end-to-side conventional bypass, this procedure may reduce the risk of hyperperfusion. So, final 1 minute, I would talk about prediction. Prediction of hyperperfusion in moyamoya disease is very important. So today we know the risk factors for hyperperfusion in moyamoya. Of course, the most important thing is the patient age. Elderly patient has much more higher risk of hyperperfusion. And the second, onset type is very important. Hemorrhagic onset patient has higher risk for hyperperfusion. And I would finally show one topic. This is a very characteristic genetic variant, single nucleotide polymorphism among the Japanese patient, and more than 70% moyamoya disease patient has this kind of very characteristic variant. But to investigate the useful of this marker as a biomarker, we examined how this genetic variation affect the postoperative cerebral blood flow. And we found that if the patient has this characteristic variant, patient has may show the prolonged or delayed hyperperfusion. Patient has a higher risk for delayed hyperperfusion if the patient has this genetic variant. Similarly, after the bypass surgery, it's not rare to see the flare signal intensity change at the vascular territory supplied by bypass, but we also found that this genetic variant contributes to the more prolonged signal intensity change by flare. So we continue examining the correlation of this genetic variant or the postoperative pathologies. So I would conclude that this is my conclusion. Thank you very much.
We'll take one question at this moment, if anybody has a question.
It's unusual, no microphones. Oh, you got one? I want to ask the speakers that have so thoughtfully given us insights into complications. Thank you for being honest. What do you do intraoperatively to put yourself in the right mind frame to be able to utilize the tools that you know you have, but at that moment when it's bleeding or you've lost something, I have found I get a little worried and I can lose sense of where I should be. Do you have a way to put yourself in the right mind frame and make sure the job gets done? That's about performance is the question. You can answer. Dr. Lawton, can you speak to that? Dr. Mura?
Yeah, I would just say that the best way to get yourself in the right mind frame is to have already been there. So what I do before any case is I imagine the worst thing that could happen, and I think of how I'm going to get out of that. It's a form of self-torture, but if you take a few private moments before you gear up and go in the OR, and you've already thought that through, then when it happens, you're not creating on the spot, you're just going down your checklist, and you can remember your checklist and march your way down to plan B or plan C, but if you have to think of your way through the problem at the time, it's a lot harder.
I want to say something. I try to remember people. I think for example, what you do, what Lawton, I said Lawton, what Lawton do, all the people that I remember, all the meetings that I've been, I told you that because it's very difficult to be original. It's very difficult. And then you need to remember everything. And I want to say something for the young one. The issue never finished with the surgery. Finished when the patient is in the house watching TV. The other day we operated a giant CP angle, and the patient came 7 days after the surgery with a pseudomeningocele, you know. And I said to my fellows, you always relax. Why you relax? I never relax, never. You cannot be relaxed, because if you relax, you start to do stupid things, you know? And then it's very important, but I always try to put faces in everything. I try to see what for example, Michael Lawton do, what Dr. Evandro did. You saw in another surgery what happened, and I try always to put a face, because we're dealing with people, not with images, you know? Thank you.
Thank you for that reminder that we're here to treat the patient more than the disease, and to never celebrate, just be grateful. So for our next talk, Dr. Martin Smirka will help teach us about AVM surgery and embolization.
Thank you, Linda. I would like to thank the organizers for inviting me. I am very happy to be here. Boston is a city where I spent 1 year in 95-96 working as a research fellow in Massachusetts General Hospital under the supervision at that time of Chris Ogilvie. And today's talk is not about complication, it's about, I would say, a real practice, standard practice, how we deal with our AVMs and how endovascular treatment may help us in the treatment of our patients. Unfortunately, we are having some technical problems. There are videos also. Will they come too? Is that? Yeah.
We can take another question while we're working out the computer issues.
So once again, thank to Ali, Linda, and Dr. Patel for the invitation. And now coming to my talk, I have no disclosures. I'm coming from Czech Republic, which is in the center of Europe, as you can see, and I am coming from Brno, Masaryk University, which is the second biggest town in Czech Republic, 500,000 of inhabitants. And there was one of the oldest neurosurgical practices established there. As I said, I spent 1 year in Boston. I like the city and all the atmosphere very much. And now AVMs. The natural course of a ruptured AVM is rather poor. We can see 25% of deaths, 42% permanent morbidity. Also, the rupture rate was calculated to 2 to 3%, also concerning not only the ruptured but also the unruptured aneurysms, malformations. So what possible treatment strategies we have? We have a strategy of complete removal, which can be provided only by surgery, complete obliteration, which can be achieved by embolization or radiation, or partial obliteration using embolization. Should we operate at all? We have some evidence that we can operate quite effectively small AVMs or lower grade AVMs, 1 and 2 according to Spetzler-Martin, or some 3, grade 3. Aruba trial questioned somehow if we should operate the unruptured or touch at all the unruptured AVMs, but most neurosurgeons don't like this study much. On the other hand, we have some evidence that even surgery of unruptured AVMs with seizures is effective. Should we embolize? Embolization with the primary intent to cure seems to be not working, as was shown by several meta-analyses, but what works is a partial targeted embolization or even transvenous embolization, which is used last 10 years. How we choose the treatment modality, of course, there is many variables how we choose the treatment modality, but what is important regarding the use and help of embolization is also the flow through AVM, the AVM-related aneurysms, or the angioarchitecture. If we decide for surgery, there are some practical rules which we should follow, which really keep the risk lower. And these are among more. These two are very important. Take the feeders first and take the outflow the latest. Couple of examples: young male with epilepsy, this parasagittal AVM, mostly fed from anterior cerebral artery. Unfortunately, I cannot move this video forward. That's bad, because I wanted to show. But what I want to show is what we do first. Of course, we first start with the biggest feeding branch, which is here. And if we clip this with a temporary clip in the beginning, this makes the operation much easier. And then we go around and then finally take the outflow. This is after operation. Another example, this is Sylvian Fisher and AVM on the right side. We can see the nidus here, but of course we have to distinguish the en passage vessels from the feeding vessel. We can use the ICG, and of course the anatomy is important. So we found finally the biggest feeding branch, and then we can safely go around and take the AVM back. And another example, this was a posterior fossa AVM, which was fed from the supracerebral arteries. In this case, it were 2 arteries. This is a supracerebral approach. We can see there are 2 supracerebral arteries. We can see also the trochlear nerve and the Peters vein, which was actually finally recognized as the draining vein of the malformation. And it was a sister of our director of the hospital, so it was rather difficult, but it was everything was done. So what can we do to how we can use the embolization? We can use it to eradicate the AVM, and the total, we said the total obliteration is rare, but we can use the targeted partial embolization to decrease the size before surgery or radiation. Or we can use it for obliteration of deep feeders, what we do sometimes. Or in high-grade AVMs, we can decrease the bleeding rate by embolization of a weak spot, bleeding like intranidal aneurysm of venous ectasia, or partial embolization to decrease flow. So these are the example how the embolization of the deep feeder here, which make the operation much easier. Another example of the same approach, very frequently it is the posterior cerebral artery, which we can close this way, or we can close the coil the aneurysm on the flow-related one, and after that we can take out the AVM. Another strategy, this is after operation. Another strategy was bleeding this flow-related, flow-related pica aneurysm, which was coiled, and then this very sparse nidus was radiated, and after 8 years we can see that there is no nidus in the cerebellum at all. And this is last case from our last series this year. This patient, young lady, had several bleedings into the ventricles, always recovered, was ambulatory self-caring at home. Finally, we offered her embolization, transvenous embolization of this venous pouch here. We can see it through the rectal sinus. And then now she is fine back home with shunt implanted, and she was fine. This is our series of 60 AVMs. In 7 cases, we used the help of embolization. I would say the results are fairly good. So finally, we consider always surgery first. We have in the high-grade bleeding AVMs, we consider also help of embolization of the weak points, radiation only for unruptured, not suited for surgery or embolization, or in combination after partial embolization or surgery. And finally, I would like to say that the guys who are dealing with embolization, whatever they call themselves, interventional radiologists or whatever, they are quite confident to do the aneurysms, but not the AVMs. And there are actually only 2 or 3 of them who can take care for AVMs or help us with AVMs in the whole Czech Republic. And therefore, we cooperate with them quite a lot. Either they come to our department or we send the patients to them. And most of the examples I have shown you are such. Thank you very much.
Thank you very much, Dr. Smirka. Next, we have Dr. Robert Rengenhart speaking about stroke thrombectomy.
All right, so first of all, I'd like to say it's very obvious I don't have enough gray hair to be on this very prestigious panel, but I'm very grateful for the opportunity to talk, and it's an honor to fill in for my mentor, Aman Patel, who sends his regrets that he wasn't able to make it this afternoon. So my name's Rob Regenhart. I'm an interventionalist, junior faculty at Mass General, and I was asked to talk a little bit about some thrombectomy pearls. So I tried to think about some of the stroke cases I've been involved in over the last few years that have been kind of, particularly painful. So the first case is an 83-year-old lady with a history of a right cavernous ICA aneurysm, hypertension, hyperlipidemia, chronic kidney disease, who came into the ED after being found down. She lives alone, but is independent at her baseline. Her neighbors called EMS for a wellness check when they hadn't seen her for a while, and so the last known well was unclear. She was not following any commands. She was mute with decorticate posturing, and it was found to have an NIH stroke scale score of 30, and a CTA showed a basilar occlusion. So the question is, what would you do? This is her CT, which did show some established hypodensity in the bilateral thalamus and the right midbrain, and a little bit in the pons as well. Given the last known well was unknown, and also there's also some PCA infarct there, and given that the last known well was unknown, a decision was made in this situation to pursue an MRI to determine if any intervention would be futile. And the MRI essentially confirmed what the CAT scan showed. So obviously not a straightforward decision, but ultimately, after a multidisciplinary discussion, a decision was made to pursue treatment to kind of give her a shot, given she had an independent baseline. So initially, femoral access was achieved, and although it's not entirely obvious in that image on the screen, her left subclavian and left vertebral artery were particularly tortuous, and it was quite challenging to catheterize the left vert, and the left vert was dominant. She didn't have much of a right vert. So in this situation, what would you do? And so we decided to obtain left radial access. However, unfortunately, she had this radial loop, which posed an additional challenge. Knowing how difficult it was to go through the femoral route and the challenges that we encountered trying to get into the left vert that way, we decided to navigate that loop. And after that was achieved, we were able to successfully get into the left vertebral artery, and we confirmed that there was still an occlusion at the vertebrobasilar junction. Typically, our group takes an aspiration first approach. However, it wasn't possible to advance an aspiration catheter over the microcatheter given all of the tortuosity. And so in this situation, we'll often use the grappling technique. So it was possible to get past the occlusion with the microcatheter and then deploy a stent retriever. And then once the stent retriever was deployed, it can serve as an anchor to help advance the aspiration catheter up to the proximal side of the clot. And then using the combined approach with aspiration on, we were able to complete a pass. Unfortunately, there was some residual stenosis after that first pass. And we're often in this situation when we think a lesion is from atherosclerosis, and we have to make a challenging decision about whether to stent or not. In this situation, the stenosis remained stable after a 10-minute delay, so we had a multidisciplinary discussion with our stroke neurology colleagues, and ultimately decided not to stent given the extent of the infarct burden, particularly that left PCA, and we decided to manage medically. Unfortunately, her exam remained poor. It may have been due to the established infarct already, and a family meeting was held the following day, and she was transitioned to comfort care. So, certainly not one of our greatest cases, but there were some lessons to be learned. The first is, don't forget about radial access in stroke. I think there's a lot of options if you can't get there from a femoral approach, and some centers will have a lower threshold to do direct carotid sticks as well. But for us, radial tends to be a good bailout approach if it's just challenging from a femoral access standpoint. And again, it's possible to navigate a radial loop and straighten a loop. Typically, it's advisable to try that with a microcatheter first and then advance your guide catheter over a microcatheter. In this case, it was eventually achieved with a 035 Terumo, but there are different strategies there, but it's something that's definitely possible. If you're an aspiration first person, don't forget that if you can't get your aspiration catheter there, the grappling technique is always an option with a stent retriever. And then finally, always consider the risks versus benefits of rescue stenting. The next case, and full disclosure, this was one that I was involved in when I was a fellow. I was trying to think of this particular complication, which is one of the most feared, and thankfully I haven't been involved in too many of these cases. But this gentleman is a 60-year-old with neurofibromatosis. He has a right temporal AVM that was resected 5 years prior to presentation. He initially presented to an outside hospital with an NIH stroke scale score of 6, where he was found to have a basilar occlusion. He was transferred to our center. However, he improved over that transfer with a repeat NIH stroke scale score of only 2. Therefore, he was admitted to the ICU and treated with IV heparin. He seemed to be doing fine. However, 48 hours later, he experienced progression to an NIH stroke scale score of 8 with worsening right-sided weakness, and that weakness was determined to be disabling. So certainly this gentleman wouldn't fit into any clinical trial. There's not a clear trial to guide us. So the question is, what would you do in that situation? A CT head was obtained, of course, which did not reveal any intracerebral hemorrhage, and there was no obvious infarct. So the next question is, would you get advanced imaging? We're 48 hours out, but the weakness, the progression, had just happened minutes before the CT, so we decided to proceed with thrombectomy. Initial angiography from the right vert is shown on the left side of the screen and confirmed a basilar occlusion. One pass of aspiration was performed without any progress, unfortunately. So what would you do next? Of course, you would try another approach. We tried a stent retriever approach. And the lesion posed a particular challenge in terms of crossing. It wasn't possible to advance a wire through it, so a loop was formed, and the loop was attempted to gently be advanced through the lesion. And during that, the lesion was crossed, but the loop widened, perhaps a bit more than expected, which raised our concern. Gentle puffing was performed through the microcatheter, which unfortunately did show contrast extravasation. A gentle run was performed, which confirmed this. So what would you do next? One of the most important things is not to pull the microcatheter back, since the microcatheter could be plugging a hole, and to begin coiling from that position. We also asked our anesthesia colleagues to reverse the heparin. This was a gentleman who the ICU had on heparin before we went to the procedure. We wouldn't routinely do heparin, of course, for a stroke thrombectomy. Post-coil 1 angiography showed that there was some reduced but continued contrast extravasation. And by the time the third coil was placed, there was cessation of any contrast extravasation. We performed angiography of the right and left common carotid arteries, which confirmed that this gentleman had very robust bilateral PCOMs, probably how he was doing so well, with this occlusion for so many hours. Post-procedure CT did show that there was some hyperdense material in the subarachnoid space, as shown here, particularly in the left occipital region. Surprisingly, the patient had a stable NIH stroke scale score of 8 despite this. Follow-up CAT scan 3 days later showed full resolution of that hyperdense material, suggesting actually that most of it was contrast, thankfully. And by the time of discharge, which was just a few days later, he was alert, oriented, interactive, just had mild dysarthria, a left cranial nerve 6 palsy, and some relatively mild weakness in the right arm, but otherwise he had full strength throughout. So I think, some people would say you're better to be lucky than good, but we were glad that his outcome was reasonably good despite that. So lessons learned from this case: thrombectomy can be considered later than 24 hours, although you always want to have some pause and think about, why did the patient decline so far out? Always weigh the risks versus benefits of more aggressive attempts to cross a difficult occlusion. Think about how severe the stroke syndrome is and different approaches to cross that lesion. If uncertain, gently puff contrast through the microcatheter to confirm you're beyond the occlusion and also to make sure that you're intravascular before using a stent retriever. I think that was key here. And then also don't withdraw the microcatheter in case the microcatheter is plugging a hole. And then finally, don't give up in this situation. Coil from that location across the presumed hole. And as we saw in this case, sometimes it's not as bad as you think that it could be. Thank you.
Thank you very much. Next, we welcome Dr. Philip Talski to speak on fistulas.
Thank you, Dr. Sultan, Dr. B, to the organizing committee. I really appreciate the invitation and seeing so many friends and colleagues that I've known over the years, teachers. I completely misunderstood the task. I thought we have to show good cases. What we learned, if I had known, I have a lot of bad cases to show too. So these are going to be more good cases and maybe some of the pearls and what we've learned from them. These are my disclosures. So I'll be talking really shortly about fistulas. And fistulas are really interesting lesions to me from a pathological perspective. And in Utah, we saw a lot of dural arteriovenous fistulas. We never really knew why that is. We thought that the high altitude and dehydration, maybe venous clot, and so on played a big role. but they're really so distinct from other vascular lesions, especially the AVMs, not only in how they present and how they're being treated, but also in the overall goal of how they're being approached and their overall pathophysiology. And we have the Borden classification, we have the Conyard classification. We like to think of it more as benign versus malignant, because these are very difficult classifications, frankly, and I'm not sure they're biologically relevant. We consider anything malignant that either has cortical reflux or a significant change in the venous outflow. And of course, here are what some of these dural arteriovenous fistulas look like. And the management of the dural arteriovenous fistulas have really changed over the years. When I started my fellowship at Mayo Clinic in Rochester, there were still a lot of scrub techs there in the OR that worked with Thor Sund, and they said Thor Sund was really cool about any kind of case, ruptured basal tape aneurysms, whatever it was. He was only nervous about torcular fistulas, and he would apparently drip from his bald head, like mine, onto the surgical field when he had to deal with them. So microsurgery, especially I think for torcular dural arteriovenous fistulas, are not so common anymore. Dr. Harris was a visiting honored guest at the Landy meeting, and he spoke about treatment of dural arteriovenous fistulas in the anterior fossa treated with microsurgery. So I think there's still a role for microsurgery in some or many of these lesions, but I think the mainstay in many shops nowadays is an embolization from an endovascular perspective. And I just want to show a couple of cases that I thought were interesting from a presentation perspective, from a phenomenological perspective. So this was a 76-year-old gentleman who was in the ICU intubated, and he was diagnosed basically with a burned out Parkinson's. He was comatose, he was intubated, and they just thought he had burned out Parkinson's. And the neurologist who took care of him was one of these research neurologists who takes call like 3 weeks a year, and so he doesn't carry a lot of water from a clinical perspective. But he came up to me and he said, you know, I think he may have a dural AV fistula that's actually the cause of his symptoms. And we did, I think there's a slide here missing, but we did an angiogram, and he had a very severe dural arteriovenous fistula that was feeding from both sides and caused very significant corticovenous reflux. And we approached one side at a time. It was difficult access. That was before we had all the tools that we have nowadays. But basically we used the septal balloon from the occipital artery and just really blasted the fistula from one side. And then we did the same on the other side. I think nowadays what we would do is we will probably go from both occipital arteries at the same time simultaneously, and we would onyx blast the fistula from both sides at the same time, with me on one side and a fellow on the other side. But the patient made a really remarkable recovery after, this is the final onyx cast, and we were able to extubate him, and he recovered completely. So he did not even have a Parkinson syndrome. It was really just corticovenous reflux and venous congestion that caused all of his prior symptoms, and he completely recovered to the point of no neurological deficits, which was fascinating to all of us. So the diagnosis of Parkinson's disease was really wrong. It was corticovenous reflux from a very significant dural arteriovenous fistula. This is another case that taught me a lot. Is a 51-year-old. She was a nurse practitioner from Montana. She fell off a horse. She had tinnitus. We did an angiogram. She had one of these sort of classical dural arteriovenous fistulas with corticovenous reflux. And you see here the fistula is pointing. We spend a lot of time looking where exactly is that misconnection. And more often than not, even though it may not be the biggest vessel, most of the time we take that posterior branch of the middle meningeal artery, even though there's also internal carotid artery fetus from Bernasconi and Casinari. And so we went through that posterior branch for the middle meningeal artery, and we got a really good onyx cast. And you see how we were there into the vein. And so we stopped, we pulled it out, and then afterwards we realized that there's actually still filling. So what we did is we stopped basically too early, and there was still corticovenous reflux. And so now we went transvenous, and we realized that we just need to push the onyx cast a little more into that venous pouch. And so we went from a transvenous approach and embolized this. And just I want to show on the left side is the initial transarterial, and then afterwards is the transvenous one that completely cured the fistula. But the point is that sometimes you think when you get that onyx into the venous pouch that you're done, that you're cured, but sometimes you may still have venous pouch that's not completely filled by onyx. And so what we do nowadays is that we always onyx a touch more, even when we think we're done or we're cured, just a touch more to really make sure that that fistulous venous pouch is completely occluded. It's problems that you don't have with open surgery and clipping, where you can just clip that venous pouch. And then I want to show this very interesting case from rural Wyoming. This was a 35-year-old handyman in a Motel 6, and he had a hard time with his right hand screwing in light bulbs. And he went to see his PCPs, and rural Wyoming is not really a bastion of, sophisticated medical care, but this was a really clever primary care doc. And he said, maybe this is a vascular problem, and he did a MRA head and neck, and this is what it looked like. Just really a wild MRA. And this is his subclavian run, where you see that right vert just, I don't know if you can play it again, that right vert just really dumping into the vein, that venous plexus around the spinal cord. And then this is the right side, and then the left side looking exactly the same pretty much. And so because all his symptoms were on the right side, we went ahead and we coiled off that right vert, which is probably something I wouldn't be doing anymore. Nowadays, I would spend more time trying to figure out where is that misconnection. But we coiled off that right side, and he recovered completely that right arm length. He could screw the light bulbs in again. But he came back a year later. Now he couldn't use his left hand anymore. And we did an MRI on him. And
-2 minutes.
okay. Basically, he had very severe worsening on that left side. And so we had to treat that left side, but the problem was the right vert was already sacked, so you needed to keep that left vert. And very hard when you do any kind of runs, you don't see the fistulous point. It's basically just the vert dumping into the vein. So we went up with a septal balloon, we inflated it, and then we did microcatheter runs on the floor rest. And then we found a perfect fistulous connection and managed to selectively coil that off. And just to finish off, here is a case with carotid cavernous fistula that we treated in a transvenous way. And in these cases, because when we think about fistulas, it's not only dural AV fistulas, it's also carotid cavernous fistulas. We always like to have some form of landmark in the carotid artery, being a balloon in the carotid artery or a pipeline, just to show us, like here, where is the carotid artery, so when we onyx it or even coil it, that we understand very well where is the carotid artery and where does it end. So some final comments to close this up. I think dural arteriovenous fistula are really exceptionally interesting, but we don't understand it so well, neither the etiology or the presentation, but we also don't understand what causes corticovenous reflux. Sometimes you see exactly the same dural arteriovenous fistula, and they may have corticovenous reflux or not, and that is very poorly understood. The other thing is that these fistulas can really present in very, very unusual symptoms like Parkinson's, coma, brainstem symptoms, hemiparesis, and of course intracranial hemorrhage. And then carotid cavernous fistulas, even though they're typically very straightforward, I think you need to spend a lot of time making sure you really understand the course of the internal carotid artery and lining it out to you as a landmark, either with a pipeline there or a balloon that you can angioplasty, one of these long hyperglide balloons, to make sure that no liquid embolic or coils get into the internal carotid artery. I want to recognize my partners and co-workers, colleagues, Dr. Ogilvie and Dr. Shutran at BI. Thank you very much.
To wrap up the vascular session, Dr. David Linger on carotid disease. I don't want to be accused of bias in that there's a 2-to-1 reflections on pearls of vascular disease. It's just that the more glory, the more reflection.
It's working. So I'm going to editorialize for 2 minutes. Ali asked me if I wanted to give a talk on philosophy or carotid surgery, and I mean, I do carotids, but I mean, what kind of pearls did I have? I wasn't really sure what I was going to say. And so I just needed like a minute just to philosophize, which I'm getting better as I get older. When Jacques' age, I hope I won't talk about anything other than philosophy. So, first of all, it's just great to be back here and to have the group, Nirav, Ali, Wenya, Osama, and the Brigham groups did such a terrific job of getting this group together, and I'm very grateful to be a part of this. I'm one of the, Ali, who invited me in along with Nirav. I never worked with you. I never was your fellow, or worked as your fellow, or you work as my fellow. I'm not exactly sure how this happened or why it happened, but sometimes you meet somebody and they impact you. And I think probably, as I think back to when that started, was when I saw this picture. In coming into the dinner last night, I'm not sure if y'all noticed, but there were photographs in the hallway. And when I was a kid, I think it was when I was a kid, I don't remember when I first saw this photograph of an Afghani woman who, with these blazing blue eyes in Time magazine, for whatever reason, I liked you to photography, and I was really impacted by the photograph. But I'd never had an Afghani friend. And getting to know Ali and his story, the ability to overcome obstacles, to overcome what his family did, in hearing his story, it was very helpful to me when I was overcoming some of my own stuff. So, that being said, that this photograph next to her appeared in this, I saw a few years ago, and it just reminded me of the passage of time. That the picture on the left seems almost like it's almost a meme or a kind of like never changes every time I see it, and yet they found this woman, 25, 30 years later, and here she was. And I look at the two of us as we've aged, and the group around us this is our group that we've grown up with, and there are many people here, Michael, Chandra, amongst others, that I've known for many, many years. And to see all of us grow up together and have these experiences together, I think that the picture connects a lot of dots for me in a new way. And so I do appreciate the opportunity to stand up here and talk a little bit. As I got over my accident, I got into Stoic philosophy. And as you know, if you've heard me talk, I've become very into the principles of Stoicism. And the 4 virtues of Stoicism are courage, justice, temperance, and wisdom. And Ali, you really represent that and all those. And I think as a neurosurgeon, we're required to maintain those. I think hearing Jacques talk, or any of us, Those are the principles of what we do. No matter what we do the right thing for our patients, whether you clip or coil or whatever. If it's in your mind you're doing the right thing, that's all you can do. So if you remember courage, justice, temperance, and wisdom, I think those are the core tenets of what I try to do every day. And I think that that's, to me, is the emblematic of what this conference is trying to accomplish. And I congratulate all of you for reinvigorating this and bringing such a fantastic group together. So that's that. So I'll move on to my disclosures, a little less emotional for me. I know I've been very into exoscopic surgery for quite some time, and I thought rather than a negative pearl, I would go the positive pearl route with carotid surgery. And I think it's reflective of the kind of the way I'm always trying to make myself a little better, try to do things with groups of people. This is our group at Lenox and in the Western region in Manhattan, just a fantastic group of guys. But when you start to think about the history of your career and then any history, it's always other people who have done things, and we incrementally build on other people's work. As far as the exoscope goes, with our microscopes, we're like either Porsche or Audi guys, or either Zeiss or Leica. To change your microscope at this point in your life seems insane, just to go from one company to another. Nevertheless, go into a completely different platform. But when you think about the Brigham back in, this is from 1928, this is Harvey Cushing actually using the first bipolar, or monopolar actually. If you look at around the room, people still struggle with the same problems that we're dealing with today, which is basically visualization, light, and magnification. I mean, that was basically been the same problem for ad infinitum. Well, the microscope was developed to overcome these problems. And the microscope platform itself hasn't really changed all that much. We've gotten better with certain types of software, certain things in the scope. It's become like a big computer. But I'm partial to the Olympus exoscope. I've used all of them. I just found this one to be the best. But I think the exoscopic platform is the future. It's going to allow for a variety of technologies to take off, and it's coming, I assure you. But I just thought I'd just talk about why it's beneficial to me for carotid disease. The microscope itself, Gene Flamm trained me. He was the first neurosurgeon to have a microscope in New York City in the early 80s. For those who study these things, Bob Rand and Pete Ginetta were some of the really original microscope users, and where they were told you're crazy back then too, back in California. But look what it's done and how it's really impacted our field, and almost probably more than any single technology. Now, what's happening now is the balancing and the optics have been essentially the same for the past, really since I finished my residency. What's gotten better are some of these add-ons, the computer aspect to it, recording, the dyes, the physiologic dyes, navigation, obviously, robotics, which is coming, which I'm not sure if it has a real impact, then obviously digitalization, which is on its way. The problem is our ORs look the same, and with the exoscope, this is what the OR looks like. It's a very different environment. It's almost like an IMAX movie every day, and if you look around the room of the team watching the surgery, I think this also creates a unique moment for the surgeon and for the team to experience. If you compare Lenox Hill, when I first brought it to Lenox Hill in 2018, you see the rep with the red hat on the left and back in Lenox, and you see the nurse in the upper right corner of the Brigham writing something down. You see everybody trying to stare and look, but we have a 21st century way of training people and educating people, and for the surgeon to see, that's a remarkable device. And I don't think there's been any one thing that I've used in my career that's been as impactful to making me happy and just enjoying myself, other than CSF, which like one of you guys mentioned earlier. But the exoscope is a great device. I've tried every one. I've tried the Synaptive, I've tried the Escalep scope. I brought them to the OR, put them side by side. But on both the top left and the bottom right are putting both exoscopes in the room at the same time with two exoscope screens just to compare images. As much for me as for the reps, to prove to myself that I'm not crazy when I see, because this is a very subjective thing, the image. And I also used this from BHS. This is a new robotic exoscope that's screenless. I think the future is going to be in screenless exoscopic surgery, goggles. There are some great companies that are coming out, other than Apple, that are having visors that are going to be used with these devices, and I think that's essential to move the field forward, especially with augmented reality. This is just a visor. These are little examples of why the exoscope is better. This is a cranial case, but you can see the angle of my eyes versus the angle of the exoscope. You can take different angles. This is one of the benefits of carotid surgery too, because you're not bending over with your loops, your headlight, looking up the neck. You can look way up high in a high carotid, look up the lumen of the carotid without changing your ergonomic position. Your wrists move a lot better than your neck. And after I had my neck surgery, trust me, if I had not had the exoscope, it would have been a lot harder to come back. So that was a side benefit. So I no longer do that, and I can look this way and this way. This is the other problem for the assistants, the position you put the assistant in. With the exoscope, everybody's neutral. And so you basically have a much better light. It's also LED, so there's no heat, no headlights. I don't use loops anymore, or a microscope. I haven't used the microscope for a number of years. It's better for observation, collaboration, teaching, better field of view. It's square. It fits in your peripheral vision as well, depth of field. When you see the image, it gives you a mindset. The 4K beauty of this image is incredible. I really believe it's the platform of the digital future, and it's an awful lot of fun. There are some nuances with the sight lines and the screen placement, the OR setup. We published our experience with using the exoscope in carotid surgery, our initial experience. I've done about 30 carotids with the exoscope now. This is the room setup for an endarterectomy. You can see where the screen is. This is a right endarterectomy. The surgeon looks just to the left over the head. The exoscope comes across the patient from the contralateral side and extends to just in front of the neck. And then the scrub tech has his own screen off to his own right. This is an actual, this is the way that looks in the OR. And then this is an endarterectomy. I don't use loops anymore. I just start off right with the exoscope. And as you can use loops with the 3D glasses on top if you choose to, but you can do everything with an exoscope that you can do with your eyes. They're basically Superman eyes. I think Bob Carter called them that. Bob was involved with some of the, got this at Mass General about 5 years ago. You can see the quality of the image. It's obviously a 2D image, but it's just a spectacular image compared to what we normally get. And I want to just, before I finish the talk, here you can see the angle, but this is a Walter arm retractor on the mandible for a high carotid. This is a table-mounted retractor. It's a robotic retractor that basically has sort of an Army-Navy attachment and just pulls that extra up without, it's better than a Henley retractor, and it's just a beautiful instrument. If you haven't used it, I find it very valuable for endarts. I purposely undercut this for the purpose of the video, so we always start the endart in the common and take the plaque. And I just want to, what happens is I get to the top, and it just, I'm not quite there, and I can angle the scope up a little bit better. And the angle and the scope of my head are two totally different things. Extend this arterotomy a bit, and just get above that plaque so that I know I'm at the top. And this, normally this requires you bending over with your headlight, you're banging headlights with your assistant or whatever, and that just doesn't happen anymore. And so once you can take the plaque out and look right up. I mean, you guys have seen this stuff before, and then just obviously feather the plaque out in its entirety, and you've got yourself, and you can really look up that lumen, again, with the angle of the scope. You can really see there's the hypoglossal nerve. So, I think that this is worth looking into. For the younger guys out there, I do think that you should absolutely try to use this and get used to it. With AR, this is the number of cases I've done. I've done, all my bypasses with it. I don't use a microscope anymore. All my aneurysms, almost 100 aneurysms, almost 100 bypasses, tumors. It doesn't change anything. It just makes me a better surgeon, a better teacher. As far as the future goes, as far as augmented reality and a lot of the newer concepts of physiologic dyes and physiologic imaging, it's essential you're in a digital platform. The microscopes suffer, they're all on an analog, essentially optical platform. And digital platforms are going to be essential to grow our understanding of brain physiology, data, big data, and also incorporating these new technologies into the OR. And I do think that our OR of the future is going to look more like Lennox in 2018 someday than the Brigham it did in 1928. So thank you very much. Sorry for taking a little longer. I wanted to say at least something and appreciate your giving my chance to give a talk here. Thanks so much.
Thank you for the moment of reflection. As we welcome our next talk, frequently Dr. Morco says that skull base and vascular are inseparable twins. Dr. Al-Mefti says that vascular is the basis of skull base and skull base is the servant of vascular. So we're going to see some of the intersections of that with Dr. Akash Patel and vascular complications during skull base tumor surgery.
All right. I want to thank the meeting organizers, Dr. Sultan, Patel, no relation, and Dr. B for inviting me to speak. It's a tall task. I'm in front of a lot of people here who have been doing this for a lot longer than I have and have been, sort of mentors and inspiration to me, even if from afar. Okay, we've got to stick to the time, otherwise the hummingbird's going to get me. I have no disclosures. And I think, vascular injury during surgery, especially when doing skull-based cases, is probably one of the most significant sources of morbidity during surgery. And I think the best management starts preoperatively with planning and just trying to avoid getting into these situations. But sometimes you do get into those situations. I think approaches with more minimal access, as Jacques said, make the management of these sometimes even more complicated. So a lot of times we see, videos and people showing their surgery, and we see the good things. And a lot of times, here we have a meningioma, and working in the extraaxial cisternal space is working in the cisternal space. There's no substitute for experience, and a lot of times these tumors invest normal vascular structures, like in this case the ACAs, and you want to use the same principles that you would use of just carefully dissecting, making sure you have good visualization, as you heard, and trying to protect the things that are normal. And if you debulk the tumors and allow yourself the ability to mobilize those things, you can visualize everything from multiple angles and try to avoid getting into these situations. And a lot of times these tumors have feeders from the normal vessels that are easy to tear and can get you into trouble. So this is when things go well. Today's the season kickoff, but sometimes we have these come on man moments, and that's what I'm going to try to show today. Sometimes you'll be dissecting a lesion. This is a vascular lesion, but then you have this come on man moment. And I think Nirav asked, what do you do in these times? And there is a little bit of like, man, why did this happen? What do we do? And it's important to realize that we're not just plumbers, although we can borrow a lot of techniques from the plumbers, and that we're dealing with biological systems, so the good and the bad that come with that. And like in this particular case, we didn't do anything actually, and this thing just stopped on its own. We were trying to dissect that artery so we could get a better view of the neck before we went ahead and clipped the aneurysm. But that doesn't always happen. And when you have this type of situation, you feel like it's this, even though it's just a small vessel or something big, and you're trying to figure out how to fix it. This guy's got something that looks like a sunt clip to me, and he's trying to fix this pipe. So some of the techniques you can use besides what you've already heard, bypass and direct repair. One is just bipolaring the sidewall. Here's an example of a patient where we had an anterior skull-based tumor, and a small feeding vessel was avulsed, and so now you've got a hole in the parent artery, and it's kind of spraying out, and it's not going to stop on its own. And so you just want to make sure you can see exactly what you're dealing with, and sometimes you can do a welding job where you just try to bipolar that hole and seal it up while maintaining the patency of the vessel that's injured. And so here we are. I'll just forward through some of this, but you can see, just trying to get a look. You don't have to, there's not a lot of blood you're losing here actually in volume. It's just a matter of finding the spot and getting it. Direct repair is obviously the best, and you want to be able to visualize the injury, and you're going to irrigate and suction, find the problem. You can use temporary clips, as you've seen. Sometimes you can use angled clips to help maintain flow if it's a large enough vessel while you repair it. And sometimes you just tamponade it and remove more tumor so that you can get better visualization and ultimately suture to repair the vessel. So I'll end with just a case here of a 45-year-old woman who presented with a paracellular mass pituitary adenoma, and we were doing this endoscopically, and this is what I mean by more minimal access. And so the come on man moment is going to come here soon, but as we're dissecting laterally, you can see we avulse what we suspect is the inferior hypophyseal artery, and now you've got bleeding. And the first thing you want to do is just try to visualize where that actually is coming from. And so you saw some blood come out. You'll see it there. And so we've got a hole in the carotid, and we try to use bipolar to close it, but that didn't work, as you'll see, and it's very painful to watch these videos. And we're sitting there, and so what are you going to do next? I mean, I think another effective strategy is tamponade, which we'll try, and there's a variety of things you can use. But I'll just kind of go fast forward through some of this, struggling. Oh yeah, so, and you can use, gel foam or Flow Seal and cottonoids or cotton directly, crushed muscle. All of these things are effective in time because, again, this is a biological system, and a lot of times that can help stop things until you do something that's more definitive. So that's what we did in this case, and we just sort of held pressure for a little bit. Time's almost up. All right. So you can tamponade, like I said, with cottonoid gel foam, crushed muscle, and you can buttress that with tissual glue. So we took this patient for an angiogram, and again, in the spirit of this meeting with multimodality treatment, we ended up, you can see the injury here in the vessel. My endovascular colleague ended up putting in a stent, and the patient did okay, went home post-op day 2, but needed to be on aspirin and Plavix. And 6-month follow-up, the patient, vessels healed. So other options, wrapping, clipping, sun clip I mentioned, bypass. All of these are things you can do before just sacrificing the vessel, and I would urge you guys to avoid doing that. So the best treatment is avoidance. Break complex problems down into simpler ones. So when you're just dissecting tumor, use sharp dissection, traction, counter traction, debulk. Mobilize the tumor that's encasing the vessel so that it's just tethered to the vessel so you can best take it off. Sometimes you can split the tumor over the vessel, and watch out for the small tumor feeders. If it happens, take a pause, visualize the injury, and assess the tools you have available to you for your situation, and opt for measures that maintain flow. And of course, lastly, advances in endovascular techniques have increased our options. Okay, thank you.
Thank you very much, Akash. Next, we have the pleasure of Dr. Antonio Aversa from Rio, who is going to share his significant experience on sinonasal cancers.
It's working? Oh, good afternoon. It's a great honor for me to be here, and I'd like to share with you our experience in the paranasal malignancies. First of all, I would like to thank my mentor, Professor Mefti, for all of the teaching, and I was so lucky to have the teaching of Professor Yaja Gilchrist and have such wonderful colleagues in my fellowship as Professor Turi and Professor Arnautovic. And thank you so much, Dr. B and Dr. Patel, for allowing me to be here. So those are the most common malignancies that you see in the paranasal sinus, in the nasal cavity. The best ones in terms of prognosis are the esthesioneuros, and the bad ones are the SNUCs and melanomas, as you know. There are some protocols for treating those patients, but surgery is still a very important part of the treatment. For example, this is a case that's not for surgery. This is a lymphoma, as you know. It's better treated with radiochemotherapy. And this is the case that they sent me yesterday. It just arrived in my institution yesterday. is a young man with a rhabdomyosarcoma. This is also a huge lesion going to the anterior fossa, but this is not also for surgery. This is better treated with chemotherapy and then radiotherapy. Of course, also those very large tumors with bilateral invasion of cavernous sinus, they are not so good for surgery. You cannot do a surgery that is important, that is going to change the prognosis. The best ones are those ones, for example, those low-grade sarcomas that you try to treat this with en-bloc resection, as you see here. And this is the reconstruction that we are used to do. We use a lot of outer table for reconstruction. But I'm going to focus in the anterior fossa invasive tumors in the midline. For example, we are used to do this in the past. This is as we are used to do in the last 25 years. And this is a large stage neuroblastoma. We are used to perform a mid-facial translocation for treating this without a real craniotomy. And then we realized that it's not necessary to do a big craniotomy, and there are many complications when you do this. And then when you go through the frontal and ethmoidal sinus, you can treat even larger lesions in the anterior fossa. So this is we are used to do in the past with the reconstruction. This is very good in terms of prognosis, of oncological prognosis, you see, but we still have the problems of the scars. So we changed our mind and we start to do the subcranial approach about 15 years ago. We have almost the same angles of view or doing this way, and we can treat almost all of the lesions in this area, in the anterior fossa, in the paranasal sinus and nasal cavity. So if you are interested, this is a paper that is just published in the Master Series of Operative Neurosurgery showing this approach. So this is the important anatomy of doing this procedure. So we see the limits of the frontal sinus, and we perform this osteotomy with the saws. And this is a frontal nasal osteotomy that we do. And then we drill the posterior wall of the frontal sinus, and this is enough for treating most of those cases. Then we can have the control of the ethmoidal arteries at the beginning. Then we can take the tumor first from the nasal cavity and from the paranasal sinus with the helping of the endoscope or so. And then we open the dura, and then ligating the superior sagittal sinus, cutting the falx. We can go and dissect the tumor, even larger tumors, without any kind of frontal lobe retraction. This is the biggest difference. So this is the cavity. So we can take the tumor from the anterior fossa of the bone invaded. Then we can have a radical resection in this way of the whole components of the tumor in the nasal cavity. And this is the biggest difference between this kind of approach comparing with endoscopy, because we can have a watertight closure at the end. So it follows the principles of Professor Mefti's COZ approach, and this is the same, but this is for the midline lesions. I think it's the same principle that you can go from below. And it follows also the principles of Doleck's extradural resection of the cristacali. It's very similar of an anterior clinar process. So a few examples. This I did last week, only for showing the resection of the cristacali drilling. You have to learn this in the lab, how you can do this, preserving the olfactory grooves. And then we have the exposure of all the lesion. You unlock the anterior fossa cavity when you do this in the anterior fossa. And then unblock resection. This is the pre and post-op. Just a few examples with video assistance, Stasio-Neuro, smaller ones and bigger ones. This is a case that we do this only for show since the beginning. We can use also the bone scalpel for performing these osteotomies. I'm using this recently. This is much safer and quick to do this approach. It's easier to do than the larger craniotomy. So drilling posterior wall, and then taking extradurally the cristacali, unlocking the anterior fossa, and then open the dura, And with the video assistance, then you can close at the end with the temporal fascia and reinforcing with the pericranial flap. So this is a few examples. Larger ones, you can do the same. Even when you have extension to the nasal bone, you can reconstruct. Those are a few examples, pre and post. Larger tumors, stasioneurals, neuroendocrine carcinomas. You can do, this is adenoid cyst carcinoma that recur 10 years later. Then we can do another approach in the same way with the subcranial approach. Those are my numbers. We don't have time to discuss them, but we have a very low incidence of CSF leak when you do this kind of approach. So, in our opinion, this is our advantage. You can combine the advantages of the endoscope view because you came from below, and you can have all the advantages also of the craniotomies. So, in conclusion, the only prognosis factors that we can change in this kind of pathologies is to get free margins to our patients. Subcranial approach, in our opinion, is the best way to deal with this kind of pathology. You can have a very good exposure of the anterior fossa and the nasal cavity with very low incidence of CSF leak. Extradural resection of the crista galli unlocks the anterior fossa, but of course, multidisciplinary discussion for taking the decisions is very important. So thank you so much, Linda, for allowing me to be here.
Thank you so much, Dr. Aversa. As we move from rostral to caudal, in a sense, we had Dr. Stephen McGill teaching us about pituitary macroadenoma tricks and tips.
Thank you for the invitation, Linda. I really appreciate the chance to come and share a little bit about pituitary with you guys. Can they see? Okay. All right, I have no disclosures, and when I was looking for a picture of a pearl for the first talk, I came across this article in the Smithsonian that says, given the natural rarity and difficulty in obtaining pearls, people began to culture them. Around the beginning of the 20th century, two men in Japan developed a method by inserting seeds into oysters, and they could get then the oyster secretes a nacre around it, which forms the pearl. So any of the pearls that I have come from the mentors who have taught me a lot about pituitary surgery, Sandeep Kunwar at UCSF and Danny Prevadello, who I did fellowship with. And both of them were in turn taught by Dr. Laws and Dr. Wilson, legends in our field. So when I was trying to think about something I could do in a short amount of time, I think about the principles of pituitary surgery, trying to remove all the tumor and preserve gland function. To me, a lot of that begins with planning. So seeing where the gland is, and then also seeing where the posterior lobe is as well. And I thought for the purposes of this talk, I would just focus on establishing and developing the gland interface plane. I try to do extracapsular dissection in every tumor and show that in a few cases. So the first is this giant macroadenoma, a 71-year-old man, vision loss gone in the left eye, getting smaller in the right. Only hypothyroidism. You can see the tumor here, maybe a wisp of posterior gland back here on the edge. The gland probably extends all the way down to there, pushed over to the right. So one of the things I always want to try to do is find the gland early and establish that plane. And sometimes the tumor is like this. You can see early on here, all of a sudden there's a little window, and you can actually see a bit of the gland peeking out here, and the tumor has a beautiful extracapsular plane. So then you can just general principles of pituitary surgery, debulk, and then work underneath. I got the inferior part first, and once I can see posteriorly, then we can develop this plane behind the tumor, working all the way around and never giving up that plane. But as you decompress a big tumor like this, it's common to get a fair amount of cavernous sinus bleeding and oozing that you can't just stop, and flow seal messes everything up. You can't see the tumor. So when you get that, then I've found using cottonoid pledgets, like I'll use here, the patties, to go in and really help define that plane and protect it so you don't lose it as you work around the tumor. Really helps me to make a better dissection. Then seeing the gland behind it, I can preserve the gland and continue to develop that plane with a few additional patties here as we come along the top. The patties also let me give counter traction. So with my suction, if I push on the patty, I hold the gland in place. So as I dissect the tumor away from the gland, the pressures at the gland-tumor interface, not pulling down on the stalk from above, which I think can put you at risk for DI. This is just gentle tension here, but as you get that in, then I can give that counter tension on the tumor, and I can work my way all the way around it, progressively bringing it out. And staying in that plane also helps avoid situations where it's difficult to tell is this gland or tumor. As long as you're in that plane, you know you're going to remove all of the tumor. We can get up behind it here. You see the gland on the back wall there, and then begin to continue to roll this out. Coming along the top, you then can start to see the diaphragma come into view. And again, here, just carefully developing it. You can see the carotid here on the cavernous sinus on the left. And then working all the way across the top. Now the diaphragma has descended a little bit, and we can come all the way around. And then here in the last little bit, just bring out the last little bit of tumor there. I'm going to skip this case in the interest of time. This one, this is the post-op scan. Sorry, you can see here. This is his 3-month post-op MRI. He had no diabetes insipidus or adrenal insufficiency. Went home day 2. I'll skip the second case. This was a growing adenoma, and in this one, it was hemorrhagic, which can make the plane really adherent. Maybe just show the first minute of it here. But as you open up, even though it's really adherent to the dura, the tumor's falling apart, if I go over and find the normal gland, which I know from the preoperative imaging is pushed to the right, once you find the gland, even in a hemorrhagic tumor that's starting to fall apart, you can begin to develop a plane. And you can see this right here, and then that plane starts to open up there. Both of these planes opened a little bit nicer. She did well. But the last case is a smaller macroadenoma, but a functional one. And this is where I think it gets really important. This is a 28-year-old woman, had a lot of weight gain, self-diagnosed herself with Cushing's. I had to show an angiogram. So we have really wonderful colleague Babak Jerome, who does excellent cavernous sinus sampling, confirmed that in the left cavernous sinus there's a huge elevation in the ACTH. You can see the tumor over here on the left side and kind of amorphously going into the left cavernous sinus. So for this plane was a lot more difficult to develop. I begin with sharp dissection trying to get around the functional adenoma, but it doesn't just fall open like the other ones. You can kind of see it there, so I thought, okay, I'll bring a blunt dissector in. And then as I'm trying to do the dissection here, all of a sudden I violate the capsule, which is not what you want to do. And so I define the gland a little bit further, and then it requires more sharp dissection. I cut down low so that the gland function can be preserved, but we can open a bigger window here. And then I can use broader instruments to get around where I violated the capsule, but preserve that and still develop. Then using the micronucleator to really try to tease out that plane. And it took a little while for this one, but eventually I was able to start to find the plane here, work my way around it, and then progressively work my way more posteriorly until we see the back side of the gland here, and then once you can see that back plane, get the gel foam is very good for developing that as well. I think that's an Oldfield technique, as I recall. And then eventually get behind it with the ring when we can see the plane back here against the posterior lobe and remove the tumor. Then we focus on the cavernous sinus part, a little bit for the vascular folks, digging some of the tumor out here. Then sucking the tumor between the carotid artery under my suction there and defining that medial wall of the cavernous sinus. Then going below the tumor here, I can resect that medial cavernous sinus wall carefully and gently up across where the attachments are higher. Then suction out, make sure we have clean back bleeding out of the posterior compartment of the cavernous sinus. And then as Kash pointed out, you always have to worry about the inferior hypophyseal artery. So as I get closer, work along the top of the cavernous sinus wall, but I was looking for it as I went along back. And then once I found the inferior hypophyseal attached to the wall, then I can come in, coagulate that, and cut it safely and avoid complication and remove the wall. You see that come out right here. And then just a DuraGen reconstruction. She did very well. Post-op day 2, the cortisol level dropped to 2.8, suggesting a biochemical cure. And at 3 months, she was off steroids, had normal cortisol levels. Her energy, anxiety were better. She's back teaching. So I think when I think about a couple pearls to close up, just finding the gland first, which comes from knowing where it is on the preoperative imaging, having a plan to go straight for that, sharp dissection as needed to develop that plane, seeing and preserving the plane. Where I've gotten into trouble is when I let it go and then I'm trying to figure out, is this tumor stuck to gland, and you're getting into the gland, not pulling, and traction, counter-traction. So appreciate my team at Northwestern and Linda and the organizers for inviting me to talk a little bit about pituitary surgery.
Thank you so much, not only for the beautiful technical pearls, but also teaching us of the history of pearls. That's one thing I forgot to look up on Google, so thank you. So, next, but certainly not last, we have Dr. George Zenelos from Pittsburgh sharing chordoma resection pitfalls, tips, and bailouts. Earlier today, we heard some of Dr. Sen's insights on the need for and the benefits of aggressive pursuit of chordomas. And so perhaps this is the other half of the coin.
Let's see this. Is it showing okay? Can I see this?
Do not worry, you will still get 15 minutes of coffee break after this. So we still have time for the question. Please.
Can I?
Who can answer? Where can you get a sun clip at this?
It's good.
They're no longer made.
I think it's good.
That's it. The clips are not available. Codman no longer makes the clips. Both the Sunt AVM clips, the Sunt Graph clips, his son there was issues. They don't make the clips anymore. Codman doesn't make enough money selling those clips.
Sorry? Nirav? Here, back. Yeah, the Codman bought the thing, and the endovascular branch of Codman stopped the production of some clips. But there are similar ones made for Peter Lasik. Peter Lasik have a tunnel clip, 3.5 millimeter, but it's similar only because it's not covered like the Sun keys. No, it's just the round thing for a laceration of an artery, but it works. But it's 3.5. It's a little bit. It's only for carotid. It's not for MCA. Peter Lasik.
It looks okay now.
Yeah, yeah. It's Peter Lasik company, a German
looks
company.
Like it's working.
Yeah. You know the problem with the Sun keys? Yes. Peter Lasik. It's a German company. L-clip. Yeah, titanium. Yes. Here in America, they have a distributor. Yeah. And the other thing with the Sun keys, the other problem is stainless steel. You cannot do MRI. The Codman, they don't do in titanium. Yes, it's a titanium clip. Yes. Yeah, but the last ones, and they stop. No, you're welcome.
I know, but like this now.
Well, fantastic. I'm glad one life-saving extra tip shared in that file transfer process.
I did. We've been trying.
Well, while we're working on that, maybe I'll ask the next question. To follow on Nirav's question earlier by psychology, he asked earlier how, oh, never mind, we'll continue onwards. Thank you.
All right, eventually. Well, I'm humbled to be here. I've learned so much from so many of you over the years, so thank you for the invitation to be here and to share some of our experience. So we'll be going over some of pearls and pitfalls and tips and bailouts for chordoma. I have no disclosures. Chordomas are one of those things that are 1 in a million. It's pretty rare. We do tend to see a decent amount of them in Pittsburgh. And the standard of care currently is maximal safe resection followed by radiation. However, this is being debated, as we'll discuss. And it really takes a village to really use it all. To quote Linda, you really need a team of people that can provide all the aspects of care that are needed for these tumors. And really, we can go further by working together. But chordoma, we've heard a number of great talks earlier. It's really a surgical disease, and both Dr. Al-Mefti and Dr. Sen and many others here have shown what we found as well, that the gross total resection really makes a big difference, and that's what we should strive for. One of my research interests has also been to individualize care for chordoma, and it does look that for the majority of the genotypes, the group A and group B tumors that we have, if you're able to resect the entire tumor and you have really a GTR, you can probably forego radiation and without having the morbidity of radiation. So it really reinforces the fact that gross total resection is even more important. And that's the 5% of that tumor is what really many times requires 95% of the work. But at the same time, that's what actually makes 100% of the difference, because it may actually mean that the patient cannot, it doesn't need radiation therapy. And whether that is tumor over the brainstem or a tumor that is extending laterally in the bone, removing the dura, or like as Dr. Al-Mefti mentioned earlier, using more than one approach. It doesn't mean that you have to only do endonasal or only do lateral. Whatever you think the tumor is going to be approached with better, but if there's residual tumor, it is worth, if you feel that it's worth going back and that you're going to get the whole tumor, it is worthwhile doing. These are midline tumors that are in between all the cranial nerves, so a ventral approach makes sense. Following the tumor from its origin tends to preserve the arachnoid planes and all the microvasculature and the macrovasculature. Fortunately, we don't have to split people's faces anymore, and endonasal approaches have really become one of the main workhorses for these tumors, providing really good versatility both in the sagittal and the coronal plane. One of the most common pitfalls is that the part of the tumor is mostly accessible is the midline tumor in between the carotids. These are tumors that are relatively forgiving as the consistency of the tumor, they're soft, they're not bleeding quite a bit. So what happens many times is an attempt where you go in and then you core the very central part of the tumor and leave the two parts of the tumor on each side. But really, that's not what is associated with the best outcomes. There have been a number of improvements over the years, and their surgical modules allow us to get to most places in the ventral skull base. But what that means, to quote Dr. Morcos, is to expose the carotid. Exposure is everything. And many of these modules actually hinge on being able to expose the carotid artery. This is not something magical to do, and it can be very safe with appropriate technique. Most of our fellows are able to do that by the end. But it really is a requirement to be able to get further lateral. Venturing to the cavernous sinus, it has become really routine from an endonasal perspective. It's much more forgiving. You've heard a beautiful talk by Dr. Sen about that earlier. But really understanding the anatomy of the cavernous sinus from an endonasal perspective, all the cranial nerves are on the lateral side, so you don't have to go through cranial nerves to get there. Also, understanding the pituitary ligaments has really allowed us to be much more safe when venturing the cavernous sinus. When you are in the cavernous sinus, it is worthwhile allowing to work a little bit through the bleeding, because these are soft tumors. If you embolize it, this can go further in the venous plexus, and you actually take the tumor further from where it is. So resecting the tumor up to the area where you think all the tumor is out, and then you have nice back bleeding from the cavernous sinus, it's always worthwhile. And once, obviously, the tumor is, you can easily pack the cavernous sinus and be effective. We think of these tumors as being bony tumors, but really the way they expand is in the venous plexus. So chasing these tumors is really chasing the tumors within the plexus itself. So understanding this is critical for removing these tumors. Posterior cliendectomies have really revolutionized the way that we treat these tumors. Most of the tumors with mid or upper clival extension would have involvement of the posterior clinoids. That was a common source for residual tumor and recurrence. The petrous apex has been a limitation in getting laterally there, either with lateralization of the mandibular strata, the lingual process, the far medial approaches, or disconnecting the cartilaginous roof of the eustachian tube from the foramen lacerum has really allowed us to get much further lateral and resect tumors all the way up to the jugular foramen. But one of the new workhorses has been the contralateral transmaxillary approach, which really increases the angle of attack and allows us to work behind the horizontal petrous carotid, which has been a significant limitation. It really changes the angle, so you can work with instruments through that into the petrous apex and again try and strive for a supramaximal resection. The anatomy of the sixth nerve has been a limitation. Dr. Trish showed nicely when you go transcranially so that the petrosal process of the sphenoid bone is a nice null mark where the sixth nerve goes above. So there's a nice endonasal landmark for the sixth nerve. And lastly, reconstruction has been an Achilles heel for these tumors. The nasoseptal flap and using fascia has really been instrumental. Lately, the rhinopharyngeal flap is a vascular option for craniocervical junction tumors that allows a vascular option to counter the radiation therapy that may happen later. Bailout options such as the lateral nasal wall flap, and then extracranial pericranial flaps for patients that have significant radiation in that area. This can be done on one side based on the supratrochlear and supraorbital vessels, and you can use the other side if this fails too. And then some of the going down the ladder, a temporal parietal fascial flap, tunnel through a neomaxillectomy and going into the lower clivus, again, can be useful for patients that had cellular gray of radiation. There's nothing alive in that area in the nose. Seeding, something that we have to pay attention to, and these nasal sleeves have been helpful in decreasing that. I have no conflict of interest personally, but I do like using them, particularly for these tumors. So in conclusion, it does, again, require a village. We should strive for a GTR as long as this is thought to be feasible. Getting comfortable with exposing the carotid is instrumental in getting lateral, and we should be comfortable with many reconstructive bailout options because this is one of the sources of morbidity. Thank you so much again for allowing me to be here. I don't know if there are any questions. Thank you for staying awake.
Thank you for the epic tour of so many pearls condensed together. Are there any keen questions from the audience? Okay. Well, in that case, we'll go to a short coffee break. We'll have a very special session coming back that I think you all will enjoy, 10 minutes. And also at the end of the day at 5 o'clock, since they will kick us out at 5 o'clock, we will gather outside at the stairs for a group photo. So thank you.
Tomorrow.
será por ahora o para mañana.
No, ahorita lo quieren.
No, no, pero eso para mañana también no será.
Me imagino que sí.
Que metamos la mesa así.
Sí.
I don't know if this is good or bad.
This is for me?
It's for you.
Are you softening that?
Trying to.
Cheers. Cheers.
Linda. 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 Linda, can you get everybody in?
The end of the day, it's always difficult.
Sorry, you were just Everything's good. Oh, no. No, I was just asking Linda.
Gotcha.
They didn't share the wine with you? You have to drink water?
No.
I wonder.
No, the one is just for the guys sitting here.
Okay.
You want some water?
Democracy is
it's
democracy.
vodka.
No, it's not. I know better.
Okay. I guess we start the last session. Hopefully it doesn't turn out too too cheesy. But I think it's very important for us. I corner Professor Al-Mefti all the time and ask him about life advice. And I think it's really, really important for a number of us to hear from people that have done it at the top and have gone through the struggles of getting there and so forth. So my first, and this is a forum that's open to the audience. So I'll ask a question and then we can pass it around. And I'll start with Dr. Laws. Dr. Laws, I personally feel sometimes that if I'm not constantly climbing and I'm not constantly doing the next thing, that I'm falling. And that's it. So there's this constant push to figure things out and do so, and sometimes it becomes a little exhausting, to tell you the truth, and fear sets in and things like that. How have you been able to maintain such an amazing career for so many years, always hitting at the top, always remaining relevant, always being impactful? How do you run a marathon like that and just do it at that level?
Well, I have been a neurosurgeon for 60 years, and it's been a great thing to do, and all of you know that, and most of you cherish it as much as I did, I think, and will do so if you haven't already. But maybe I can talk to you about some of the presidential words that I have given at different stages in my life at different places. The first was in New York City, where I was born and raised. And at the Academy of New York, I was asked to give a talk. And the thing I talked about was collegiality. And it just had by that time had come to me that one of the things that kept me going, that was encouraging and was absolutely not a problem. It was something we loved to work with each other, to be totally helpful from one to another, to share our worries and to share our advances, and to work together with people to try together in a teamwork or almost of a family situation. And that's been a really important part of my life, and I wish it were happening more today. I don't see as much of the collegiality among our trainees as we had in a different setting, at different places, different instruments, different visualizations, and so forth. But I see it's not there where the resident a year ahead of you taught you everything and was proud to do it and helped you. And that happens sometimes, but it's not the way it was before. It was expected of us as we were budding neurosurgeons. The second talk that I gave was actually a little bit different. It had to do with tradition. In my early years, I was given a lot of encouragement by looking at the history of neurosurgery, starting back in the early days of the 19th century. And we learned all of this, and we saw all of the things that people did to move surgery of all kinds and medicine in general go together. And to see this occur and to learn about the tradition that's there for you if you want to find out about it. And if you do, you realize that these pioneers, these wonderful people, were able to do something in very difficult primitive conditions and to make huge advances in what we were doing. And the third had to do with mentorship. And it goes back to my understanding of Harvey Cushing and he was at Johns Hopkins and I was at Johns Hopkins, and he came to Boston and I'm at Boston. And he was chastised by his mentor, and he had been cross with one of the nurses, and these days would have been turned in to the government. Right? And Dr. Osler, who was his mentor, Osler, the medical genius, if you will. And Osler sat him down and he said, Harvey, you can't do this. It's not the right way to be. You've got to treat people well and stay out of trouble. And he took that advice, and it made a major difference in his life and his thinking. And don't forget, he wrote a Pulitzer Prize-winning biography of Sir William Osler. And it's a gem to see what Osler had done. So those are things that have kept me going, things that I still love looking up. Some of those old papers, Dr. Dandy's work, and the controversy between Dandy and Cushing, and you get the heart of people who are dedicated to what they do and darn good at doing it and helping each other. And I hope that would rub off on all of our trainees and all of the people we like to treat and be mentors for and end up being so proud of becoming neurosurgeons.
Thank you. Thank you. Just in follow-up to the trainees and the future and so forth. You know, everybody complains about these 80-hour work weeks and this and that, and it's not the same anymore. But I'm wondering if it's on us. You know, the reason I fell in love with neurosurgery is this man. The reason that I was collegial with everybody is because he taught us to take care of one another and die for one another, essentially, and the patients. So is it on us as the teachers? I've been absent for a year, 2 years from my residents. I don't treat them the way he treated me. Is it on us or is it on them?
You mean You don't beat them like I did you?
You scared me many times. The only man that scared me, but you never beat me. You gave me a lot of love and a lot of support. Professor Moret, I described you before as a warrior, as an artist, as a person that fought a lot of battles and created a lot of good. But what really impacted me was a conversation we had where you're no longer this mythical creature, but a real human being. And the stories were about your childhood and your father, and I just want to, and not that you have to recap any of that, but what created this fire in your belly that still goes on and wows people?
Should I say the truth?
Absolutely, always.
You know, when I was a child, I saw the miserable life of my parents. They were a baker. It was a tough job. They were working like crazy without taking care of their child. I was alone in my corner. And the only thing I had to do is to jump with them in their business. So I was always, doing some primary school and then the rest, helping them to try to make them more comfortable. My father was a bulldozer. He had never any obstacle in front of him. He was always going through. And my mother was trying to, accommodate with that. So, they were destroyed by life, honestly. And I decided to help them as much as I can, but to do something different. I didn't know that I will be a doctor, but once I got the age of 14, 15, I decided to become a doctor. And I don't know if you know, but in France we have a system which is a little bit different. You have the regular system, and then you have the university, and then we have what we call the grande école, the big school. It's a big school like the school that all our governor and president are going through. So, for example, Sciences Politiques or Polytechnique or Central, they are all either administration school or engineering school or blah, blah. And for some reason, my father wanted me to go through Polytechnique, which is a very high-level school. So I followed what he was asking me, and I went through this school. So you have 2 years of preparation, so working like crazy. It's just terrible. Working is not that terrible, but I didn't want to do what he was asking me to do. So during the second year, I say, Dad, I don't like what you ask me to do, and I'm not going to continue. So now I will be a doctor, and I will go through the exams to be a doctor. So he was a little bit disappointed, and he said, well, doctor, because for him a doctor was, a family guy, coming and saying hello, and well, what are you? So give you a little bit of thing. It's more a part of the family. So he said, are you going really to do that? I say, yes, I will do that, but probably in a different way. This is the first thing. So I saw my parents really in big trouble, working like crazy, and I decided to do studies and to make something that was useful for me. The second point is, this man is responsible of your vocation. of course, for me, it was a woman. And I had a chance to have one of my master, and she was a wonderful lady. She was a very clever lady, and she always told me when I decided to do so that I had no future in this direction. But she said, if you want to do that, and if this is really what you want to do, I will help you. I am 100% convinced that you will not have any future, but if this is what you want to do, I will help you. And she left me free, and she was always, trying to help me. And honestly, this is what I try to reproduce with the younger generation. If you really want to do that, do it, and I will help you. So, it gave me a lot of strength to do that. It gave me a lot of strength. The third point is probably the system. In France, everything is free of charge. So the only money you need is to buy something to eat. So to buy something to eat, it was not that difficult at that time. I was working at night in a restaurant, and during the night, 3 times per week, I was going to shops in what we call les Halles. Les Halles, it's a place, it's the biggest market in Europe, inside the middle of Paris at that time. Now it's a little bit outside. And I was, going there, buying whatever, fish, food, vegetables for the restaurant I was working at night. And then when I was coming back, I left around 2 a.m., and I was coming back towards 6, taking a shower and going to the university to do my medical study. It gives you such a good sense of life. Honestly, you go to the university during the night. You drink a glass of wine at 2 a.m. with the butchers, full of blood. It's just a wonderful, wonderful period. And then I did a medical study, but it was absolutely boring. I had zero interest in my medical study. The teachers were really not too much engaged. The education was with no color. So I was desperate. And I became interested in what I was doing when, I decided to do the business I wanted to do, which is interventional neuroradiology. At that time, there was really no name like now. But at least, when I decided that this is what I am going to do, it was fun. Perfect. So, nothing was really easy, but it was absolutely fantastic. And honestly, I have 2 kids. The first one is I did not succeed to give him any push like that, because, he had really nothing to do, just to go to, he could go, and he didn't have to work during the night to get the money to live and to eat. And I think this is probably one of the things that I regret. I was too smooth with him. I was too flimsy. I was so happy to see him going well, and I think it's not life. Honestly, I think it's not life. My last kid is too young. I am too old. So the only thing I can do for him for the time being is to give him love, and he gives me love. And this is another tremendous boost for me. When I wake up in the morning, I think I have still 100 years to live with a wonderful project and everything. And so overall, I would say that I believe in life. I believe in the quality of life. I believe that happiness is something that you have to fight to get. It doesn't come like that. And, well, in summary, if I feel somebody more happy than me, I kill him because I want the only one.
Thank you so much. It's really nice to see a part of your real being. I was going to ask a question for my mentor, but I think Linda's question is better than mine. So why don't you come and ask Dr. Harrows?
Thank you, Ali. And thank you for all of you for sharing your experiences. Dr. Heroes, or any of you, I would love to learn about how you come to forgiveness. Specifically, we talk about mistakes, complications. None of us ever forget. We learn technical pearls if we're lucky so to reflect on it. But the anger and the fear, and either at ourselves or at someone else we think caused harm, that lingers a lot longer. How do you grapple with or come to forgiveness at either yourself or others, if that's ever achieved?
Wow, that's quite a question. Forgiveness for the complications that we have, for the hurt that we produce sometimes in our patients, the damage and the sorrows that we produce in our patients, it's hard to forgive ourselves. But we just hope that we can say that we did our best, right? That we tried. And unfortunately, what is difficult is sometimes to realize that we actually did not do our best, that we could have done better. And if you dig into it with an open mind and an open heart, you usually end up finding that in fact you could have done better. And I think that you don't have to wear it in your sleeve. You don't have to talk about it like I like to, like I have done throughout my career, but I'm sure that all of you who are excellent surgeons and have become better surgeons have done so because you have suffered with your complications and you have, on introspection, you have realized that in fact you could have done better. And because you didn't, your patients have suffered. And that's how we learn, that's how we get better. And that's how we also continue to be human. We would lose that humanity if we didn't have that capacity to introspect and realize that almost always we could have done better. And that is almost always not just bad luck. Yeah, sometimes luck, but you know, the best, I say that, and you'll be surprised if you ask me, who is the best neurosurgeon that you have met? And some of you have heard the name, I'm sure, Dr. Bob Ogeman. I think he was the best neurosurgeon that I have met because he was slow, he was boring to watch him operate. It was terrible. I mean, hours of, but I think he was the best neurosurgeon I've ever known because he had the least complications of any neurosurgeon. And the reason he did not have complications as often as I did is that he did everything like if everything that could go wrong would go wrong, and as if he hadn't done it before and didn't take any shortcuts, and you know, his results were just spectacular. And I think that's really what makes a good neurosurgeon, to have good results, to do well for your patients. But you know, I was thinking about it when I didn't know what this was going to be about. I didn't know if you had any questions, or we had to come up with something. But I was thinking about, as I read, in fact, I had forgotten that I was on this panel. As I saw the wine, I said, wouldn't it be nice to be part of this? But then, so here I came for the wine, But I was thinking, what have I learned at this? What's the most important thing that I have learned? And I can tell you the most important thing that I have learned is how lucky I have been. I cannot imagine any man has been as lucky as I have, and much of that luck had to do with my becoming a neurosurgeon. I mean, our career, what we do as neurosurgeons, and I consider you a neurosurgeon too, in many ways, Jack. What you do, it's second to none, and that I had the good luck. It took a number of very lucky steps in my life to get to where I am, but having become a neurosurgeon is something that I have never for a minute regretted. It's just being awfully nice and beautiful, and my only sorry is that I cannot do it again anymore. I would like to start all over again and begin my career again, and I'll take the chances that maybe I won't get to be any good as a neurosurgeon, but I take my chances to start again because it's just been such a great journey. Now, regrets I have. When there's a song that Frank Sinatra's, what is it? I did it my way, and then he said, regrets, I've had some. I had some. Not many, in the case of, but I have had some. And this is an audience of mature neurosurgeons by and large, but some of you are young. There's still some young neurosurgeons, and I'll tell you about a couple of things that I just thought about fleetingly that I would do different, regrets I've had. One of them is not preparing myself for retirement. To us, it comes at different times. To Ed Loss, he's still not retired. He still can operate. I can't anymore. I couldn't possibly do what I used to do when I have somebody around like Jack Marcus, who can do it so much better than I ever could. It would have been very difficult for me to continue to do this. So I stopped doing complicated surgery about 5-6 years ago. And then I realized, okay, so what am I going to do now? I'm ready to retire, but then I don't fish. I don't do, what do you call it? I look around at my colleagues who is happy in retirement. And there are about 4 or 5 things they do. Fly fishing, I don't even know what it is, but I hear that it's something that makes people happy at retirement. The other thing could be golf. Golf would be wonderful, but I never played golf, and I'm too damn competitive to start now and have a handicap of 300 or something. So I can't do that. Sailing, I would love to do, but I don't have a boat, and I've never sailed, and I'll probably sink if I try to go out what else? I've done none of those things. All I've done is neurosurgery, so I haven't been able to retire. I had to continue to work as an administrator, which is something that I'm really very bad at. I really don't do well at all. But I tell you, just because I was a neurosurgeon, they pay me that well for being an administrator, or a chief medical officer, they call it, because I just don't have anything to do other than this. And the second regret I had, and this is it took me a while to realize that, but I have three kids, 3 children. The older ones are 50 or something, 50, 48, and I regret the time I didn't spend with the older 2 kids. And then I say, well, now what could I have done? What could I have cut out of what I did then that took me away from them? And I wouldn't have given up my time operating, my time with the patients, my times learning to prepare myself to be a better surgeon. But I could have given up the whatever I may have written, been involved in maybe 200 papers or so. And I can tell you that out of those 200 papers, it took a long time to write them and so forth. Probably there are 10 or 12 that would have been worth writing. The rest of them were a waste of time. It didn't help anybody, it didn't help me, and took time away that I could have spent going to my older kids' games. And I remember my son, he's now 50, and he played football, and so did I when I was young. And of course, tactless as grandmothers are, my mother, when he started playing football, he told him, "Oh, but you should have seen your father. You never play football like your father. He was MVP in Cuba." And so I had to sit down with him and say, "Look, forget what your grandmother says. Let me tell you something. I was a lineman. I played offense and defense on the line, and I never made a touchdown playing football. Never made a touchdown. And you have the opportunity to make a touchdown because you're an end, you can catch a pass." And sure enough, I get this call on a meeting. I was away on a meeting, and I hear on the telephone, "Dad, the first Harris touchdown," and he had made a touchdown, and I wasn't there of his game to watch it. And that I regret, and I think what I could have cut out of my career that took a long time is the briefcase. The briefcase, and I'll end up with the history of the briefcase. I had one of the best residents I had here at the Mass Siena. There was a fellow called Carl Swan, and when he was getting to be a senior, he was my favorite resident, one of my favorite residents. When he was getting to be a senior, he came to see me apologetically. He said, "Dr. Harris, you're going to be disappointed in me, but I just have to tell you, I'm going to go into private practice. I'm not going to go into academics." I said, "My God, gee, Carl, you've got everything." And I said, what make you do that? And he said, "Oh, it's the briefcase, Dr. Harris, it's the briefcase." I said, "Well, what do you mean about the briefcase, Carl?" And he said, "Well, you know that I admire you, and I've been watching you, and you work long hours, 8:30, 9 o'clock. At the Mass Siena, you leave the hospital at 9:30, and the last thing you do is you go to the office and you pack your briefcase and take your briefcase home." He said, "When I go home, I don't want to take a briefcase. I want to be with my family and my kids. So I don't mind working long hours, but so I spent a little too much time with the briefcase, writing papers that really didn't help anybody. And that I would do differently if I had a chance."
Thank you. Thank you for that advice. I'm in that stage now where guilty feelings of not climbing and not being at every meeting with 3 little kids at home, and how do you balance that? Linda, do we have one question from the audience? I think we have to wrap up in a couple of minutes. Yeah, of course, Professor. Yes.
I have a comment for you. Working like crazy and trying to be always at the top, it doesn't make sense, because the society around you is forcing you to do that, and you should not jump in the trap. Do what you love, and if you're at the top, it's perfect, and probably it's going to be much easier for you to be at the top when you do it without any pressure. So relax. Second point, there is no redemption to work like crazy. Administration of the hospital doesn't care. What cares? Your family, your kids, your friend. You got an heart attack, you died. The hour after your death, administration of the hospital takes somebody else and forget you. And even all those guys here in the room, they will forget you when you die. After 1 week, 2 weeks, because this is life. So work for you and enjoy the people you want to be, comfortable with. Roberto, the last time I saw you, I don't know if you remember, I was unpolite with you. And I regret. And it's a pleasure for me because I didn't meet you since I was unpolite with you. So in front of everybody, I want to apologize.
It was always a pleasure.
Yes, because you are a gentleman, but honestly, I was not unpolite, but I was stupid with Robert Spetzler. I don't know if you were, and I do apologize too. I have many, many situations in my life where, if you look back, I think it's time to say, I apologize. But when you are the one against everybody, you become aggressive, because this is a way to defend yourself. And for Robert Spetzler, who is a good friend of mine, but we had a terrible, I would say, verbal contact together. And to make a long story short, it was in Houston during a course, and the program was done like that, and he was speaking about how dangerous it is to play with, surgically speaking, with the P1 segment of the posterior cerebral territory. And my talk after was how to escape complication with the P1 segment. So finally, what's supposed to be difficult is not that difficult, and I would even say that it's easy. So we had a big battle in front of everybody. And I made a big mistake. I made a big mistake because I was so arrogant at that time. I printed a paper that was done in French. I printed 200 samples of the paper, which was on the perforators of the basilar tip, depending on the embryological division of the basilar territory. It was a wonderful work that we did with one of my colleagues. And I said, everybody, what Robert Spetzler explained, he did it by superstition. What I told you, I did it with knowledge. And that was terrible. And honestly, you should not do that. Even if you have the proof that, something is new in the understanding of the anatomy and the embryology, something that has never been described before, this is not a reason to shit on the people. So Robert Spetzler will probably understand that. I apologize for him too. Thank you.
Thank you. Thank you so much. Thank you for all of your wisdom. Thank you for all of your guidance. You said you don't do this anymore and you can't do this anymore. I remember you once had a hard case and you said, Ali, put your fellows on the wall and every so often look at them. Everything that I do is in your name. Everything that I do. And a number of the influences that I've had in my life have been from special people like you. So even if you don't do it anymore, we all do it for you. We all do what you've always taught us. And we love you immensely, immensely for the contributions and the amazing things that you've done for the field and for us. And thank you so much for being here. For those who I will be seeing later on, dress down. It's going to be hot.